conference yesterday, I feel honored to welcome you all again today for the virtual conference update in Cardiology 2021.
Just a minute. We have to go live.
Recording in progress.
Yeah, we are ready now, madam. We can start in 5, 4, 3, 2, 1. Please start.
Good morning. After a day-long successful conference yesterday, I feel honored to welcome you all again today for this virtual conference update in Cardiology 2021. I'm sure that you will all feel enriched with knowledge after completion of this event and will have a great time ahead. Today's program will begin with an industry-sponsored program, High Bleeding Risk Patients, the Ideal Consensus. And for this, we have our chairperson, Dr. Manutosh Panja, and moderator, Dr. Dhiman Kahali, expert panelists, Dr. D.P. Sinha, Dr. Saroj Mandal, and Dr. Ranjan Kumar Sarma. Welcome you all.
Hi, Anil. How are you? Good morning.
Hi, fine. Thank you. Good morning. How are you doing?
Good morning. Good morning to everybody.
Hello, sir. Hello, Dr. Kahali.
Yeah, good morning.
Start the
Good
program.
morning. Good morning.
Yeah. Good morning.
So, Minal, good morning.
Good morning.
Good morning. So, can we start now?
Yes, please start.
My name is Mani.
Okay.
So, Dr. Kali and Lipika, should we start the meeting now?
Yes, sir. Right now we start.
Yes, it is the right moment, 12 o'clock. So, and good afternoon and good morning at the junction period. We are here. So here this very important meeting for the particularly how we manage the high risk bleeding by the intervention. Dr. Kahali is the moderator, and the panelists, Dr. Saroj Mandal and Ranjan Sharma, Dr. D.P. Sinha, and there is fourth speaker. And today, important session that thing, high bleeding risk, very important issue. you have to know what are the high bleeding risks, particularly any patient more than 75 years age, oral anticoagulant, anemia, transfusion, renal failure, and the particularly plan for surgery, and the stroke for within 1 year, and hospital bleeding, particularly from GI tract or bronchiectasis, and steroid getting patients, and various intracranial hemorrhage, thrombocytopenia, and severe liver disease. Now I requesting Dr. Kahali, is the chairman of NIC and is one of the director of Interventional Cardiology BML Hospital. He is the dynamic interventional cardiologist in Bengal. And please, I request Dr. Kahali to give the interaction in this context of high bleeding. Dr. Kahali, please.
Thank you, sir, for your kind introduction, and good morning to all the panelists. Good morning to all the delegates, chairpersons, and speakers. So I think that it will be a very interesting session. And as Professor Paja has told, that we are really bothered about HBR patients, and recently everything is changing regarding HBR. Just a week back, I was talking with Dr. Shamin Sharma in a meeting, and he was telling me that he has changed his practice of giving prasugrel to the patients, because he's telling that for 1 month or 2 months he's giving the patients 10 milligrams of prasugrel. Then after 2 months he's bringing it down to 5 milligrams, and there is a lot of de-escalation happening. And we are starting with ticagrelor or prasugrel, giving it for 2-3 months till the endothelialization happens, and then we come down to clopidogrel. And some of the most recent trials are showing that clopidogrel is no way non-inferior to ticagrelor or to prasugrel. So we are reverting back, and this is the one front, that is the pharmacology, which is very important. And second is that, and now we don't use GP2B3A blockers like previously we used to use. Of course, we are using cangrelor sometimes, but that too rarely in India because of the cost factor. And other domain is the stent. The stent design has changed considerably. We have seen the Giants 30, Giants 90, and then we have seen the Onyx one, study, and all these have shown that they are very good, and we can stop the DAPT very early. Now it is the town of synergy, and they are telling that this stent is also equally good from Boston Scientific, and so we won't name anything in our deliberations. And I would ask the first speaker to come, and Dr. Minal Das to moderate the session.
I think I'm the first. I'm Dr. Nick Parshure.
Yeah, Nikhil, good
Yeah,
morning.
hi. Good morning, good afternoon, Dr. Kahali.
I should introduce Dr. Nikhil. He is practicing in Apollo, Mumbai. He was in UK for 25 years. Very dynamic cardiologist. And so, Nikhil, you please start. Good friend of mine. Yeah.
Yeah, Nikhil will talk particularly important subject, high bleeding risks. That is his important experience that should be well appreciated by every one of us. Nikhil, please.
Thank you for that kind introduction, Dr. Kahali. And I'm going to talk about, is obvious, we're going to talk about HBR patients. And let me see, it's playing up a little bit. I am not able to, yes, okay, that's fine. So I'm going to talk about HBR patients, their outcome in terms of, can you see, can you hear, and can you see?
Yes.
Yeah, okay. So I'm going to talk about HBR patients, their outcomes, and how precision is required in achieving what we call optimal angioplasty. Let me first correlate mortality to bleeding if it happens after PCI. And if a major bleeding happens, consequently hypertension happens, we have to stop DAPT, patients may require transfusion, resulting in ischemia, stent thrombosis, and ultimately mortality, as is shown by Dr. Bhatt and Dr. Braunwald way back in 2005. So if you look at the outcome data in ACUITY trial, that is the influence of major bleeding and MI in the first 30 days on risk of death over 1 year. So all these patients who bled, that means major bleeding happened to them within 1 month of angioplasty. and what was the correlation to that bleeding to the outcome in terms of mortality. And you can see that there were about more than 13,000 patients enrolled, and the bleeding is correlated with myocardial infarction, which is 2.5 times with, you can see the confidence intervals as well. The major bleeding without or before transfusion was 2 times higher, and major bleeding after transfusion was 3.9 times the risk of death in these patients. So it is very clear about if the patients bleed after angioplasty, the risk of death is 3.9 times higher. The risk of having an MI is 2.5 times higher. So data from the ADAPT-DES study, which is 2 years follow-up, in terms of post-discharge bleeding, increases mortality significantly. And a post-discharge bleeding, again in this particular trial, showed that the risk of death is 3.9 times higher if the patients bleed. So it is very well established now that the post-PCI bleeding is related to extremely high risk of death, which in terms of the data is 3.9 times higher. I have a patient now which I'm going to use as a way to understand the current knowledge about HBR. This is a young man of 36-year-old, complained of chest pain a month ago, which subsided with antacids. He started having chest pain on exertion and chest pain on dialysis with a history of GI bleed 6 months ago. This is the ECG which showed biphasic T-wave inversion in the anterior leads, telling us that he has what we call LED syndrome. He was anemic at 8 grams. His creatinine was high. Of course, he was on hemodialysis. So his coronary angiogram, I don't know why it's not playing. It will play probably in a minute. His coronary angiogram showed that he has blocked LED. And other vessels were normal. So we move on. It's actually moving very slowly now. So this patient we know that has anemia. He's on hemodialysis. He has a history of GI bleed in the past. But if we think about high bleeding risk patients, who are they? Why are they important? And why were they previously ignored? So if we look at this, this was a white paper published in Circulation in July 2019, which defined HBR patients undergoing PCI by Philip Urban and group. So as everybody knows about it, that the age, renal and liver disease, active cancer, anemia, low platelet count, previous stroke, bleeding diathesis, prior bleeding or transfusion, need for oral anticoagulants, continuing NSAID and steroids, and planned surgery are the risk factors for bleeding post-PCI. Some of them are major bleeding risk factors, and some of them are minor risk factors. So you can see that age is a minor risk factors, but need for oral anticoagulation is actually a major risk factor, which is very, very common. So in my patient, we can see that the patient has end-stage renal disease on hemodialysis. He has a history of GI bleed 6 months ago. He's anemic and is planned surgery. So he has both major and minor risk factors, and we must identify them early, which we have. And now we need to use the knowledge how to deal with these patients in terms of minimizing his risk of bleeding post-PCI, and therefore minimizing his risk of death. And he's very young, you have already seen. So bleeding remains one of the most common complications after PCI, with up to 6% of patients experiencing a major bleeding event. And that's very important data to remember, that up to 6% of patients experience of major bleeding events. And why? Because there's an association between bleeding and increased risk of death and MI, as I have shown you in previous slides. Clinically relevant bleeding occurs in up to 6% of patients, and up to 4.8% patients are hospitalized post-PCI. And the most common source of bleeding is GI tract. Of course, you all know about it. Majority of bleeding occurs within 30 days post-discharge, and post-discharge bleeding-related hospitalization after PCI is associated with subsequent death or MI, which you have already seen. Highest risk of death or MI occurs in the first 60 days after bleeding related hospitalization. So how common are HBR patients in routine practice? They are actually extremely common. 40% of the PCI population meet criteria for HBR and are at high risk for bleeding at 1 year. We understand this from Burn PCR register, which treated more than 12,000 patients between 2009 and 2016. And what did they find? 40% were identified as HBR and were older, more commonly female, and had more risk factors and comorbidities. And of course, at 1 year, the HBR patients had increased risk of primary endpoint of BARC3 or 5 bleeding and composite endpoint that included cardiac death, target vessel MI, and target lesion revascularization 12.5% versus 6.1%. So in trials, who were these patients included? Well, the most common HBR factors were age, need for oral anticoagulation, renal failure, anemia, hospital for bleeding, actionable bleed, and thrombocytopenia. So these were the commonest risk factors included in trials for HBR patients. Well, if you look at, there are more than 14 trials now of short DAPT or what we call ultra short DAPT, which is 1 month. And we can clearly see that since Senior is a actually very old trial, which was used with Synergy drug-eluting stent of more than 1,200 elderly patients, in which 1 month versus 6 months of DAPT was used, and so on and so forth, including leaders free. What are the guidelines telling us? Well, it's very simple. If the patient is undergoing PCI and is at high bleeding risk, and if the patient is stable coronary artery disease, then 1 month DAPT is class 2B/C indication, and 3 month DAPT is class 2A/B indication. What about ACS patients? ACS patients, the guidelines are clear that you need to continue. If we have to shorten the duration, you have to shorten to 6 months DAPT with class 2A/B indication. In my patient, I also calculated the precise DAPT score, which was very high at 70. And we know that if the precise DAPT score is more than 25, then that patient has a very high risk of bleeding and death. What about the trials telling us? Because I am trying to gain the knowledge from the trials to apply to my patient and then carry out the PCI according to the knowledge I gained. So Evolve Short DAPT trial, which was actually the first US trial data, was submitted to the FDA to get a high bleeding risk indication, in which more than 2,000 patients were enrolled in more than 110 global sites with high bleeding risk. And the analysis was completed in 15 months. And what do we find? The risk, according to us, if we think that we are going to shorten the DAPT, is stent thrombosis. And it was actually 0.2% stent thrombosis in this patient. So it was extremely low. What about Senior trial? Senior trial was 1,200 elderly patients, randomized 1:1 to Synergy versus Rebel BMS, and 0% stent thrombosis at 1 year, with 0.3% stent thrombosis at 1 year. If we compare this to bare metal stents, then actually it is non-inferior, or in terms of superiority, it's better. Another trial of Synergy is ASSET of more than 200 patients with prasugrel only right from day 1. So patients were given aspirin and prasugrel, and they were continued only on prasugrel. And what did we see in this trial? Although there were patients only few, about 200, then what we see here is actually 0% stent thrombosis and no significant BRC5 bleeding. At the same time, there's no cardiac death significant, only 1 patient. So we have now with Synergy stent an ASSET trial where 0-month DAPT was used, Senior trial where 1-month DAPT was used, and Evolve Short DAPT trial where 3-month DAPT was used. So there's an extensive data right from 0-month DAPT to 3-month DAPT with Synergy stent. So real-world distribution of bleeding risk determinants showed that if you have anemia, then you have a combination of 2 or 3 risk factors with this, same as for CKD as well. So what we have learned so far, HBR patients are common in real-world practice. Bleeding post-PCI is associated with high risk of mortality. We have to identify HBR patients before PCI and strategize for short or ultra short DAPT and choose matched DES according to the knowledge we have gained. Imaging guidance and imaging optimization of PCI is extremely important because we need to really expand the stent very well. We need to choose the stent extremely well in terms of its size so that the patients may not have any risk of stent thrombosis when we discontinue the DAPT. So in this patient, actually, we opened up the LAD, and to understand the length and diameter, we did the OCT pullback, which you have seen here. And after the OCT pullback, we actually decided to see how long the stent we need to use and what is the diameter depending on what exactly we are seeing, because we have to believe what we see in terms of precision. We identified the distal landing zone here because the artery was almost normal here. We wanted to choose this as a landing zone for proximal, but we had to lengthen our stent's length because of a particular reason. I will talk about this because this is what we didn't like. Here, that's why we extended it. And why did we extend it? Because we found thin cap fibroatheroma from 6 o'clock to actually 2 o'clock, which is less than 65 microns. You can see the orange glow throughout, except in this area, which is darkness. Darkness simply means rich lipid pool. And if we had put our stent edge here, the patient would have come back with a stent thrombosis or later with restenosis. And we would have wondered why. We only can understand when we do imaging like this. And then we used synergy stent to achieve with this big tube structure along with a very circular tube here in the cross section. And we were very happy to see that there was no stent edge dissection. It was fully dilated here. As you can see, the MLA of 8.39 square millimeters and a diameter, residual diameter of only 3.3% at this point only, which is insignificant. And this is how precisely we achieve a result. And we check the stent from every angle to make sure that we are not missing anything, or this red thing is not actually malposition, but only a branch here. So this is what the angiogram we achieved in this patient. And then we were very happy that we were going to discontinue this patient's DAPT at 1 month, and we did. And then the patient underwent renal transplantation, after which we restarted his DAPT. Why I chose synergy stent? Because of ultra thin struts, biodegradable polymer, synchronous drug elution and polymer absorption, early healing, freedom from long-term polymer exposure, and is the first drug-eluting stent to get FDA approval for short DAPT, which I don't think many people know about it, but it is a first test to get that. So this young man had ACS with HBR on the basis of end-stage renal disease, history of GI bleed, anemia, and planned surgery. We utilized knowledge from published trials of PCI in HBR patients to make decisions. We utilize imaging guidance to achieve optimal results to minimize ischemic events. I'm not going to go into issues, but this is a very important slide of FDA perspective on DAPT labeling and note about safety and effectiveness. So shorter DAPT duration may impact the safety and effectiveness of profile of an approved stent. And a change in recommended DAPT this duration in the stent labeling requires supporting clinical data specific to that stent. So what I mean to say is, if FDA has approved Synergy as the first stent for reduced DAPT, we cannot extrapolate that finding to some other stent. And it is not fair because this is what the FDA says. Well, what do we know and where do we are going from here? So shorter DAPT duration invariably involves a trade-off between higher ischemic and lower bleeding risk. Optimal duration of DAPT seems strongly dependent on whether the clinical presentation at PCI was ACS or not. And data on ultra-short DAPT durations after stenting in HBR patient seems encouraging, but trials comparing different DAPT durations in HBR patients are lacking. And synergies between short or ultra-short DAPT plus P2Y12 monotherapy and true high-potency monotherapy requires further investigation. Thank you very much for your attention.
Thank you, Nikhil. Excellent speech. Very nice speech. And you have shown that how Synergy has outmaneuvered the other two good stents. And it is the only FDA approved stent That is very important to tell. And your patient was also a very, very high risk patient. And I also appreciate the fact that you went beyond the lesion and saw the portion of the lumen, which is normal lumen, but has a very thin lipid core, so that's very important. And just I want to mention about Greg Stone's lecture in last NIC meeting. He has done a, study prospect 2, I think, prospect 1 and 2 with a very small number of patients, 300 like that. I can tell you that he has shown that with all the medical treatment with statin, atorvastatin 80 or rosuva 40, and DAPT with recent molecules, the mortality was as high as 10.2%. And with he gave a bio, this BBS absorbable stent which he used, and with that he showed the mortality to be 4%. So I really appreciate the fact that you have shown with the latest of evidences in your work. Thank you very much, Nikhil. Excellent.
Okay, Nikhil, one of the important question that is you have to rightly point out the synergy is very, very useful in the cases of the high bleeding risk. Another important trial, the POEM trial, with the help of the surgery, and the synergy is 1 month duration of the DAPT followed by this thing. Very, very important also. But in your cases, the dialysis is going on, the renal failure, CKD, so that which DAPT particularly you are used for 1 month and followed by the ticagrelor or the clopidogrel, which?
It's a very, very important question you have raised. If we look at all the 1 month or 3 month DAPT trials in different stents which are available now, this is the jury is still out there. Although we used for 1 month ecosprin and ticagrelor, and we actually discontinued aspirin, believing that aspirin is the one which causes more bleeding, and we continued ticagrelor until the patient underwent renal transplantation, and after which we reintroduced the aspirin to the patient. But in some trials, I'm aware that actually the jury is still out. We don't have the full data that which monotherapy to continue, either aspirin or ticagrelor, or aspirin or clopidogrel, or aspirin or prasugrel. So hopefully this will crystallize in next few months with more outcome data available to us.
Yes, particularly in the case of Onyx trial, no?
Yes.
After 1 month, they advocated either clopidogrel or ticagrelor, anyone can be continued. That is very important. That is why I asked the question.
Yes.
Any other question from anyone? In panel, Dr. Ranjan Sharma?
Anil, any comments, Dr. Mishra?
No, quite good.
Anil?
We have fairly common topics, so there'll be some overlapping slides as well, and we are really dealing with the same spectrum of problem. So I'm sure.
If you allow me, Dr. Maja, just I want to tell one thing, that Barney Meyer, who was one of the first persons who did angioplasty with Andrew Granjig, he was telling when he came to so many times to Kolkata that in all his intervention, he uses only prasugrel 5 milligram with initial, loading dose of 30 milligrams. He doesn't give aspirin to any of the patient, and none of his patient had any problem or stent thrombosis, very little. So he is a very world-renowned person. And, he has so many, and announced, legend by both EuroPCR and TCT. And he told that he uses only 5 milligrams without any aspirin.
Correct. That
so
is
we can
aspirin.
go to
Yes, correct. That aspirin should be way out when there is ultra thin stent is available nowadays. Any question, Dr. D.P. Sadar, panelist, Dr. D.P. Shana, Dr. Ranjan Sharma, and Dr. Sarojmal? Anyone? Any comment?
If the patient is going for surgery like renal transplant in a short period of time, then I believe ticagrelor would be a better choice, because the rapid onset of action and rapid offset. So my preference would be, as he has prescribed, the ticagrelor in this situation as a single agent.
Yes.
Right.
Okay. If there is no question, thank
Dr.
you.
Mondal, Dr. Swaraj Mondal is there?
No, he is not there.
He is not there. Okay.
Not there. Okay. If there is no question, you can proceed for the next speakers. Thank you, Nikhil, for excellent presentation.
Thank you.
And I can invite the next speaker, Shaidur Rahman Khan. And he's a dynamic interventional cardiology in Bangladesh, and very experienced use of imaging particularly. He will talk on the IVAS guided case illustration on the background of the high bleeding risk. Dr. Khan, please.
Sir, kindly unmute,
Yeah.
sir.
Yeah. Can you hear me now?
Yes, sir. Yes, sir.
Can you hear me now? Yeah.
Okay.
Okay, Dr. Paza.
Yeah.
Can you hear me and my slides are visible?
Yes, everything audible and as well as visual.
Okay. So my slides are visible also?
Yeah, everything is perfect.
Okay. Okay, thank you. So, you know that talking about the HBR is really, the slides, the presenters, there is some mixing of the slides, the same slides we are using sometimes. So there will be some mixing here. And I like to start in such a way that once upon a time, a decade ago, when we were thinking of the very late stent thrombosis, DES versus BMS, we are very much equipped with that one. But the bleeding was totally undermined at that time, or underestimated categorically, I can tell. But now from real world perspectives, the bleeding, and its risk of HBR terminology, this sort of is the talk of the town. So my topics, I was guided case illustration of the HBR patients. So I'm trying to go for the thing is the same slide which that Dr. Nikhil has shown here, like that the major bleeding ultimately ends up with mortality. So we have to take care of that one very properly. And also this one is also seen in the Mount Sinai, where more around 20% actually. Now it is more, also meet the ARC definition criteria for HBR. So with the factors, even also it has been told here, all these factors are responsible, and we have to define and determine which patients are actually with HBR, and we have to handle that one because PERK 305 bleeding risk is more than 4% at 1 year, and the ICH risk is more than 1% at 1 year. So the main concern, I'm going a little bit in a different way, that main concern, the biggest question is the complex PCI of the chief population, either in the SCS or CCS settings. Itself bears a high thrombotic and ischemic risk, and if it blends with high bleeding risk, then the dilemma begins. And that dilemma means that you have to balance between a high ischemic risk and a high bleeding risk. It's a tug of war. And here, that's why, keeping this issue in mind, while treating an HBR, planning should be based on vascular access, choice of stents, and also antithrombotic medications, and also the complexity of the lesions. Especially the complexity of the lesions is very much important in HBR case, to avoid too much complexity and to simplify the case. That should be also we should keep in our mind. And the trials with a focus on HBR, for DAPT or something, just make a small glimpse here up to 2021, starting from 2015, all these trials has advocated that the short DAPT regimen is possible, and also followed by SAPT, that is also possible. And also we need to consider the intravascular imaging in complex PCI, especially the intravascular imaging is very much important, because we don't want a blurred picture while treating a population case or a very complex case in stage HBR. So let's look at a nightmare case, at least for me at that time while handling this one, and named it from a Grunwald era to modern era. This patient is 75 years old with very low BMI, with CKD, with prior ischemic stroke, with poor cognitive function, with class 3 for angina, but ejection fraction was preserved a little bit. And so these are the factors which has determined that the patient is a very HBR case. And if you go for even the precise DAPT score, or if you can see the ARC HBR criteria, this patient is meeting both criteria, and it's a case ultimately of CCS with HBR. So when you see the angiogram, that is much more devastating. The calcification and calcification everywhere, and you can appreciate that the complex calcific lesions almost in the proximal to mid LAD, and also involving the LCX to the marginal branch, and also in a tortuous calcified RCA with severe diffuse disease in its mid part. So how I wanted to handle this case? Wanted deshouldering, didn't happen. Her team review done. The bone cutter has left the scene, and the patient party was also in the same tone. So my plan was I was guided PCI and avoidance of rotablation if possible for this sort of cases to not make too much ischemic burden or thrombus burden. So we have started in that way. The radial axis was there, and IVUS catheter initially was not crossed. So meticulous vessel preparation with NC balloons and also the scoring balloon was done. And after that, even with the scoring balloons with the body wear, and then we have been able to cross the IVUS catheter, and you can see here almost a napkin ring calcifications in the mid part and also in the whole section, even with the scoring balloon, some sort of cracks are there in some places, but in some places it's not. So we have to change the plan, and we have to go for a rotablation, and the rotawire was taken, but at that moment patient jumped up because of his poor cognitive function. We have to postpone the procedure. We have to leave it up to the Grunzig era with a balloon dilatation only. And the next day, we have gone with proper counseling, that upfront rotablation with 1.5 bar. And after that, the IVUS has shown some cracks there. And then we have been able to deliver the stent. And after that, this final picture is relatively soothing. And also we have done the PCI to Prince volume at the same setting. And also the RCA, where fortunately we didn't need the rotablation, but just the guideline has helped us to put the stent there, and the final picture is good. So for this complex calcific multivessel PCI in HBR case, in CCS setting, the planning initially was not perfect for us, for me actually. The front rotablation plan would have saved time than complexity. Vascular access was good. Its transradial choice was good. Not too much contrast in subsequent two settings was not that much actually. And second and third generation desk platform were used. And considering all these facts, the beta issue here is the tug of war with the DAPT regimen to maintain balance between ischemic and bleedingness. This is actually, it has got a high ischemic burden also at the same time. I love this algorithm, which has been published in European Heart Journal, review, and here I can use it, the high bleeding risk with high ischemic risk. I have put this patient for 3 months DAPT followed by SAPT. My next case is he's a 85 years old man, and with all the risk factors right there, and presented this time with a non-STMI along with a syncopal attack, and the ECG shows complete heart block, but a relatively preserved ejection fraction. And for this patient also, this precise DAPT score is more than 25, and also it's meeting the ARC-HBR criteria. So it's a case of SCS with HBR. Very hesitant to handle this case with a very elderly population. Forget about 3-4 angina. At the same time, the patient had syncope. Nobody can ignore that one. And but we have to go for to see the coronary anatomy. And it was like throwing a rock in a beehive. So you can see the coronary anatomy here, and you can appreciate that the distal left main and the LAD itself are very much severely diseased, and also the marginal branch. But fortunately, the RCA is so far benign. So these are the issues here that we have quite ambiguous angle of the LCX and of ostium, and also you can see here the distal left main is literally hanging. So went to old age to Socrates to ask that the egg first or the hen first for this double keeping these devastating coronary lesions with first and a stressful procedure, knowing this sort of coronary anatomy, or if revascularization first, then how long will be the time limit for the passenger to take the train of chronotomic reversal, if any, and with DAPT PPM implantation in HBR, and how it can be done. We decided to go for the left main PCI first. Complex journey for intervention by TRA, and it was really hard to wear the LCX actually, and well preparation of the vessel bed preparation was done by NC balloon to crack the calcium, and wiring of the LCX was also a challenge here. So then we have done an IVUS pullback from from proximal to distal LED and left main, and you can appreciate that at least God has helped me a little bit, that not that much calcification, which we can expect from an 84 years patient. So after that, it's comforting, yeah, that this IVUS image has helped me a little bit. Then planned for decade upfront for a two-strand strategy in this complex left main bifurcation, seeing all the angles and the anatomy of the lesion. And after that, all the steps of decade crush was made in cool head. First with the 2.524 days inside branch, and then in the LED 2 days, 2.7524 distally, and after left main to LED 3.530 days. And after that, that all port wearing keys and other steps were followed. And then I was pulled back from LED. You can see here that the stand-up position and MLA, everything was satisfactory. And from LCX also, the polygon of confluence is very much beautiful. So the final smile without any hiccup. And after that, 3 long days with the APT, the patient has the patient underwent the pacemaker, permanent pacemaker. So for this complex left main bifurcation PCI, SCS setting with HPR, IVUS guided PCI was perfect from planning perspective, and also the access site, the costumes, and the desk platform, everything was perfect. And for this patient, what will be the DPT regimen? With 3 months. From these 2 cases, while dealing with the complex relation with HPR, we need to have proper planning before procedures. In aging guidance, IVUS or OCT helped a lot to make it perfect. Not guidance for chip population and HBR, and it can see that one back in 2005 in the guidelines, just see class 2 indication. Later on, some trials and RCTs were there for IVUS specifically. And then the guideline also again revised, and again it has told the class 2 in 2014. Then the ultimate trial has some better outcome. And then optimal trial, we are waiting for the results. But still, even all these trials are there, still IVUS in complex PCI with HPR is still underutilized, because even in EBC main, if you see in the decade crush 5, if you see everywhere, the percentage is almost 40%, the maximum. It's not that much. So to wrap up, I can tell here that in a very complex PCI and HBR, bleeding matters, but ischemic risk cannot be spared at all. Precise and perfect procedure outcome must be the priority. DAPT regimen for HBR is still in the midst of cloud, but at least short duration of DAPT is widely accepted. And for precise PCI, most importantly in cases with HBR, should have imaging tools and to make it perfect and simpler. Thank you very much for your patience hearing.
You've got Dr. Kahali. You have got only 9
We can't go into any. We can't go into any discussion. I have shown your. I have shown your direction in the chat box because we have to finish by 1 o'clock. So I would call the next speaker, Dr. Anil Bislo, good friend of mine. He's a very good interventional cardiologist and doesn't need any introduction. Very dynamic. He will be talking on latest evidences on short DAPT. Anil, please.
Yeah, just give me a second. I'm sharing my screen. I think you got it on the screen. Right. As we said, we've all been discussing the risk of bleeding and how to optimize it. There are a number of factors which are involved with this. And some are related to the patient, some related to the stents. We always should consider what is the clinical status of the patient, whether it's a STEMI, acute coronary syndrome, or a stable angina. What is the lesion type? Is it a simple, straightforward single vessel disease, focal lesion, or long lesion, bifurcation lesion, small vessel lesion, things of that sort? What are the bleeding risks involved using the various scores, etc.? And of course, we have to take into consideration what kind of stent we have. What is the thickness of the stent? What is the metal alloy we have used? What is the drug in it? And what is the polymer coating? Is it aluminum or conformal all over? So these things are what we need to consider. And a new factor which has been coming in, the duration of DAPT only, not only that, but also what kind of DAPT we are going to use or single antibiotic therapy we are going to use. This is a new confounding factor which is coming in now. So one has to find the balance, right balance, the sweet spot between having a low ischemic event at the same time having a low bleeding risk, because giving antiplatelet therapies increases the bleeding risk where it reduces the ischemic events. And if you reduce it, it becomes vice versa. So you really have to balance it and find the right sweet spot. Now, we have already discussed in the patients, not only the bleeding risk, we also have to see what are the comorbidities which will increase the problem of stent thrombosis. Diabetes, renal dysfunction, heart failure, previous stent thrombosis, etc. And we have discussed what is the anatomy of the lesion we have to see, and we have to see at the same time what kind of stents we are using. Are we using a first generation, second generation stents, and what are we using instead of those? Sorry, my slides are playing up a bit. So let's go over the slides again. We have already seen this slide with evolved short DAPT. This is a synergy stent used for these patients where they are being used on 2,000 patients over 110 global sites with high risk bleeding, and they have a very low rate of stent thrombosis. And I think this thing is coming on my way. I'm going to get this off. Yeah, I think that's better. Sorry, my slides. So we have 2,000 odd patients with dual antiplatelet therapy for 3 months, and we continue the DAPT and continue with only aspirin thereafter for 12 to 15 months. And the results, we see very low stent thrombosis rate and very low primary endpoints of death and myocardial infarction. We can see not only that, the bleeding risk in terms of strokes and BARs here, bleeding is also fairly low. The events are low. Another trial is STOP DAPT trial, where they compared 1 month versus 12-month DAPT in cobalt chromium eluting stent, which is Zion series basically. And they used DAPT for 1 month, and it was allowed to use prasugrel as well in this 1 month. But after the 1 month, they would continue either clopidogrel for 5 years or continue aspirin for 5 years and continuing clopidogrel for 2 years. So there are 2 arms here. One is monotherapy continuing for 1 year where the primary analysis was done, or dual therapy with clopidogrel and aspirin for 1 year. And the results, there were 2 kind of results because they had 2 populations. One was a population which has included only 38% ACS patient, 62% were chronic stable patients, whereas the other population where they exclusively used ACS patients. So good number of patients, 3,000 and more on both sides, and they were studied after 1 month of DAPT versus 12 months of DAPT. And the result shows that overall, they met non-inferiority trial of having 1 month DAPT compared to the 1 year DAPT. But if you see the ACS group, they did not mean the non-inferiority. And therefore, for the ACS group, you still want to use longer period of DAPT. But if you see the non-ACS group, or where the ACS people were less in the population, they had good results. They met the non-inferiority criteria. The bleeding risks for both group had been low. So another trial, Zion's trial, Giant short DAPT with a 30-day or 1 month or a 3-month therapies. Again, we continued DAPT for 3 months in one group and for 1 month in one group, and thereafter aspirin only to continue for 6 months in the shorter period one and for 1 year in the longer period one. And primary analysis were done at 2 different times. And if you can see, the non-inferiority was met for both the 3-month and the 1 month group in terms of primary endpoints. We also see that the secondary endpoints of bleeding thrombosis were also less in both the groups, and the stent thrombosis was fairly low again in both the groups. On this basis of this, there is now evidence that one other stent could possibly meet the criteria of being used for a lesser period. Ideal left main is a little extension into a complex left coronary artery disease, because left main stent is considered to be a high risk patient, and therefore traditionally 12-month therapy has been advocated. But here in this trial, there were 818 patients which were divided into a synergy by the stent with 4-month DAPT and Zion stent with 12-month DAPT, and they were compared at the end of 1 year, and they found that there was non-inferiority. So 4-month DAPT with synergy was as good as having Xience with 12-month DAPT. Onyx 1 global study, again, close to 2,000 patients had dual antiplatelet agent for a month, and thereafter they discontinued DAPT, but continued any of the P2Y12 or ASA monotherapy, depending upon the choice of the physician, for 1 year. And the results are here to see. The cardiac death, MI, stent thrombosis, MI, and bleedings, the reasonable, comparable, and they were non-inferior, but the figures seem a little high, you see. But when you combine this with Japanese and USA data, which becomes Unix 1 clear study, then you see these figures have come down very good comparably. The cardiac death, MI, stent thrombosis, BRC, bleeding, etc., have all come down significantly and are now non-inferior to using a 12-month DAPT therapy. So on basis of this, I think Onyx 1 also got approval with the FDA. Seniors trial is an old trial, but again, 2 groups, 1-month therapy of DAPT or 6-month therapy of DAPT. And you find the MACE results were fairly comparable to bare metal stent. Stent thrombosis rates were very low, very impressive. And bleeding rates were also low, both in the 1-month group or 6-month group. The 6-month group was the one with acute coronary syndromes, and stable anginas were getting 1 month. So in senior elderly patients also, you can reduce the DAPT therapy. ASSETS trial went 1 step ahead. They eliminated aspirin altogether. These patients who were chosen for plasty were given, stable angina group people were given prasugrel only therapy right from day 0 to 3 months. And thereafter it was studied. They found a very low rate of events and bleeding. So very impressive on this one. But this is a pilot study. We need to have more data on this with other studies. Dr. Panja was mentioning POEM trial. Again, 443 higher bleeding risk patients in 9 Italian centers given aspirin monotherapy after the 1st month only if indicated. But if they were an oral anticoagulant, they were given only oral anticoagulant after the 1st month. Very low rate of MACE, very low stent thrombosis rate, and low bleeding risk. So very good results there as well. So 1-month therapy in Italian study also matches a 12-month DAPT therapy. So we have seen this slide that we started off with data which gives a 3-month DAPT therapy, then 1 month data from 1-month DAPT therapy, and now even for 0-month DAPT, only single antiplatelet therapy may be equally good, but this needs more validation by other trials. We have had data from master trial with other stents. Ultimaster stent was used in this, but DAPT was used for 2 months if they were on anticoagulation, and for 5 months if there were no anticoagulation. And they showed non-inferiority standard DAPT therapy. If we go through Tycho trial from Korea, again, 3 months of DAPT therapy, where after that it was not aspirin, but ticagrelor, which was continued for 12 months using Orsiro stent. They found that this therapy after DAPT was superior to the standard therapy of DAPT for 12 months. So combination of aspirin, clopidogrel was a standard therapy, and using monotherapy after the 1st month was superior, both in terms of event rates as well as bleeding risk, surprisingly. Bleeding risks were less as well. Twilight study we all know about. Again, 3 months of DAPT compared with ticagrelor monotherapy thereafter, and in people with high risk ischemic or bleeding features, showed less bleeding, and clinical outcomes in terms of event was similar with a standard DAPT therapy. Smart choice, again, 3,000 patients, who's a lot of patients, and they were using wide variety of stents. They were using cobalt chromium, platinum chromium, and of course the sirolimus eluting stents as well. And they used different kind of agents as well. They used clopidogrel, ticagrelor, and prasugrel. And there were 2 groups, a DAPT group for 12 months, and of course the 3-month DAPT therapy. And the results were quite encouraging that they found the p-values for major events were all similar compared to the 12-month therapy. Of course, the bleeding risks were less because of the shorter duration of therapy. So that is also very encouraging. So on basis of this, you will find that we already have data for 4-month DAPT for left main, which is a complex lesion. We have 3-month DAPT lesion data for synergy, and of course, Xience we have. We also have 1 month DAPT data for Synergy, a lot of data with 3 different trials, and from Onyx 1 clear trial, basically, as well as Science. And now we are thinking about using only a single antiplatelet therapy, which will be, again, has to be verified and validated in some other clinical trials. And the guidelines still remain the same, but I'm sure in coming years, 1 or 2 years, some of these may change. We have gone through this again. The first speaker really went through this. We can see that we can, in selected cases with high bleeding risk, go up to a 1 month of DAPT therapy if required, but 3 months would be optimal for them. But of course, with acute coronary syndrome, one has to be more careful. It should be perhaps 6 months of DAPT, but data is emerging. This is a changing scenario, and with emerging evidence, we will see this data change and these guidelines change as well. Thank you very much for your patience. And I think in this short 12 minutes, I've not been able to cover everything available, but whatever possible relevant, I could cover.
Thank you, Dr. Mishra, for excellent presentation. Carl, you can ask only one question only, even only one.
Minal has told that no question now.
Okay,
because we are
that's fine.
out of time, only 7 minutes left.
For this session, we have only 8 minutes left, sir.
Only
Okay,
8
okay.
minutes left,
Thank you very much. So we are calling
friend, Dr. M.G. Ajam,
Yeah.
to deliver his lecture on DES, choice of DES in HBR patients. Very good lecture on it. Yeah. Dr. Ajam,
please.
very good friend of mine.
Yes, I am sharing my slide. Okay.
Yeah, please. Yeah.
Slide is upload.
Recording assistant, sir. You can see a share screen bottom center. You can able to see share screen, sir.
Okay, I just.
Dr. Azam, why don't you speak off the slide? Off the slide you speak. That will be better lecture actually. If you speak off the slide. We do frequently.
Share the
Yeah, green
Yeah,
one.
it's loading, sir. It's loading. Yeah, we can see your desktop now.
Right.
So you can open your PPT.
Yes.
Okay.
Is it?
Yeah, make it full screen, sir. Kindly make it.
So you have got 72 slides. You'll have to bring down to 10.
Okay, can you see my slide?
Yeah, please proceed, sir.
Sure. Okay. Thank you very much. Actually, it's my honor and privilege to be here with you. It is a wonderful session. I must give special thanks to the Cardiology Society of India to arrange such a wonderful educational program. And as you know, this is the hybrid risk topics is very common emerging topics, and almost everything is covered by my previous lectures. So I have to skip some slides because there are overlapping some slides. Before going to my talk, I just show you one or two cases. This is 65 years male, smoker, diabetic, and his hemoglobin was only 12.4 gram per dl. His coronary angiogram. If you look at this, his syntax score was 31. Left brain NAD, LCX, and also RC disease. So it is actually left brain and triple vessel disease. Categorically, patient decline for cabbage, then we go for PCI. Definitely, it is a complex PCI procedures. So we did actually fix it up by SARC2M, then mid NAD, and left brain to proximal NAD as well covered by overlap stent. And finally, we go for final casing inflation to open the start as well as and go for port. And this is the final result. This is not the end of the story. You see, this is the final result. But initially, his precise test score was 17. We are planned for to continue longer duration of test was end. But unfortunately, patient attended our emergency department after 2 weeks later. Black Terry's 2 pieces of hematosis and melena, and become patient hemodynamic unstable with tachycardic, and patient found severely anemic. And what is the actually next plan of management and what will be the TB duration? I think it's wonderfully covered by Dr. Mishra. And just what we did in emergency department, just urgent risk score for bleeding to assess the mortality prior to endoscopy, as well as how much urgent need to go for endoscopic strategy. And we did a Glasgow Bradford bleeding score and local score pre-endoscopy. And we did it accordingly within the next 24 hours. We arranged the endoscopy and endoscopy strategy was taken, and we managed accordingly in our guideline. And again, we assessed the rebleeding score, and it is found around 5.3% mortality. Second case, you see, this is also 54 years male, unstable angina. He had multiple comorbidities like deuterium ectoderm operated and ischemic CVD, hypothyroidism, DM, and smoker. His renal function is impaired and also CKD. And he presented to our center with a previous angiograph with 1 year span, with showing triple vessel disease as well as RC total occlusion. And in the course of hospital, patient developed complete heart block. We did permanent pacemaker implantation, following for 48 hours, we go for PCI. We did this complex procedures. Long synergy stent was implanted in the SARC and LED as well. And finally, we just decide we should, as because the precise depth score was 32, we should continue the short duration of DAPT. So actually, upon this consideration of two cases, the complexity of the high bleeding risk patient, we have to understand actually high bleeding risk patients are a large, growing and complex subset of population. Around in our daily practice, 40% patients are suffering from actually hidden or expressed way in high bleeding risk patient. Though we have limited data, but HBR patient appears to have complex disease more often than all commerce patients. Greater risk of bleeding events for high bleeding risk patient on extended DAPT program are present. That's why we can conclude the optimal strategy to balance the bleeding and ischemic risk for high bleeding patient is very important to understand in our daily practice. Why we should address the high bleeding HBR patient is because 30% patient may require DAPT interruption due to have a major bleeding events. And if you look, bleeding is essentially the very bad prognosis. If you look at this left panel, most of the bleeding hazards occur due to GIT cause. Other cause also happened, but that is not too much significant. In case of if you continue longer duration of DAPT, you see that the bleeding risk is much more higher. But the most important thing is first 30 days is very crucial. Why we are considering short DAPT within 1 month is because bleeding complications as well as thrombotic risk is the most occurred in the first 30 days. So we have to be careful in this first 30 days. And if you observe this data, you see the 18-fold increased risk of death in case of first 30 days. So we have to be very careful in first 30 days to management of our HBR patients. I have to escape this slide because all of you know the all high risk patients. And once you consider the patient are complex patient, you have to go for PCI. Then you have to correlate DAPT and DAS because after stent implantation, DAPT therapy need to be individualized, but stent properties that allow for rapid healing could also play an important role for a patient who may need to interrupt or discontinue DAPT shortly after stent placement. But once we plan for stent implantation, we have to think of our stent, as nicely said, Nikhil Parchuri, as well as my second speaker, stent design, platform, polymer, drug, also important.
Maintain the time, sir.
Sorry, can I give you two minutes?
Okay, sir.
It's because if you think that this also enhance the faster complete healing and that reduce this discomfort and thrombosis, that may reduce the MI and death. So why it is better? The drug should be safe and effective. Polymer should be thromboresistant, non-inflammatory, and platform should be appreciated to encourage the healing. So these are the how we categorized. If you think the hybrid risk and complex PCI is subset, if it is no HBR, we should continue longer duration. If it is due to HBR, then we should continue for shorter duration. And all of you know the PCI depth score should be done before your planning of strategy. And these are all our trials in our clinical practice. Almost all stand.
Could you wind up the session, sir? You have already entered the next session. Sir, wind up the session.
Yes, please
Can I
conclude
go
this session.
Conclude? Can I go to the conclusion slide?
Slide? Yes, that's right.
This is my final slide actually. Before going to procedure, we have to make a plan. Bleeding risk should be stratified and appropriate next of criteria for reversal should be considered. Avoid routine pre-treatment antiplatelet therapy for all patients. We should go for radial access as because to minimize the bleeding complications. Optimal anticoagulation should be considered. Appropriate social selection because thinner is better. That's why we always prefer for synergy stent in case of high bleeding risk patients. IVUS also optimization should be used. Choice of DAPT is a matter, and shorter duration of DAPT should be considered. And we have to sometimes modulate as DAPT, as you showed my past case, and in terms of convection, proton pump inhibitor we can add in case of high bleeding risk patient. And it is my in-home message. Patients with high bleeding risk score have higher rate of cardiac event, MI, and stent thrombosis. And assessing bleeding risk alone does not help assess the grade of risk. Individual patient condition clinical judgment is paramount to decision making. Newer generation tests is very safe, but several ongoing studies are underway to establish how truly they are safe. The flexibility of discovery DAPT would be beneficial to patient and would be a big challenge and advantage for any patient in our daily practice. Thank you very much.
Thank you, Najat,
for your excellent speech. And I think we should give a big thanks to all the speakers. They have done extremely well. We should also thank Professor Paja and all the experts present in the panel and all the delegates. Dr. Paja, short comments, please.
No, okay, we are very thankful to all the speakers and the discussion moderator for till speaking. We are finished in time. Though the scientific chair is very strict in timing. That is depends on the success of the conference. Thank you all the speakers for excellent discussion and presentation. Thank you.
Thank you, sir, for a good discussion on this important topic. Our next session is on lipidology and metabolomics, and for which we have moderator of the session, Dr. UK Shaha, Dr. Shunib Banerjee, Dr. Pishi Mondol, and in chairpersons are Dr. Devanu Ghosh Rai, Dr. Sunil Baran Roy, Dr. Tarun Praharaj, and Dr. Soumitra Rai. Our first speaker is Dr. Soumitra Rai, and he will be speaking on relevance of lipoprotein little a in lipidology.
Dr. Mondol, you start the proceeding immediately. And
Yes.
the speakers are requested to stick to the time, and chairpersons also should see that it goes fine.
I'll request Dr. Soumitra directly to start his deliberation on this dual sort, that is LPA, both thrombogenic and atherogenic, and an heritable risk factors. Please, Dr. Rai, you start.
Thank you, Dr. Mondol, all the chairpersons, moderator, team CSI, West Bengal update. Now, my talk today is relevance of lipoprotein A in lipidology. Now, LPA is an important but underappreciated risk. Most people know that LDL cholesterol can cause heart disease, but very few of us are aware.
Sorry to interrupt you, sir. Sir, kindly make it full screen.
I am in full screen in my computer.
No, sir. You have selected full screen, and so kindly stop share.
Stop share. Yes.
Now, kindly
Reshare again.
Share screen. Then you can
Share
select
screen.
full screen.
Yes.
Now you can say select full screen option.
Full screen option. Where is that?
No, you can able to see two PPTs, right?
I can see two PPT. Yes,
yeah,
yes.
In that full screen mode will be there.
Full screen, yeah.
Yeah.
I
then
share
share.
the full. Are you seeing it now?
Yes, sir. Perfect.
Is it full screen?
Yeah, perfect.
Yes,
Perfect.
yes.
That's
Please
good.
go ahead.
Okay, right. Now, the very few of us are actually aware of the importance of lipoprotein A. This is comprised of an LDL-like particle, but with a second protein attached called apolipoprotein A, which is coiled around it. And recently we have come to know that high LDA may have a 2 to 4 times increased risk of heart attack. And despite that, the awareness is still not that good. So this is the LDL-C versus an LPA. Apart from ApoB, there is an extra ApoA attached to the LDL particle, which makes it A. And this is an independent risk factor, not an associated with LDL cholesterol. And many people, about 10% of people who have got heart attack, don't have any conventional risk factor, but they have only high LPA as the risk factor, like some famous personalities who died and had heart attack in the early age with LPA as the sole risk factor. If we see the LPA metabolism, as I told, that apoprotein A is synthesized in the liver and it wraps around the LDL cholesterol, which is secreted in the blood, and it is taken up by the coronary arteries and other endothelial surfaces, but it is recycled back into the liver for destruction. But what are the mechanisms through which LPA can cause a cardiovascular disease? There are pro-inflammatory effect, there are pro-thrombotic effect, there are pro-atherogenic effect. So I don't go into the details, but there are multiple mechanisms by which LPA can promote atherosclerosis. So genes control what will be the level of LPA in our body. And it is the largest single gene risk factor identified for heart disease. This is very interesting. Diet and exercise really do not have any impact on LPA. Now, most people of LPA have the range of 5 to 30. Above 30, the risk increases, and above 50 milligram per DL, the risk curve really becomes very steep. About 15% of people are above this threshold of 30 milligram per DL. But there are racial and ethnic variation, with some Black individuals like to have more elevated than the white, Hispanic, and even Indians. So it is Afro-Caribbeans have got more, and it actually there was some gene tracing came which showed how the population migrated from the ancient days, carrying the LPA gene with them, so that there is this ethnic and geographical variation we can see today. This is an US data, typical distribution of LPA in the general population. If you see above 50%, the risk starts, but it is not a very huge number of patients. Around 20% have got above 50 milligram, both for men and women. And if we see the prevalence of LPA in a huge number of population coming from the US database, below 30 milligram and above 50 milligram. Above 50 milligram is around 25% people. Above 30, if we take the cutoff, then 1/3 of population in above 30. Now, LPA comes in different size, and just like small dense LDL, LPA can also be small particles. Now, if the particles are small, then they are more atherogenic, because milligram per milligram, you have got more particles. So sometimes we are trying to express it in nanomole rather than milligram. But again, like LDL, the assessment is a bit difficult. Now, structure of ApoA includes the loose segment, what we call the kringle. And depending on the number of kringle, the size actually varies. If you see the kringle, that means the turns and turns in the apolipoprotein A chain actually determines the size of the LPA. And the lesser the kringles, the smaller the size. Now, because LPA particles vary in size, the most commonly used laboratory tests are not ideal. These tests measure the total mass of LPA in milligram per DL. As I mentioned, a more accurate approach would be ideally nanomole per liter, which actually will tell the number of particles rather than the volume of the particle. If you see, even for the same 30 milligram per DL value of LPA, there could be 55 nanomole per liter or 85 nanomole per liter. So depending on the number of kringles and size of the particles. So of course, it is very visually obvious that if you have got more particle, 85 nanomole per liter, your body is more atherogenic. Now, lipoprotein and heart disease, what is the risk? 1 in 14 heart attacks and 1 in 7 cases of aortic valve disease can be explained by or associated with higher LPA. So aortic valve disease is something new, which is not explained by LDL cholesterol or triglyceride or HDL cholesterol, but by LPA cholesterol. And measuring the LPA cholesterol can actually decide the risk prediction at the bedside. If you see, this is an interesting slide. The addition of LPA to this risk score allowed reclassification of about 40% of the patient. Either they go back to lower class or they come into the higher class, depending on the LPA values. So the standard risk prediction, if we superimpose LPA on that, almost 2 in 5 cases, we have to change the risk category of the person. So this is, I think, an interesting thought. Now, LPA and the calcific aortic valvulopathy, if you see, as the LPA level increases, the calcific aortic valve stenosis also increases, and the pressure gradient also has been shown to be increased across the aortic valve. Now, elevated LPA and oxidized PL ApoB predict progression of the CAVS and the need for aortic valve replacement. So not only it stops in the pathogenesis, it also can predict whether the patient will progress within next 1 year or 2 years to have the aortic valve replacement. So the gradient will increase beyond the severity limit of about 80-90 millimeter mercury. So LPA concentration depends on the affected vascular bed. If you see, if you have got multivascular disease, say your coronary, your carotid, your peripheral, you will see a corresponding higher level of LPA in your blood. Whereas if it is a just single coronary artery disease and nothing else in the body, you may have a lower LPA. So LPA level is linearly associated with the number of vascular bed involved by atherosclerotic process in the body. An elevated LPA linked to the higher risk of heart attack, as we said, as the value increases beyond 30. So below 30, if the risk is 20%, above 30 it becomes 60%. It's a very steep rise. And if you see, if it is above 110 or 15, it is 160% rise. So actually, LPA is strongly correlated with a heart attack. Now, evidence base for LPA as an independent causal genetic risk factor. There are meta-analysis which bore evidence to it. There are Mendelian randomization, which again bore evidence to it. And there is also genome-wide association, which we call GWA, which also shows the strong association. So actually, there is enough proof and evidence that it is causally related to both atherosclerosis and aortic valve disease. But there are no currently approved medicine that directly target the LPA. Maybe this is the reason why we are not so enthusiastic about talking about LPA, because the question comes, what if we get a high LPA? What should we do? So unless we can do anything, why should we know about it? It only increases the worry. But I'll tell you why we should know now. Statins do not reduce LPA and may even cause a slight increase. So statins is not the answer. Niacin can provide some reduction, but it is never approved. And of course, it is very side effect related medicine. The most effective therapy is apheresis, but the procedure is normally reserved for very high risk patient because it is expensive, because it requires weekly visit, because it's not sustained. Within 3, 4, 5 days, the LPA starts increasing and it involves certain risk. Apheresis can initially lower the LPA by 70%, but levels start to gradually rise within a few days. So, and how many of us know where a apheresis can be done? I personally don't know whether in Calcutta it is done or not. So really, I am in a soup. Recently, evolocumab has been shown to reduce the LPA, and antisense gene modulation is holding promise for future. If you see, the apheresis is really reduces 70% of LPA. Along with that, it substantially reduces the MI, PCI, and CABG rates as well. But of course, how can you do it lifelong? Because you have to go back to the center every week. Fourier trial showed that the evolocumab can reduce LPA by up to 36%. And you see the MACE reduction, which was so evident with evolocumab, it has been calculated that LDL cholesterol reduction contributed to 73% of MACE reduction, and LPA contributed to 27% of MACE reduction, particularly on the higher side of LPA level. If your LPA is 30, there's no point reducing it. But if your LPA is 150, you get substantial benefit by evolocumab by the reduction, corresponding reduction of LPA along with LDL cholesterol. Odyssey also, apart from Fourier, showed that a history of peripheral artery disease or cardiovascular disease, LPA is causally associated, and the treatment can really reverse some of the risk. In the Odyssey outcome, you have seen that quartile 1, 2, 3, and 4, depending on the LPA level, varies according to the MACE incidence. The MACE incidence increases from 9% to 12% if you go from quartile 1 to quartile 4. Now, towards the end, I will say the work going on a medicine to silence that particular gene, which is the strongest single gene risk factor for coronary artery disease, that is the LPA gene. Researchers are exploring a new type of therapy called short interfering RNA. We know it now, inclisiran is such a magic thing for LDL cholesterol now. So we are waiting for a magic for LPA as well. this approach targets and disrupts the mRNA that is required to translate the LPA gene to particle. And by silencing the gene, the goal is to achieve a large and durable reduction so that once or twice yearly injection can permanently reduce your LPA. An investigational therapy on this new drug has started in 2018, and any medicine designed to lower LPA level will require large outcome trial because you have to work over LDL reduction, and the work always becomes heavier. And the antisense oligonucleotide is really very significant. Just like inclisiran, it reduces the LPA by 60 to 70%. 2019 ACC guideline on the primary prevention of cardiovascular disease showed, which is endorsed by most other bodies, showed that elevated LPA is a relative indication for the measurement is family history of premature ASCVD. Above 50 value constitutes a risk enhancing factor, especially at higher levels of LPA. So they have categorized it in the section of risk enhancing factors, along with kidney disease, along with metabolic syndrome. And the 2019 ESC guideline showed LPA measurement should be considered at least once in each adult person's lifetime to identify those with very high risk, that is more than 180. And also above 50, you should be cautious. And recently, we are going to publish from the Asia Pacific guideline on lipid, and there we have included the LPA to be measured at least once. And I personally believe if at least once, it should be at the beginning of life when you are assessing the risk for the first time, because you can do something about it. And lastly, the new ICD-10 course, effective from October 2018, made it a separate entity for diagnosis and disease, that high LPA is a disease per se. So I thank you, ladies and gentlemen. I stop over here.
Thank you, Dr. Rai. I think it is a nice lecture. Just one thing I will ask you. You have given this antisense gene mutation and targeting siRNA as a therapeutic measure to make the gene silence. Is there any role of LPA GRS, that means genetic risk scoring, if the value is more than 125, LPA more than 125?
Yes, there is a
highlight this area.
Huge database is being done in India as well to get the genetic database of the Indian population on different cardiovascular risk factors. So, and there are recent publications on it as well, which also includes the LPA gene. But the first job, Dr. Mondal, is to get the database ready to see the gene pool, in which part of India it is an important factor, so that we can target those population for measurement and possible treatment. But so far, evolocumab, is very expensive treatment and difficult to maintain, and it is not yet indicated to specifically target LPA. So at the moment, we should get the epidemiology clear for India first, then we can proceed to the next step.
Yes, just one thing, if the value is, suppose a lifetime you have advised at least once to measure the LPA, suppose the value has come up as more than 125. In those scenarios, if there is a history of premature CAD or sudden cardiac death in the family, then LPA GRS, genetic risk score, has got some value, and that is approved, evident from UK Biobank cohort. It's a large cohort in Europeans that shows that particularly they have targeted the Asian immigrants. If the value is too much high, more than 125, their thrombotic risk is also very high. Besides atherosclerosis development and progression, that's complication, that means plaque rupture and with superimposed thrombosis is also very high. From that point of view, this genetic risk scoring and targeting a genetic gene therapy is advisable, but it is not yet included in the guideline.
Thank you.
So we can move to, is there any question from other panelists or any delegates? If there is no questions, we can go forward for the next presentation by Dr. Rammohan Roy. He will present on triglyceride and CAD. Is there any question from anyone? Dr. Roy, you want to make any conclusive remarks from your point regarding this Asia Pacific guideline and anything?
Yeah, I think it is now, we should be more aware of the importance of LPA. we should measure it, keep it in perspective. And I personally also, if the value is very high, as you said, above 150, 125, I measure it serially, not once in a lifetime. And along with other treatment, I also have a look into it, whether I can successfully. And a couple of my patients, not many, I have given evolocumab to reduce the LPA, though I know it is not by guideline. And the LPA has come down from 150 to around 60, 70. And LDL was always below 50 anyway. So I felt more comfortable, and the patients are doing well. So it is not guideline recommended, but I think it is important also.
Okay, I am accepting your one line, at least measure one time LPA value in all Indians. And
Yeah.
I'm throwing it back to the delegates. Please accept this line. That's a very good line he has uttered. So we are going to the next presentation by Dr. Rammohan Roy on triglyceride and CAD. I think this will be a nice presentation from Indians' perspective, because we are very much prone to have high triglyceride as a part of metabolic syndrome. Dr. Roy, please.
Thank you, sir. Am I audible, sir?
Yes, yes.
Hello.
Okay,
Thank you,
audible.
sir.
Please go ahead.
Very good afternoon, respected moderators, sir, the respected chairpersons, the delegates. My sincere thanks to the organizing committee, especially the chairman scientific committee, for giving me this opportunity to speak on a very important topic on lipidology, that is the triglycerides and coronary artery disease. And my discussion will be on triglyceride-rich lipoprotein metabolism, the role of triglycerides in cardiovascular disease, controversies and consensus of triglycerides, the benefits of newer therapy like omega-3 fatty acids and fibrates, and what the guideline says. Now, usually there are simple lipids in our blood, which are cholesterol and fatty acids. On the contrary, the complex lipids are cholesterol esters, the triglycerides, phospholipids. The lipoproteins, actually these are spherical complex, which have a shell of phospholipids, apoprotein, and free cholesterol, as well as a core of triglyceride and cholesterol ester. As we can see, the VLDL, VLDL remnants, chylomicro remnants, the large LDL and LDLs, these are relatively larger size and pro-atherogenic. On the contrary, the HDL are anti-atherogenic in mechanism. Now the chylomicrons, VLDL, these contains the maximum triglyceride, that is around, chylomicrons contains around 90 to 95% of triglycerides, followed by the VLDL, whereas the LDL or HDL contains around 4 to 7% of the triglycerides. Triglycerides account for the major portion of the ingested fats. The plasma rich with these triglyceride-rich lipoproteins has a milky and cloudy appearance postprandially, and after lipoprotein lipase-mediated lipolysis of triglyceride-rich lipoproteins occurred, the plasma has a clear appearance. Now, these free fatty acids generated during this lipolysis are used either for energy production or storage. Now, mainly there are two pathways for the lipoprotein metabolism, that is the exogenous pathway and the endogenous pathway. The exogenous pathway are nothing but the synthesis of chylomicrons in the intestinal border cells. Now, this goes into the systemic circulations, taken up by the for lipoprotein lipase activity. The free fatty acids are generated for the energy production in the muscle and the adipose tissue capillaries, and the chylomicron remnants are taken up in the liver, as well as they can contribute to the this production of atherogenesis. On the contrary, the endogenous lipoprotein pathway, this consists of synthesis of VLDL and LDL in the liver. This again goes to the bloodstream. The free fatty acids are generated for energy production through lipoprotein lipase activities, and it is mainly free fatty acids are provided to the muscles, the adipose tissues, the heart. The LDL particularly, these are taken up by the LDL receptors both in liver as well as the endothelium of the vessels, and most importantly, these also contribute to the atherosclerotic process. Now, the causes of elevated triglycerides are the obesity and overweight, physical inactivity, smoking, alcohol intake, high carb diet, several diseases like type 2 diabetes, chronic renal failure, nephrotic syndrome, certain drugs, and various genetic disorders. The hepatic triglyceride-rich lipoproteins are precursors of cholesterol-rich LDL. Cholesterol ester transfer protein is very important and allows all triglyceride-rich lipoproteins to modify the composition of cholesterol-rich HDL and LDL. As a result of this hypertriglyceridemia, LDL particle can become enriched with triglyceride and depleted in core cholesterol ester, leading to small dense LDL, which are actually very much atherogenic. And the major gene regulators for lipid metabolism affect both triglyceride and cholesterol. Now, the triglyceride-rich lipoproteins and the remnants readily penetrate the arterial wall and can be taken up by the scavenger receptors on macrophages directly without oxidative modification, leading to formation of foam cells and atherosclerotic plaque development. But we have to remember the cholesterol content of the triglyceride-rich lipoproteins, that is the remnant cholesterol, is more likely to be the cause of atherosclerosis and cardiovascular disease rather than raised triglyceride per se. The cholesterol, not triglycerides, accumulates in the intimal foam cells and in atherosclerotic plaque, and remnant lipoproteins, just like LDL, can enter the arterial intima, but chylomicrons are too large to enter. The lipoprotein lipase activity at the surface of the remnants, either at the vascular endothelium or within the intima, leads to liberation of free fatty acids, monoacyl glycerols, and other molecules, each of which could cause local injury and inflammation. So hypertriglyceridemia is often associated with decreased HDL cholesterol and an increased number of atherogenic small dense LDL particles. Thus, therapeutic targeting of hypertriglyceridemia might provide further benefit in reducing cardiovascular event, and in addition to that, achieved with LDL cholesterol lowering. Now, hypertriglyceridemia is currently treated with lifestyle intervention and with fibrates in combination with omega-3 fatty acids. Now, what are the benefits of fibrates? Obviously, fibrates decrease the triglycerides up to 50% and almost 20% reduction of the LDL-C occurs. Fibrates have been found to be effective in reducing diabetes-related microvascular complications. It has certain side effects. And importantly, a meta-analysis from almost 18 trials with fibrate therapy with or without atherogenic dyslipidemia found that 13% relative risk reduction for any cardiovascular events, although no benefit on stroke, cardiovascular mortality, and risk of all-cause mortality was found. Now, certain lipid trials on fibrates, especially to mention the field and accord trial, if you can see the entire cohort, the CV reduction was not significant, but if we can see the lipid subgroup, the cardiovascular disease reduction was significant one, both in field as well as the accord trial. Now, is there any benefit of omega-3 fatty acids? It has been in market for a long time. Let's see what are the clinical evidences. The most important landmark trial is REDUCE-IT trial, which is a multi-center randomized double-blind placebo-controlled trial. And it has shown actually a decreased cumulative incidence of cardiovascular events. And the conclusion of the trial was, among patients with elevated triglycerides levels who were receiving statin therapy, the risk of major ischemic events, including cardiovascular death, was significantly lower with 2 grams of icosapentaethyl twice daily than with placebo. But the benefit occurs irrespective of the attained triglyceride level at 1 year, which suggests that there might be some other metabolic effects than the reduction of triglyceride levels for this risk reduction. Now, another important trial, which is more like a negative trial, is a strength randomized trial, where the participants were randomized to receive 4 grams per day of omega-3 carboxylic acid, that's the combination of icosapentaenoic and docosahexaenoic acid, versus corn oil. And the duration was around 41 months of the trial. And here the conclusion was, among statin-treated patients with high cardiovascular risk, the addition of omega-3 fatty acid compared with corn oil to usual background therapies resulted in no significant difference in a composite outcome of major cardiovascular events. Now, is there a triglyceride paradox which exists? Now, the triglyceride target should not be a very low one, because one study done in China with almost 3,000 patients, it was a single center cohort study to assess the association between admission triglyceride levels and long-term mortality risk in coronary artery disease patients found that the risk of all-cause mortality exhibited an overall rising trend as triglyceride levels decreased. Now, since the last decade, lots of society guidelines, they were in a dilemma whether to suggest therapy for mild to moderate elevated triglyceride levels. Some said yes, some said no. But finally, in 2019, European Society of Cardiology guidelines, they have clearly stated that statin treatment is recommended as the first drug of choice for reducing cardiovascular disease risk in high-risk individuals with hypertriglyceridemia that is more than 200 milligram per deciliter. Now, they have also recommended to evaluate the non-HDL cholesterol for risk assessment, particularly in people with high triglyceride, diabetes, obesity, or very low LDL cholesterol, and as well as ApoB analysis for risk assessment, particularly in people with high TG, diabetes, obesity, and metabolic syndrome, or very low LDL cholesterol. Now, both were class 1 indication. Now, regarding the treatment of hypertriglyceridemia, the ESC recommends statin treatment as the first drug of choice for reducing cardiovascular disease risk in high-risk individuals with hypertriglyceridemia with more than 200 milligram per dl. That is the class 1 indication. And the class 2 indication was in high-risk patients with triglyceridemia between 135 to 499 milligram. That is the mild to moderate hypertriglyceridemia patients, despite statin treatment. N3 PUFA, that is icosapent ethyl, 2 gram twice daily per day, should be considered in combination with statin. Now, they have also recommended the fenofibrate or bezafibrate in primary prevention, as well as in high-risk patients who are at LDL cholesterol goal with triglyceride level more than 200. Both were class 2B indication. But in 2021, ESC clinical practice guideline for prevention of atherosclerotic vascular disease, they actually they also stated that statin treatment is recommended as the first drug of choice, obviously the class 1 indication, but they have downgraded the indication for icosapent ethyl from 2A to 2B, and they have stated that in high-risk patients with triglyceride more than 135 milligram per dl, despite statin treatment and lifestyle measurements, N3 PUFAs, that is icosapent ethyl, may be considered in combination with a statin. As well as there is the indication of fenofibrate or bezafibrate, which are also to be given, may be given, considered in patients more than 200 milligram triglycerides. Now, what is the goal of the triglycerides? Now, ESC guidelines clearly states there is no goal, but less than 150 milligram per dl indicates a lower risk, and higher levels indicate a need to look for other risk factors. Now, to conclude, elevated blood triglyceride as an independent risk factor for cardiovascular disease, plasma TG should be assessed to identify people who may have a greater modifiable risk of ASCVD than is reflected by low LDL cholesterol, especially in persons with diabetes mellitus and metabolic syndrome. Lifestyle modification and statin are the preferred treatment, and addition of N3 PUFA and fenofibrate may be considered. Thank you for your patience here.
Thank you, Dr. Rai. I think, is there any question from anyone? They can ask just one question or two questions can be allowed. Time will not permit more than that. Any question from anyone? Is there no question? Is there any metabolic validity of TG paradox that is given by the Chinese literature? Is there any metabolic explanation of this TG paradox? Triglyceride paradox?
No, sir. No, sir. Basically, as the triglyceride, I think the main source of energy. So maybe because it is the most important reason for which actually the patients of this coronary artery disease with low triglyceride level during presentations, they have a worse outcome than the normal or increased triglyceride levels.
I mean, that's
as such of a metabolic. Yes.
It is not valid metabolic explanation. It is just a
no such valid.
That's why it was got proved later. So thank you, Dr. Roy. Very nice presentation. You have covered most of the areas. So we are moving to the next presentation, that is PCSK9 and lipid goal by Dr. Spandan Bhaduri. I request Dr. Bhaduri to go ahead with his presentation, please. Unmute yourself, sir.
Sir, I sent a request to unmute. Kindly
Yeah.
Yeah.
Am I audible and
Yes, sir. You are audible and visible. Kindly share your PPT, sir.
Yes.
Kindly select your PPT.
Oh, that I have already done.
No, you have seen only folder.
Achha.
So just click on share screen and select the PPT.
Yeah. Now is it visible?
Yes, open the presentation. Your screen is visible, but it is.
No, sir. If you select folder, we can see only folder. So kindly stop share.
Open the PPT now.
That I did. I did.
That means
Just
you
a
have
minute.
to minimize it.
Instead of selecting folder, select your PPT, sir.
Achha. Just a minute. Share screen.
No, sir. Again, you have selected the folder. It won't be visible, sir. It won't. Or else you can select a desktop. Either you can select desktop or PPT.
Why it is not coming? That
you close that folder, please, and open your presentation, minimize it, and share the desktop. You will see the presentation, minimize presentation below, and open the PPT there.
Or else you can select a desktop, first option.
Screen. Share Ashanatu. Let me open that PPT first. কি হচ্ছে কে জানে?
Topic of Dr. Roshan, and then we will come back.
Dr. Mondal,
I think we can go ahead to the next presentation first, then we will come back. Dr. Bhaduri, I am requesting you to open your presentation and try to share. We are going to the next presentation by that time. Assessment of cardiovascular risks in asymptomatic adult by Dr. P.K. Asakan. I will request Dr. Asakan to start his presentation now, please. Oh, already, yes, Dr. Asakan, you have shared your. Yeah. I will request the technical support team to off the video of Dr. Bhaduri and please bring up Dr. Asakan now. Technical support team,
sir,
you have to
kindly unmute, sir. Kindly unmute. Yeah, done.
Good afternoon to you all. Can you hear me now?
Yes, clearly audible.
Respected chairpersons, at the outset, let me thank Dr. Deepika Adhikari, the chairman of the scientific committee, the organizing committee, and scientific committee of CSA update, and the West Bengal chapter of the CSA for giving me opportunity to talk. I'll be talking on the risk assessment of cardiovascular risk assessment in asymptomatic adult. 90% of the patients with CAD have at least one atherosclerotic risk factors. Approximately 50% of all coronary deaths are not preceded by cardiac symptoms or diagnosis. Estimation of risk of occurrence of future events is an important step to lower this high burden of the coronary death in asymptomatic adults. You see the risk factors, the non-traditional risk factors or traditional risk factors, and major risk factors for coronary artery disease. The traditional risk factors outweigh the non-traditional risk factors. And if you see how to approach this risk assessment, first you identify the risk factors, traditional risk factors as baseline, lipid profile, and estimate the risk using a risk calculator. Identify any risk enhancing factor, and after that, estimate the risk based on the calculator. The first risk score was based on the Framingham Heart study in the year 1960. This is widely applied in most of the trials and guidelines and especially ATP3 guidelines, where the score is high. If its percentage of risk is over a period of 10 years, more than 20% considers high, and less than 10% low, and in between is intermediate. A pooled cohort equation, it is actually introduced by American Heart Association, ACC, in 2013, and is used in most of the guidelines. The main difference in Framingham and the pooled cohort equation is the inclusion of race, ethnicity, and diabetes to estimate the 10-year myocardial infarction death and from coronary artery disease or stroke. If it's less than 7.5% over a period of 10 years, is low risk. More than 7.5 is high risk. And most of the studies, all the countries, they have their own risk factors. Like say UK, they use these risk factor to calculate, and Western Europe, the score, where the systemic coronary risk evaluation is used. China, unfortunately, we don't have a risk score in India. Some studies are tried, but we don't have a definite risk score. And you see that is the ESC 2021. Where they changed the score. Initially 2012 is the score, now is the score 2 and score 2 OP. Score 2 OP means old persons. There's a different score. And score 2 is less than 75 years, the different score. This is based on systemic blood pressure, then the age of the person, non-HDL cholesterol, and history of smoking, and gender, male or female. Then the score is calculated. And is considered as a low score in a young individual if it's less than 2.5. The low score in an elderly individual above the 70 if it's less than 7.5. And similar way, it is a age is less than 70 and the risk estimation over a period of 10 years is more than 7.5%, it considers high score. And above the age of 70 years, if the score is more than 15%, it's required to consider. What is the difference? Here, there's a difference based on the age. The threshold of risk is actually increased as the age advances. Age itself is a risk for the CAD. So we'll avoid to overestimate the traditional risk factors elderly, try to overestimate the traditional risk factors young, intensify the treatment in young, and calculate the lifetime risk for the young people. That's the motto of this. If the patient age is less than 40 years, if there's a family history of premature disease, familial hyperlipidemia, juvenile onset of diabetes, or patient with multiple risk factors any age, or if you have done scanning, imaging, and if there's coronary score is present, then suggest atherosclerosis. These all concepts have very high risk in young age group. See, elderly, more than 75 years, limited data is available. See, old age group benefit from smoking cessation and control hypertension, hyperlipidemia is well known. But clinical judgment should be used to avoid side effect for over-medication, polypharmacy in elderly individual. And very important thing is elderly individuals are, usually they have some comorbid conditions. Non-CVD risk factor is competing for CVD risk, traditional risk factors in elderly. That's a very important point. So age-based scoring is introduced in 2021 guidelines, very clearly mentioned. See, this is what we have already discussed. Suppose the risk score is 10 in young individual less than 50 years. If you see this 10% elderly, about the age of 70 years, this comes under moderate to severe risk. But in a young patient, it is come under very high risk. So we're coming back to the risk categorization based on 2019 guidelines. If there is a documented atherosclerosis, there's no need to further stratify, it's come under very high risk. If there's a diabetes, target organ damage, and the long-standing diabetes 20 years, very high risk, and 20 to 10 years, it is a high risk only. If family hyperlipidemia, and if there's associated cardiovascular disease, come under very high risk, and without risk factors, as such family hyperlipidemia come under high risk group. And CKD, EGFR less than 30, very high risk, and 30 to 60 is high risk. And if you calculate the score over a period of 10 years and it's more than 10%, considers a very high risk. 5 to 10% is only high risk. So again, the repetition and diabetes already discussed, but I'll just summarize here, very high risk group based on eGFR. If it's less than 45 ml, irrespective of the albuminuria, that come under very high risk. But if eGFR is between 45 and 59, then you look for microalbuminuria, the albumin creatine ratio, or any proteinuria more than 300, or any involvement of the microalbuminuria, retinopathy, or neuropathy, come under very high risk group. What about the CKD? CKD, moderate CKD, come under high risk. Severe CKD is very high risk group. Familial hyperlipidemia, as such, is come under high risk group. So now we'll coming back to the recommendation for 2019, and it's very clear that for adult between 40 to 70 years, you should assess the traditional risk factors, and is based on the cohort equation. This is a class 1 recommendation. But there's a difference in European and the American guidelines as far as the age is concerned. And here the 20 to 39 years is a class 2, and every 4 to 6 years repeat estimation is advised. Systematic global assessment recommended individual with any of the risk factors presents a class 1. And what about the age? If it's male more than 40 and female more than 50, if there is no risk factors, that is come under class 2. And if we see the ESC, the latest guideline 2021, this is their Western Europe geographic areas where the score 2 is there considered. And if it's less than 75, there's no risk factor as a class 1 indication. And if above the age of 70 years, they go by the score 2 OP, and risk calculation is a class 1 indication. We already discussed here, and coming to the calcium scoring with a CT may be considered as a risk modifier in cardiovascular assessment, asymptomatic age, person at low or moderate risk. So coming back to the implication, initial step in ascertaining global score, family history is very important. Class 1 recommendation, and it's a simple and inexpensive. If patient is a low risk, no further testing is necessary. Similar way, if patient is already in high risk, and most important, that's intensify the preventive steps, no incremental benefit for further testing. Only in intermediate group, additional testing can further stratify the risk. So what are the tests we used? We are very clear that is already we discussed history taking, but genotyping is not recommended in all patients. Resting ECG is a class 2A indications if there is a diabetes, hypertension, otherwise a class 2B indication. Echo is not routinely recommended except in hypertensive patient to detect the LVH. And exercise ECG may be beneficial in mild to moderate risk group. And this angle breaking index is regularly not included in the risk stratification in the score, but is useful to assess the risk. And if you see the calcium scoring, it is indicated if asymptomatic adults, if the risk score is between 10 to 20% over a period of 10 years. But if the score is less than 6%, is not recommended. In high risk group also is not recommended. So routine CT coronary angiogram not recommended. So what are non-traditional risk factors? Current evidence is insufficient to assess the balance and benefit and harm of adding ABI, high sensitive CRP, or calcium score to the traditional risk assessment for CVD in asymptomatic adult to prevent CVD events. How often we should do the test? For 5 years, there is no hard and fast rule, but it's 4 to 5 years recommended. And if patient is less than 40 and 50 years, no risk factors, it's a class 3. As for the European, there's a difference in American, European here. So how to approach this patient risk assessment, decision making, estimate the first initial 10-year risk factors. If it's low risk, lifestyle modification. If patient is high risk, more than 20% risk, lifestyle modification drug is recommended. In borderline intermediate risk, what you have to do is risk enhancing factor look for, a net benefit, discuss the patient, a lifestyle modification drug, and if uncertainty exists, calcium scoring may be useful here. And this is a very important step. This is stepwise, individualized, tailored treatment as far as the ESC 2021. Now, all patients stop smoking, lifestyle modification, systolic blood pressure reduction less than 160 is recommended. It's based on the age. If age is less than 50 years and the low risk, no additional prevention is recommended, additional treatment recommended. But patients high to moderate risk, then first step is to lower the risk and see that the BP, systolic BP is 140 and the LDL cholesterol is 100. And at this stage, look for a residual risk. If it persists or exists, then we can further intensify the treatment based on either score 2 and look for lifetime risk factor and any comorbidities and discuss with the patient preference. And this class 2A, 1, if you reduce the BP further to 130, if tolerated. And if patient with very high risk or very high risk, this can be LDL cholesterol can be reduced to less than 70 or 155, that's class 2B. And you come to the age group more than 70 years, if patient estimated risk is less than 7.5, no additional treatment preventive goal is required. If patient is 7.5 to 15, then the reduction of the risk to 140 systolic BP and LDL cholesterol is 100. Whether to reduce further, that is depends upon specific risk factor and you to individualize. And using a statin to reduce the LDL cholesterol to less than 100 is a class 2A recommendation in elderly. And you have to consider here polypharmacy and the patient preference. So, ladies and gentlemen, let me conclude. This prevention guideline proposes a new stepwise approach to treatment intensification. Acts as a tool to help physicians and patients pursue this target in a way that fits patient's profile and preference. Tailored intervention on an individual level. Structured national program aiming to identify underdocumented atherosclerotic cardiovascular disease risk factor in adult over 40 years without diabetes or disease treatment them shown better risk factor control. Younger currently appear in a healthy subject. Lifetime risk assessment available to support treatment decision, replacing the 10-year risk. Young adult, yet always you to consider lifetime. Then take home message, assessment of cardiovascular risk in asymptomatic adult is the need of the hour. In the current era of evidence-based medicine, all decisions need to be based on robust scientific evidence, not on personal preference. The assessment of risk for development of clinical manifestation, atherosclerotic CVD is designed to aid the clinician in informed decision-making about lifestyle, pharmacological intervention to reduce such a risk. Thank you.
Thank you, Dr. Asokan. I think we are already over time. Any comment can be allowed by the time Dr. Bhaduri gets ready. Any comment from anyone?
Thank you. It was an excellent presentation. But one thing I want to make sure, while all the risk factors took into consideration major cardiac event risk, the score risk factor considered fatal outcome. What is your opinion on that? Framingham, ACCHA cohort, JBS2, all considered major cardiac event as the final risk. But score
Dr. Asokan, please stop sharing your screen.
Yeah, stop sharing. I'll miss. Yeah, done. Done, sir.
Are you ready?
A question has been thrown by Dr. A.L. Doctor that the most of the guidelines they have taken as the fatality as the outcome. All guidelines depend on fatality. Can it be due to development and progression of atherosclerosis? All guidelines. Score 2 and Score 2 OP has highlighted this area regarding not on based on only fatality, but also on progression of atherosclerotic plaque and development of plaque also. That's why this score in young age, that is Score 2, is applicable to teenage also. That means your query regarding most of the guideline taking as a fatality as the outcome is not in scope 2 and scope 2 OP. It is also taken into account the development of atherosclerotic plaque and also progression of atherosclerotic plaque, not only events.
Correct. Agreed.
I think I'm clear from that point. This scope 2 and scope 2 OP has given a advanced role of this assessment. I think that has been highlighted by Dr. Asokan also. And we'll go, thank you, Dr. Asokan. We'll move to the last presentation of this session, that is PCSK9 and lipid goal by Dr. Bhaduri. I think he's ready. His slide is already in the screen.
Thank you.
Dr.
Am I audible?
Yes, sir. Yes, sir. Go ahead.
Thank you very much, Chairperson, sir. And I must thank the organizer for asking me to discuss the issues of dyslipidemia control, targeting the goals with the aid of PCSK9 inhibitors. We know that the use of PCSK9 inhibitors is at its toddler stage at best, or infancy rather, in some cases only at toddler stage. So we'll discuss with the following agendas: that residual risk after statin, PCSK9 inhibitors physiology and mechanism of action in short, the two pivotal trials, Fourier and Odyssey outcome trial, and some guidelines regarding the goals and indications. Now, in real world data, we know that most of the patients, even of the best of statin use, do not achieve the LDL goals, and to the tune of say 60 to around 80% of people do not achieve the desired target LDL goal of less than 70. And that is so even after use of ezetimibe along with high intensity statin, only around say 14% for people with LDL cholesterol 100 to 129 and 7% for more than 130 milligram of LDL at baseline achieve the target. So the incidence of incident major cardiovascular events are always significant, and that is proved it TIMI, IDEAL, TNT, so-called the high intensity statin trials. So what should we do in the next step? And for that, in that connection, what is PCSK9? It's a protein that regulates cholesterol metabolism. It's a family of enzymes involved in converting precursors of secretory proteins, such as hormones, enzymes, receptors, into bioactive molecules at their intended target tissue. These enzymes are part of regulatory pathways that help the body to maintain homeostasis. It was PCSK9 was first described in 2003. Its active form PCSK9 regulates cell surface receptors, in particular the LDL receptors. It is encoded by the concerned gene primarily in the liver. And PCSK9, while on being attached to the LDL receptors, internalizes it and aids in co-destruction of these LDL receptors along with LDL within the hepatocytes. PCSK9 mediates degradation of the LDL receptors. It is highly expressed in liver, small intestine, and kidney. Now coming to these inhibitors, these are monoclonal antibodies which target and inactivate these PCSK9 molecules, proteins in liver, and dramatically decrease the LDL cholesterol concentration. And this is a science which rapidly progressed from discovery to bedside, from the bench to bedside. In this early 2003-4, this gene itself was described. The 2004 to 2010-11, the animal experiments were done, and 2017-18, the two major cardiac outcome trials are published, and the molecules are listed and suggested in the guidelines. So when there is PCSK gain of function mutation, there is less LDL receptors, so high LDL concentration in body. And when there is PCSK9 loss of function mutation, there is more LDL receptors in the hepatocytes and less LDL in the body. That is what we learned from the genetic studies. Now we know from this ATP3 onward, this study of different clinical studies, that lower the LDL is better. So we have to lower it down with when the goal is not achieved. We have two PCSK inhibitors in hand, alirocumab, that is Praluent, Sanofi, and evolocumab, that is Repatha, Amgen. Evolocumab, that is Repatha, is marketed in India too. And these are the two approved by FDA and available for clinical use. And there are a host of these so-called clinical trial and programs conducted before these molecules came into market. With this alirocumab, these ODC programs were done, and with evolocumab, these Laplace, Mendel, Gauss, and these are host of studies done. Most important is Fourier from this clinician's point of view. This alirocumab and cardiovascular outcome trial was the ODC outcome trial. This trial is also conducted. Both the trials are also partly conducted in India too. In this ODC outcome trial, patients who have had an ACS at high risk within 12 hours for recurrent ischemic cardiovascular events, it was sought to determine whether alirocumab would improve cardiovascular outcome after an ACS with lowering of this LDL beyond this high intensity statin therapy. It included 18,000 patients with abnormal lipids on maximally tolerated statins. And of this population, 30% were diabetics. And goal of trial was an LDL between 25 to 50 milligram of DL. And this is the result that as against placebo, this alirocumab provided a significant reduction of LDL level even within 4 weeks of randomization, and more than 60% reduction of LDL and more than around 66 milligram absolute reduction of LDL from the baseline. So median follow-up of the study was 2.8 years, and the LDL achieved was 53.3 milligram in patients, and this compared with 101 in placebo arm. The incidence of adverse event was similar and not significant, with the exception of local injection sites pain. So this molecule resulted in a reduced composite primary endpoint of first occurrence of coronary heart disease death, non-fatal MI, unstable angina, recurring hospitalization or ischemic stroke of 9.5% as against 11.1% with an hazard ratio of 0.85. That is 15% clinical reduction. And this study equaled the benefit achieved in Osler's trial, another trial done with evolocumab. Now comes this Fourier trial, further cardiovascular outcome research with PCSK9 inhibition in subjects with elevated risk. This Fourier trial included total 27,000 patients, out of which 40% were diabetic, were on maximal statin therapy, and median trial period was again 2.2 years, and it similarly reduced the primary composite endpoint of CV death, stroke, MI, hospitalization, or coronary revascularization in both diabetics and non-diabetics to the range of this 17% to 13%, which are statistically significant. Importantly, the trial showed no increase in new onset of diabetes or glycemic derangements with the use of PCSK9 inhibitors. So this is the summary of effects, that the LDL reduction was 59% with a median of 30 milligram per DL. CV outcome were reduced, and it was safe and well tolerated, and the benefits were statistically significant with a hazard ratio of around 0.85 for CVD, MI, stroke, there's primary endpoints. So in Fourier, for singular endpoints at 26 months, very tight lipid control reduced the risk of MI by 27%, stroke by 21%, and coronary revascularization by 22%. A sub-study of this trial was also done because this study achieved a very low LDL level, whether it has something to do with the cognition of this function of brain, because these lipids are very important for brain function. This Ebbinghaus trial was studied to assess this, and it showed that as against placebo, evolocumab had no difference in this outcome as far as this cognition endpoints are concerned. Similarly, a sub-study of this Fourier was done, Glagop, which assessed the plaque regression with PCSK9 inhibitors, which also showed that it achieved significant, that is statistically significant, this plaque regression in a subset of around 484 patients as against equal number of this placebo patients. So in statin-treated patient with symptomatic coronary heart disease, addition of evolocumab 420 milligram monthly for 18 months achieved this LDL cholesterol averaging 36 milligram per DL compared with 93, produced regression, mean change of platelet atheroma volume was significant, which is p-value significant to the less than 0.001, and induced regression of greater percentage of patients, 64% as against 47%. Now coming to the goals, because the topic is actually two topics now. Goals regarding this treatment of LDL, my job is made easy by the previous speaker. The American College of Endocrinologists, they stratify these all patients into two groups, that is two higher risk group, that is extreme risk and very high risk, where the treatment goal of LDL is below 55 for extreme risk and very high risk for less than 70. And here on only this PCSK9 inhibitor should be considered for use in combination with statin therapy for LDL cholesterol lowering in individuals with familial hypercholesterolemia and very high risk patients. And they have given the doses also. For aliricumab to start with 75 milligram every 2 weeks subcutaneous, followed by up titrated to 150 milligram. And for evolocumab, there is no up titration. You either start with 150 milligram every 2 weeks or 420 milligram once monthly. Regarding this ADA guideline is also stating that if LDL cholesterol below 40 years or above 48 years, if LDL cholesterol is more than 70 milligram despite maximally tolerated statin, consider adding additional LDL lowering therapy such as ezetimibe or PCSK9 inhibitors. But here the ezetimibe use at first is mandatory for this so-called co-pay requirements. Coming to this AHA guideline, again, they have more or less similar recommendation in patients with clinical ASCVD who are judged to be very high risk are considered to be PCSK9 inhibitor therapy. That is class 1 recommendation. And these very high risk ASCVD patients who are on high intensity or maximal statin, this if PCSK9 is considered, add ezetimibe first to maximal statin before adding PCSK9 inhibitor. That is the GIST recommendation, because first we have to try with ezetimibe to see that whether the LDL desired goal is achieved or not, then only this PCSK9 inhibitor can be added. Now coming to this 2021 ESC guideline. In ESC guideline for this prevention of ASCVD, they have recommended class 1 indication for ASCVD, patients with established ASCVD, lipid lowering treatment with an ultimate goal of below 55 milligram per DL, and if more than 50% reduction in LDL cholesterol versus baseline. And that can be done if not with statin or plus ezetimibe with PCSK9 inhibitor. For secondary prevention, patients not achieving that goal on maximum tolerated dose of statin ezetimibe, combined use of PCSK9 inhibitor is a class 1 indication. In patients with diabetes with very high risk and intensive lipid lowering therapy, we have to aim at more than 50% LDL reduction and LDL absolute goal of less than 55 milligram per DL. Then in patients with established ASCVD, lipid lowering treatment with an ultimate LDL goal of more than 50% reduction versus baseline and absolute level of less than 55 milligram is recommended for patients up to 70 years of age. Beyond 70 years of age, the recommendation is same. That is for secondary prevention, that PCSK9 inhibitor is recommended, and that is again a class 1A inhibitor. I am not discussing the familial hypercholesterolemia today. Now coming, this is my.
Please try to conclude, Dr.
Yes,
Bhaduri.
yes. This is the last. That this is our own guideline. That is Lipid Association of India guideline 2020. Here, the important change from the so-called international guidelines is that our target is 50. That for very high risk group, LDL cholesterol goal is less than 50. And there is one extreme high risk group, category A and B. This category A is this established CAD, diabetes, familial hypercholesterolemia, LPA more than 50, etc. But extreme high risk category B is that already established coronary artery disease with diabetes or with polyvascular disease or recurrent ACS or associated with homozygous familial hypercholesterolemia. This LDL cholesterol is 30. This is one guideline where officially they have recommended below 30 is the target. No other guideline has given this such strict target. So these are the probable level of reduction of LDL with different options available. Thank you very much for patient hearing. Thank you very much.
Thank you, Dr. Bhaduri. I think it is a very nice presentation, elaborate, and it has been, now the guidelines have been tested multiple times. So I think we should conclude the session because it is I think that it should not be any questions because it has presented so nicely. So we are concluding this session with this. I'll hand over this to CSI head office again to proceed for the next session. Thank you all. Thank you.
Thank you, sir. Thank you to the speakers, the moderators, and the chairperson for enlightening us with this topic of lipidology. Our next session will be on valvular heart disease, and the speakers of the session are Dr. Rothindranath Kormokar, Dr. P.K. Hajra, Dr. Bhuvan Majhi, Dr. Lipika Odhikari, and Dr. Shubhro Banerjee. The session will be chaired by Dr. H.S. Pathak, Dr. Sunil Baron Roy, Dr. Torun Prohar Raj, Dr. Shomik Basu, and the session will be moderated by Dr. Arnav Roy, Dr. Anil Misro, and Dr. Shaumo Patro. May I now request the chairpersons to take over?
There is a correction. Dr. Shubhro Banerjee has a separate session. That is a grant by wearing that. He is not part of this session. In this session, we have only 4 speakers. So, Rothindranath Kormokar, P.K. Hajra, Bhuvan Majhi, and Dr. Steve. Vashish.
Sir, we are ready to start the session.
Please start.
The session of heart disease. Please, chairperson, sir, please start this.
I think there is some technical glitch. I call on Dr. Rothindranath Kormokar. Dr. Kormokar, are you there?
Yes, sir.
Yeah, please start your presentation.
Is my screen visible?
No, it is not visible.
It's not visible. You can see.
Now it is visible. Make it full screen.
Okay. Yeah. Is it okay?
Okay.
Oh, okay. Okay. Thank you. At the outset, I would like to thank West Bengal CSI for inviting me for this talk. The era of TAVI started with Dr. Alan Kleber being the first person to implant a transcatheter aortic valve in a 57-year-old gentleman with severe AS who presented with a cardiogenic shock. The Western world has witnessed the enormous rise in the cases of TAVI, trans-aortic valve implantation procedures for the last decade, and presently it has surpassed the number of surgical aortic valve cases in the Western countries. Along with this, the population which are going to be benefited with this procedure has also changed, also evolved over time, from the highest risk of people in the elderly population to include the lower risk and younger population, younger patients. During the last 2 decades, the treatment of degenerative aortic valve stenosis has undergone a tremendous evolution. A rapid adoption of TAVR was observed with a continuous decline in the mortality risk. Technological advancement, procedural simplification, as well as reproducible results in large studies has resulted in has transformed the treatment of these patients. As a result, it enjoys the Class 1 guideline recommendation for its use in symptomatic patients with increased surgical risk, and newer guidelines are including the lower risk population also. So at the point of time, TAVR is established and considered a standard procedure with high rates of procedural success and low rates of peri-procedural complications. The evidence base behind the TAVI initiated with the partner and core valve trials, which are performed in high and extremely high risk surgical risk population, and thereafter it extended its boundaries to the intermediate surgical risk group, with the evidence base being partner and SATA-V, and now it has encroached into the domain of low surgical risk group also, with chiefly 2 studies. One is partner 3 and second is evaluate low risk trial. Partner 3 was performed with a balloon expandable valve, and evaluate used the self-expanding valve. But before these 2 landmark studies, there was another relatively smaller trial, namely the Notion, which was actually an all-comers trial, which showed at the end of 5 years there was the TAVI was in non-inferior to surgical aortic valve replacement, and when the sub-study was done in population with the low surgical risk, it was shown the results were favoring TAVI. With this, after this Pioneer is a partner 3 study was designed, when where almost 1,000 people were included in this study who were having low surgical risk, and they were randomized to either TAVI or surgical aortic valve replacement. They included all the severe calcific aortic stenosis cases who were having at least class 2 functional status, abnormal exercise test, or having LV dysfunction. The technological improvement has gone up from the initial landmark partner 1 trial, which was conducted in 2011, to Sapien 3, that 3rd generation valve, with the improved valve technology, sheath compatibility, and a wider range of available valve sizes. The primary endpoint, which was a composite of death, stroke, and rehospitalization, was significantly lower in the TAVI group, and this finding was also observed in individual parameters of these composite endpoints. That was similar reduction in the death, isolated death, stroke, and rehospitalization in favoring TAVI. And a recent publication where a 2-year outcome of this study was evaluated, and it has been shown that the benefit favoring TAVI is extending till 2 years of 2 years of therapy. So the partner trial concluded that the population with severe symptomatic aortic stenosis who were at low surgical risk, where TAVI were using the TAVI where the Sapien 3 valve was used, it reduced the primary endpoint of death, stroke, and rehospitalization to 46% at 1 year. The other study, which also included about 1,400 patients, and it randomized to either TAVI or surgical procedure. It included almost the same kind of population, but additionally, it also included asymptomatic, very severe cases. That is where the mean gradient crosses more than 60 millimeter mercury. The valve which was initially used in this study was changed during the study period. Initially, the core valve was used, core valve. Thereafter, Resolutor and later Evolute Pro was used. Here also the primary endpoint were met, and TAVI was found to be non-inferior to surgical procedure, and all the individual components of the primary endpoint was also favoring TAVI. So the study concluded that TAVR may be a preferred strategy to surgery in patients with severe aortic stenosis at low risk of surgical mortality. In a meta-analysis thereafter, which encompassed all the patients across the spectrum of surgical risk, it carried the message that compared to surgical procedure, TAVI is associated with reduction in all-cause because as the spectrum encroaches to the lower risk population, the concern of durability of the valve, because younger the patient, the longer the patient is going to survive. So durability, along with other issues like aortic regurgitation, patients with bicuspid aortic valve, later coronary access, for those patients who are having concurrent coronary artery disease or who may develop later coronary artery disease, the coronary access remains one concern, along with other issues. So the research is going on globally to explore all these gray areas. Along with this scientific evidence growth, the guidelines are also evolving, and starting from the extreme to high risk in the both American and European guideline, it is gradually encroaching the lower risk zone also, and very likely that it is going to include the low risk population very soon. In near future, the dry leaflet technology and dedicated motorized deployment mechanisms are being evaluated in patients with this aortic stenosis, and their clinical application is being evaluated with different studies. Another one study which including the patients who are absolutely asymptomatic severe aortic stenosis, the early TAVR trial is going on. Another study which is also being done in moderate aortic stenosis with LV dysfunction, that is TAVR unload trial. These studies will further increase the number of people, the number of patients who are going to be benefited with this procedure. So to conclude, during the last decade, TAVR technique and technology have continuously improved, making the procedure a safe and effective treatment for most of the patients. TAVR will continue to gain significant popularity among patients with aortic stenosis, and it is expected that patients' volume will grow exponentially. In near future, TAVR is very much likely to become the treatment of choice for patients with single aortic stenosis, and TAVR may be considered a complementary alternative for these patients who are not candidate for TAVR. Thank you for your patient hearing.
Thank you, Dr. Kormukar, for your lucid presentation. Our next speaker is Dr. P.K. Hajra, who is famous for his various innovative interventions in India, and he will be talking on importance of imaging to combat the complications of TAVR. Over to you, Dr. P.K. Hajra.
Thank you, Dr. Deepika, for giving me a chance to speak. If you go to the history of cardiology, there are many innovative things has been developed for the benefit of humanity, starting from the catheter to the valve, to the wire, to the device, and etc. Now, as my previous
sorry, sir. I think there's a mic problem. Can you remove your headphone and
okay,
try,
okay,
sir?
I'll do that.
Sorry.
I'll do that.
can you hear me now?
Yes, sir. Perfect.
Okay. So the many innovative technologies has been evolved for the benefit of humanity, and we have TAVR for the first time in human. In animal, it happened long time ago, before 2002, but we do not remember that man, but we do remember Dr. Alan Crebier for his novel work. And when he exchanged with a man from US, that was none other than Martin Leon, and this telephonic exchange has told us that that particular patient was very high risk, the sheath was larger. Anytime any complications on 10% ejection fractions with a systolic BP of 60 millimeter, intra-LV thrombus, imminent death is going to come if you do not take care of the complications of the TAVR. Now, Martin Leon has suggested something, and he said, let's go ahead with the valve implantations. Since then, the complication is an issue. Now look at this 91 years Henry Kissinger, who was Nobel Peace Prize winner. And on the other hand, my favorite singer, Mick Jagger, at the age of 75, both had calcified iliofemoral arteries, severely calcified aortic valve, but both are living and both are doing well. And both had TAVR in New York. Even Arnold Schwarzenegger, who had a Ross operation in 1997 for bicuspid aortic valve, then he had this pulmonary valve displacement in the aortic positions. And later, 2020, he has undergone aortic valve replacement. So huge body weight and very large size and obesity is a problem for access and its complications. So access evolution is utmost important part in the pathway of implanting TAVR successfully. Implantation is very easy nowadays, and it has come to such an extent that you can compete with the surgeon if you can produce a good result without any complications. And most of the time, it is a vascular access complication that can kill a patient, and that can give rise to mobility. And the Braunwald said this is a historic moment, and all of us here should remember it as such, that even in normal patients, this can be done when the risk is low, and you can compete with the surgeon if you do not produce any complications. Now with time, the CT scan has evolved from a thin cut to a 3D reconstructions of the aortic valve. So you know where the coronary sinus are, height of the coronary arteries, and as well as you'll get to know the coronary anatomy, whether he needs additional coronary angioplasty, revascularations in the form of a stent or any other means where the compromise on coronary circulation can be minimized. So 3D printing with artificial intelligence can tell you if you have a co-registration or fusion imaging facility in your lab. Most of the time, last few cases, we have an experience of having balloon expandable, self-expandable, Edward, Medtronic, and Merrill in our lab. And most of the time, in the 2 days back, we have done under local anesthesia, fluoroscopic guidance, and a simple echocardiography at the bedside can tell you what are the complications you can develop during implantations. Now, sometimes these complications are devastating. So it will tell you whether you have developed perforations, whether you have developed aortic regurgitations, perivalvular, intra-device, or any other complication which can be tackled by yourself, or you can call a surgeon who is standing by. Now, many times these patients do develop complete heart block, especially if you have a right bundle branch block to start with, and LVOT calcification is of utmost importance, which can give rise to complications, and pushing this calcium towards the conduction system can give rise to complete heart block. So temporary pacemaker is not only for your rapid pacing, most of the time this is not required in self-expandable valve, but in balloon expandable, it is mandatory. but also very much required if you develop a complete heart block or asystole during implantations. So this echo can tell you what size of the LVOT, the morphology of the LVOT, and that can predict the complications like a conduction system block or conduction system delay. We nowadays do not use the term block because there is no block. It is the delay of the left bundle branch, the delay of right bundle branch, and it can recover. So the delay, which is temporary, can recover later on. So CT assessment is most critical part of the TAVR: device size, balloon size, pre-dilatation, calcium, bicuspid valve or not. And it accuracy so much, it can go into some millimeter level, and it is reproducible, and it can be circulated throughout the world. So you can have an opinion from the globe, who is the expert, by digitally transferring these investigations for the experts. If you are not comfortable with yourself, you may not need a proctor if you have an opinion from the global leaders. So minimum, maximum, mean diameters, perimeters, area derived diameters, all these are available on the modern CT scan software. So in our lab, in our hospital, we have a special software. And once you tell this patient should undergo TAVR, they have a protocol to follow. So we don't have to do anything. The software will tell us what size of the valve, so that it does not produce annulus rupture, and it tells you how much volume, extra volume will take in Edward, so on and so forth. Whether there is a chance of protecting the coronary, just keeping a stent in the left main, and the annulus angle or implantation angle is done only by CT scan, the Caspar view. No other imaging modality. Even if you have raised creatinine, MRI cannot replace that information which we obtain from the CT scan. We also, when you traverse the ascending aorta, the calcification, the flexions of our Edward sheath or your Merrill sheath or your Medtronic Edward sheath is of utmost importance, because most of the time we are not doing TAVR with Sentinel carotid protection device. So any scratching on the ascending aorta can give rise to stroke. So these hits can be reduced if you have prior knowledge of the morphology of the ascending aorta, and CT scan is the best modality to prevent this. Now, if you do not have an alternative access, if you do not have a femoral access, you can go for alternative access. So if you are going from the left, you also know whether lima is there, the lima compromise in CABG, the angulations, if you have a vein graft, if you're going direct into the aorta, you know where from the vein grafts are arising. So this final puncture on your aorta is determined by previous CT scan imaging. So pre-TAVI imaging is done only and only by CT scan. Nothing can replace CT scan. And these are very important part of your initial TAVR learning. And rest of the things you can calculate on the basis of the dimension the CT scan gives you. As I said, some of these are turned down cases because of severe LVOT calcium on CT scan, adverse aortic root, poor transfemoral access, anomalous coronary 5%, and high risk. And we cannot do any kind of imaging in valve. So bicuspid valve, they have different morphology, which is 30% in Asian Chinese populations, and also in other forms, like if you have valve in valve, if you do not have the previous information of the surgeons, the type of tissue valve, the ring, this valve in valve software can give you some idea, but that also depends on the feedback from the CT scan software. So this previous anatomy, altered anatomy, and you know that RVOT is important, this membranous septum is important. If you heart there, it can produce VSD. If you heart the conduction, it can delay the conductions. And that's why we want to know that the deeper implantation of the valve can give rise to block. So sometimes you have to go for a 0, like last case we did 0, sometimes 50-50. So those information cannot be obtained by anything other than CT scan. So the CT scan is of utmost importance, and the sheath size, has come down. But if you have a smaller iliofemoral vessels, or if you have a tortuosity of the vessel, even if your this sheath which is expandable, like Edward sheath, can give rise to complications like intimal tear, perforation. So prevention is the best. And if you see this, always go for an alternative access. But in our institute, so far the cases we have done is from femoral root. So to finish with, a good case can be done by apprehending the complications, planning the TAVR program, sitting with the surgeon, sitting with the radiologist, and take care of the patient as a total, from the vascular access, the ultimate implantation of the aortic valve. The calcification is the dangerous enemy of any interventions, but sometimes it is much more forgiving to have calcium in the valve rather than calcium in the aortic or iliofemoral artery. So calcium is good to some extent for implantation, holding the valve in the aortic position. Without calcium, the valve holding or dislodgement of the valve is very high, but that same calcium can give rise to complications. Now we have intravascular lithotripsy also. The shock wave therapy can overcome these complications at the iliac level. So giving shock wave therapy or IVL in the iliacs can solve certain complications. The things are getting better, and I'm sure with newer understanding, newer imaging, the complication will come down further, so that it is kind of therapy for everyone. With that, I'd like to thank for your kind attention. Thank you.
Very informative presentation by Dr. Hajra. Let us invite a few comments and questions.
We can move on to the next talk if there is none.
Okay, okay. So let us invite the next speaker.
Next speaker is Dr. Bhuban Maji, and he will be talking on functional MR current status in management. Dr. Bhuban Maji, over to you.
Am I audible? Whether the screen is visible or not?
No, sir. Kindly share it. Screen is not visible. You have to share it. So you can able to see bottom center share screen option, sir, in a green icon.
Yeah, I am seeing it.
Just click on it.
Okay.
So you will get another. Yeah. Now it's open. Now it's shared.
Okay. So good afternoon, everybody. Respected chairperson and the learned audience. My topic of presentation is current management of functional MR. Next slide. There it is moving. It's not moving. The slide is not moving.
Yeah, no, it's moving.
Yeah,
Sir, moving.
now it's moving. So heart failure is a growing epidemic with an estimated 6.2 million adults affected between 2013 and 2016 in the US. Mitral regurgitation is common in heart failure patients, especially in those with ischemia, left ventricular dysfunction, or dilated cardiomyopathy. MR in the absence of structural abnormalities of the mitral valve complex is called functional or secondary MR, as the problem lies with the ventricle. So SMR is the most common form of MR, and in 2001, its prevalence was reported to be around 16,000 patients per 1 million in the US population, a total of 5.2 million people. The etiology can be multiple. They are usually related to the etiology of heart failure. The etiologies include the tether leaflet due to ischemic cardiomyopathy, dilated LV annulus secondary to severe LV dysfunction and long-term LV ischemic cardiomyopathy, dilated annulus from dilated non-ischemic cardiomyopathy with a similar mechanism as the previous etiology, papillary muscle dysfunction related to acute or chronic ischemia secondary to coronary artery disease, dilated left atrium can result in a dilated mitral annulus and SMR. So functional MR is one of the many components of the heart failure syndrome, which are ischemia stunning, hibernation, fibrosis, dilatation remodeling, atrial fibrillation, left ventricular dysynchrony, malignant arrhythmias, neurohumoral derangement, and obviously this functional MR. So pathophysiology includes either increased tethering force or decreased closing force or altered mitral valve function. The diagnosis includes echocardiography, obviously is the gold standard, apart from the clinical examination, which often can miss the low-pitched secondary mitral regurgitation. According to the American Society of Echocardiography, severe MR is consistent with vena contracta width more than 0.7 centimeter, effective regurgitant orifice area more than equal to 0.4 centimeter square, regurgitant volume more than equal to 60 ml, and regurgitant fraction more than equal to 50%. The severity of MR, we all know, moderate or severe, 3+ is effective regurgitant orifice area 0.3 to 0.39 centimeter square, regurgitant volume 45 to 59 ml, and regurgitant fraction is 40 to 49%. If there is discrepancy between the echocardiography and the patient presentation and physical examination, other modalities such as transesophageal echocardiography, cardiac MR, left ventriculography can be used to determine SMR severity. In the management of functional MR, a multidisciplinary SMR treatment is the standard practice today. The first is obviously guideline-directed medical therapy, that is GDMT, followed by in the patients who are eligible for CRT, in those CRT, and in those patients in certain population there is transcatheter intervention, and in certain obviously where there is ischemia, there is CABG plus minus MB repair replacement, and in the end stage patients often LVAD and heart transplantation. So first, the guideline directed medical therapy in heart failure with reduced ejection fraction, we all know it. That is the ACE inhibitor, ARB, beta blocker, diuretics, as is needed. And we have to add on aldosterone antagonists in open the ARNIs, hydrogen nitrate, in the eligible patient ICD, in those with QRS duration more than equal to 150 millisecond and LPPP pattern of ECG, ejection fraction less than equal to 35%, CRT, and heart rate, where the heart rate is not controlled, we have to add ivabradine, or where the maximum, after the maximum tolerated dose of beta blockers. Now, the transcatheter treatment of the valves of functional MR, the innovation trigger was given by the Everest 2 trial, and we had peak of inflated expectation. However, the MITRA FR trial, we had throw or disillusionment. However, with that, next, there is slope of enlightenment with the co-op trial, and obviously plateau of productivity with RESEP heart failure 2 trial. The echocardiographic inclusion criteria in the co-op trial was secondary MR grade 3+ or 4+, graded by one of 3 criteria: left ventricular ejection fraction 20 to 50%, left ventricular end systolic diameter less than equal to 70 millimeter, and patients with estimated systemic pulmonary arterial hypertension more than 70 milliliter of mercury or severe RV dysfunction were excluded. So affected regurgitant orifice area more than equal to 0.3 centimeter square or pulmonary vein systolic flow reversal are included, or affected regurgitant orifice area 0.2 to 0.29 centimeter square with any one of the following, like regurgitant volume more than equal to 45 ml, regurgitant fraction more than equal to 40%, or vena contracta width more than equal to 5 millimeter. And in certain patients where affected regurgitant orifice area is less than equal to 0.2, with at least 2 of the following: regurgitant volume more than equal to 45 ml, regurgitant fraction more than equal to 40%, vena contracta width more than equal to 5 millimeter, and peak E velocity more than equal to 150 centimeter per second, or PISA radius more than 9 millimeter, or large more than equal to 6 millimeter hollow systolic jet wrapping around the LA. Now, the trials of transcatheter mitral valve repairs are MITRA FR, co-op trial, and RESEP heart failure 2 trial. In all these trials, functional class 2 to 4 and heart failure hospitalization within last 12 months were included. Left ventricular ejection fraction were between 15% to 50%. In different trials, SMR severity, I have already told, and the intervention obviously by MITRA TIP in all these trials. In MITRA FR, around 300 patients were taken. In co-op trial, 614 patients. For a RESEP heart failure 2 trial, 650 patients are going to be included. The primary endpoint In mitral effort trial was death, heart failure, hospitalization at 12 months. In co-op trial, it was cumulative heart failure, hospitalization at 24 months. So it was also mortality. And RECEPE heart failure 2 trial, cardiovascular death and recurrent heart failure hospitalization during follow-up. Now this is mitral effort trial. We saw that there is no improvement between the control group and interventional group as regard to the heart failure hospitalization and mortality. The composite primary endpoint outcome, death from any cause or unplanned hospitalization for heart failure at 12 months, was almost similar, and p-value was not significant in the mitral effort trial. The functional class between the medical therapy group and the percutaneous intervention group was also not significantly different between the two groups. In the co-op randomized trial, we already know 610 patients at 78 sites were taken, and they were randomized 1:1 to either mitral clip or control group. The primary endpoint was recurrent heart failure hospitalization through 24 months. And in the co-op trial, there was local site heart team. The central eligibility committee, independent education committee was not there. There was data safety monitoring board, independent echocardiography core lab was not present, which was present in mitral effort trial. And enrollment was between December 2012 and June 2017. The result of the co-op trial was, however, completely different from that of mitral effort trial. It showed that all heart failure hospitalization was reduced and all-cause mortality was reduced by around 17%, and the relative risk reduction was to the tune of 40%, all-cause mortality. Now about surgical treatment, cardiothoracic surgical trials network shows that 2 years outcome of surgical treatment of moderate ischemic MR, which has taken 301 patients of multivessel coronary artery disease plus moderate ischemic MR, was randomized to 1:1 to CABG alone versus CABG plus mitral valve repair. Follow-up was for 2 years. However, this did not show any benefit with regards to death or major adverse cardiovascular and cerebrovascular events. The 2-year outcome of mitral valve repair versus replacement of severe ischemic MR by the cardiothoracic surgical trialist network, however, showed that recurrence of moderate to severe MR was reduced with mitral valve replacement. However, there is no significant difference with regard to the hazard ratios in regards to the MACE. So the utility versus futility of mitral clip procedure according to severity of MR and LV systolic dysfunction, we can see that if there is moderate to severe MR, effective regurgitant orifice area more than equal to 30 millimeters square and regurgitant volume more than equal to 45 ml, along with mild to moderate LV systolic dysfunction, that left ventricular ejection fraction more than equal to 20%, and left ventricular end systolic dimension less than equal to 70 millimeter, where mitral clip is useful. In the other situation where the left ventricular systolic dysfunction is much more, that is LVF less than 20%, or left ventricular end systolic diameter is more than 70 millimeter, or there is mild to moderate MR, the mitral clip is futile. So the reduction in all-cause mortality with current therapies for heart failure shows that mitral clip has the highest reduction in mortality, around 40%, along with the other guideline-related medical therapies. It is the relative risk reduction. So the recommendation for intervention for secondary MR, reference studies that support the recommendation are summarized. In patients with chronic severe secondary MR related to LV systolic dysfunction, LVF less than 50%, who have persistent symptoms, NIH class 2 to 4, while an optimal GDMT for heart failure, that is stage D, transcutaneous end-to-end repair is reasonable in patients with appropriate anatomy as defined on TE and with LVF between 20 to 50%, LV and systolic dimension less than equal to 70 millimeter, and pulmonary artery systolic pressure less than equal to 70 millimeter of mercury. This has got a 2A recommendation with level of evidence class B. In patients with severe secondary MR stages C to D, mitral valve surgery is reasonable when CABG is undertaken for the treatment of myocardial ischemia. In other situations, the surgery has got a class 2B recommendation, like those who have atrial fibrillation or who cannot be controlled by the guideline detected medical treatment, and mitral valve surgery in these patients can be considered where percutaneous intervention is not feasible. So the contemporary management of secondary mitral regurgitation is symptomatic secondary MR, where moderate to severe. The optimization of heart failure therapy has to be done. After that, we have to do a repeat TTE. If it is less than moderate MR, medical management has to be continued. If it is moderate to severe or severe MR, anatomically suitable leaflets, LVF 20 to 50%, LVIDS less than 70 millimeter, and there is no contraindication of mitral clip, we have to do mitral clip surgery in this patient. And if these anatomically suitable leaflets are not there or the criteria do not fulfill, then transcatheter mitral valve replacement or mitral valve replacement surgery or left ventricular devices or heart transplantation should be considered. So the conclusion is transcatheter mitral valve repair with mitral clip is the new gold standard for treatment of SMR. Based on the co-op trial data, the relative reduction in all-cause mortality with mitral clip is the highest of all the available therapies, including medications for CRT. It is proven that correction of SMR in HF-REF with mitral clip reduces mortality, reduces heart failure hospitalization, and improves quality of life. NOH class and 6-minute walk distance. Patient selection is the key to identify those who will benefit the most from this therapy. Patient with large dilated left ventricle, less than equal to 3+ MR, severe irreversible pulmonary hypertension, severe right ventricular dysfunction, or those on inotropic support may not benefit. It is important to remember that 29% of patients in the mitral clip arm in co-op had died by the 2-year follow-up, emphasizing the high mortality associated with SMR. Therefore, we need to identify the factors that can help in early diagnosis and treatment and continue to enhance GDMT as allowed following the procedure. Thank you all for your patient hearing.
Thank you, Dr. Bhuvan Maji, for your beautiful presentation. Let us go to the next topic, which will be spoken by Dr. Lipika Adhikari, the Scientific Committee Chairman of CSI Update 2021. And I request Dr. Lipika Adhikari to present heart deliberation. The topic is role of stress echo in regurgitant valvular heart disease. It's a very, very important topic. Over to Dr. Lipika Adhikari.
Hello, is my slides audible?
Yes, madam. Yes,
slides
yes,
are visible?
Yes, madam. Please go ahead.
Today, my topic of discussion is role of stress echocardiography in regurgitant valvular disease. As we know, the stress echocardiography was initially started to look for the viability of the myocardium, and subsequently its use was extended to diastolic heart failure, evaluation of diastolic heart failure, non-ischemic cardiomyopathy, valvular heart disease, pulmonary hypertension, athlete's heart, congenital heart disease, and heart transplantation. Performing echocardiography at the time of exercise also allows link to be drawn among symptoms, cardiovascular workload, all motion abnormalities, hemodynamic responses such as pulmonary pressure and transvalvular flows and gradients. So what are the stresses? We all know that it is predominantly a treadmill test, but semi-supine bicycle ergometric test is indicated when multiple stress parameters are assessed at the time of different level of exercise. Dobutamine, of course, is a preferred alternative, and vasodilator stress echo is particularly indicated for coronary assessment of the coronary flow reserve, particularly non-ischemic cardiomyopathy and hypertrophic cardiomyopathy. And these are the different stages of exertion. In bicycle ergometer, progressively increasing stresses, resistance were given, and the different assessments done at rest, mild, moderate, and peak exercise and during recovery. What are the assessments done during valvular functional assessment, that is left ventricular function, regional wall motion abnormality, LV filling pressure, severity of mitral regurgitation, gradients across valve, systolic pulmonary artery pressure, and right ventricular function. Similarly, progressively increasing doses of dobutamine stress also was given, and the parameters measured at rest, peak exercise, and recovery. Now, when to stop the stress echo? It is when the patient becomes intolerably symptomatic, muscular exhaustion, having hypertension to the extent 220/120, symptomatic hypotension, develops arrhythmia or different features of ischemia. Now, hemodynamic changes during exercise. Some valve-related exercise changes are evanescent. Peak exercise is mandatory in that case. Apart from changes in E by E dash, an estimate of LV filling pressure obtained at low level of exercise before even wave fuse, other parameters should be obtained throughout the test. The kinetic changes in LV contractile function and tricuspid pressure need to be assessed, especially in patients with mitral regurgitation. Increase in pressure gradient can indicate a more severe disease process. This is particularly important that initially stress echo was done for ischemic heart disease, but subsequently it was implied for low flow, low gradient aortic stenosis, and now it is very pertinent feature for pertinent investigation for evaluation of regurgitant valvular heart disease. The dynamic change in systolic pulmonary artery pressure and the occurrence of exercise pulmonary hypertension should be interpreted with caution and analyzed in light of age, exercise load, and changes in systemic blood pressure and cardiac output. Left ventricular function, a worsening in wall motion abnormality from the baseline classically indicate inducible ischemia as a result of exhausted coronary reserve. The absence of LV contractile reserve is characterized by a small increase in LV ejection fraction or a longitudinal function derived from the tissue Doppler imaging or two-dimensional speckle tracking. Failure to increase in ejection fraction more than 5%, global longitudinal strength increase more than 2%, and failure to increase stroke volume by 20% denotes compromised LV function. So in mitral regurgitation, different level of stress, predominantly the severity of the mitral regurgitation and systolic pulmonary artery pressures are measured, both during stress as well as during recovery. And in aortic regurgitation, it is the LV filling pressure and ejection fraction, these two are taken. Now, as we know, the mitral regurgitation is of two types, primary and secondary. Clinical value of exercise echocardiography has been extremely demonstrated in patients more with mitral regurgitation than aortic regurgitation. In asymptomatic patients with more than moderate primary MR, exercise stress echo may reveal dynamic mitral regurgitation in approximately 1/3 of cases. Close relationship is demonstrated between increase in mitral regurgitation and systolic pulmonary artery pressure. The level of increase in systolic pulmonary artery pressure depends on the ability to recruit the pulmonary vasculature successfully to accommodate the increased blood flow with exercise and increase the LA pressure, and each of which may be abnormal at rest. Exercise stress echo may also enable the identification of latent left ventricular myocardial dysfunction. Long axis function is known to be more sensitive to any myocardial disease process than the short axis functional assessment, and hence global longitudinal strain is the first to be reduced in the presence of intrinsic myocardial dysfunction, even in the left, when the left ventricular ejection fraction is preserved. Patients with slight increase in left ventricular global longitudinal strain at exercise are those with limited left ventricular contractile reserve. Exercise changes in global longitudinal strain are less load dependent and less affected by the dynamic behavior of the mitral regurgitation. These are some pictures which shows the dynamic increase in primary mitral regurgitation severity during exercise. Moderate primary pulmonary regurgitation with normal left ventricular global longitudinal function, but without contractile reserve. And bottom feature shows that the same that is cardiac magnetic resonance shows the increased gadolinium enhancement in the particular area of hypokinesia. So what are the recent guidelines? In the current European Society of Cardiology and American Heart Association, they show that class 2B indication for mitral valve repair in asymptomatic patients without LV dysfunction and dilatation. So whenever there is a disproportionately increased severity of mitral regurgitation and the patient is asymptomatic, stress test is a very important test for this thing. Patients with an exercise-induced marked increase in MR severity and pulmonary hypertension could benefit from early elective mitral valve surgery. The lack of LV contractile reserve is independently associated with reduced cardiac event-free survival, and elective surgery could also be contemplated in asymptomatic patients with severe MR. When treated medically, these patients should be followed up very closely at 3 to 6 months interval. Asymptomatic patients without exercise pulmonary hypertension or with LV contractile reserve could be monitored annually. Now, in case of secondary MR, rarely exercise-induced increase in MR occurs as a consequence of acute transient ischemia. This type of dynamic MR is clinically revealed by flash pulmonary edema. Acute increase in mitral regurgitation during exercise independently is a predictor of cardiac death and heart failure admission. And exercise increase of mitral regurgitant orifice area more than 13 millimeters square has been identified as the cutoff point for predicting an increased risk of cardiac event. Considering this, combined mitral valve repair is advised at the time of surgical coronary revascularization. Now, regarding aortic regurgitation, exercise stress test is reasonable for the assessment of functional capacity. Failure to reduce end systolic volume or increase in ejection fraction exercise was specific for predicting LV function. The absence of contractile reserve, decrease in left ventricular ejection fraction 5% at exercise, identify the presence of latent LV dysfunction earlier than conventional echocardiographic parameters obtained at rest. Colored tissue Doppler imaging for measuring the systolic mitral annulus velocity may be used as a surrogate marker of long axis and subclinical LV dysfunction. Now, whenever in valvular heart disease, there is a disparity between severity of the disease and the symptoms, or the patient is asymptomatic with moderate or severe valvular heart disease, exercise stress test can be done to evaluate the valve, ventricle, and hemodynamics. Regarding valve, whenever during exercise test, there is increasing grading of the mitral regurgitation, or there is increase in area of mitral regurgitant orifice area more than 13 millimeters square. In the ventricle, when there is a loss of contractile reserve, that is less than 5% increase in left ventricular ejection fraction, less than 2% increase in the global longitudinal strain, and stroke volume is reduced by 20%, there is appearance of new wall motion abnormality, there is left ventricular dyssynchrony, and the left ventricular and also the right ventricular dysfunction, means the patient is at risk. And the regarding hemodynamics, whenever there is with exercise, there is increasing left ventricular filling pressure, that is E by A dash ratio is altered, and the patient is having the appearing pulmonary hypertension more than 60 millimeter of mercury. So these all are risk factors for developing symptom in near future, and these patients may be taken early for the intervention, maybe either repair or replacement. So to conclude, during both exercise and inotropic stress, a normal response, and that is augmentation of function in all segments, increases and the cardiac output also increases. The presence of a new or worsening wall motion abnormality identifies ischemia, while the improvement in regional wall motion abnormality by 1 grade in dysfunctioning segment characterizes recruitable myocardium. Global contractile reserve in patients with no regional resting dysfunction is often defined as an increase in approximately 5% in ejection fraction, while a flow reserve is defined as an increase in forward stroke volume by approximately 20%. Any change in cardiac function, improvement or worsening of wall motion, ejection fraction, global longitudinal function, as assessed by the strain rate, hemodynamic parameters, that is the stroke volume, systolic pulmonary artery pressure, E by U dash ratio, left ventricular outflow tract gradient, and severity of valvular disease, that is improvement or worsening of the mitral regurgitation or aortic valve area and pressure gradient, must be reported early. Thank you for your patient care. Chairpersons, kindly make a quick comment on this session and conclude the session.
Any comments from the audience?
No comment from the audience, Chairperson. You just give a quick comment and then just wind up the session. Rida, quick comment.
This has been a very good session, very informative. All the speakers have done their job very convincingly. So as chairperson, I thank all the speakers as well as the audience. Thank you. You can proceed for the next session.
Thank you, sir. So that was a wonderful session on valvular heart disease. Now we have a industrial session which is sponsored by Boehringer Ingelheim from their unrestricted academic grant. The speaker for the session is Dr. Shubhro Banerjee. May I now request Dr. Shubhro Banerjee, sir, to be on the screen and present his lecture.
Thank you very much. I'm just going to share my screen, and I believe I am audible.
Yes, sir, you are audible and visible, sir.
Okay, great. So, okay. So as you know, patients with diabetes, if they are not adequately treated, are liable to develop cardiovascular and renal complications. But some of the drugs that are used to reduce blood sugar have been found to have favorable effects on the heart and the kidneys. And that's the reason why they're being widely used by the cardiologists and the nephrologists. However, to ensure proper multidisciplinary care of such patients, it's important that A, cardiologist, nephrologist, and endocrinologist need to work in harmony. And B, we need to identify drug or drug combinations which would be acceptable to all these subspecialties. So my talk today is on connecting these dots, and the session has been sponsored by Boehringer. Now, uncontrolled hemoglobin A1C is a strong predictor for death, acute MI, stroke, and heart failure. Unfortunately, uncontrolled hemoglobin A1C is a major concern globally. And as the Discover study program has showed that globally, 27% of patients have A1C more than 9%. And the highest proportions were from Southeast Asia. Also, only 17% attained the target hemoglobin A1C of less than 7%. And again, the figure was higher in the Southeast Asian population. Now, you know about the dysglycemic legacy, which states that patients, if the hemoglobin A1C are not below the target level within the initial year of their treatment, then they tend to have more complications than those patients whose hemoglobin A1C is less than the target, which was 7, and the treatment was started early. So in other words, it's not only important to get the hemoglobin A1C down to the target, but also to get it fast. Oops, sorry. Now, yeah. Now, it has been seen that glycemic control tends to decline over time with monotherapy. And we know that the guidelines have said that if the target hemoglobin A1C is 1.5 to 2 or more above the target, then monotherapy may not be sufficient and we may have to consider about combination therapy. Therefore, we need for the perfect, or at least for the better drug combinations, which will be able to get the hemoglobin A1C down in a short period of time. Let's look at the Omidas octet, you know about it. So it refers to the different pathophysiological mechanisms which lead to hyperglycemia. Now, if we look at metformin, what it does, it reduces hepatic glucose formation, increases glucose uptake. Sulfonylureas would increase insulin secretion. Now, DPP-4 inhibitors would have incretin effect, would increase insulin secretion, would reduce hepatic glucose production, would reduce glucagon secretion. So at least they would act by 4 different ways. And SGLT2 inhibitors also worked in a multitude of ways, and although primarily it reduces glucose reabsorption from the kidneys, it also promotes glucose uptake and also promotes insulin secretion. So if you have a combination of DPP-4/1 and SGLT2 inhibitor, then you could actually target most of this this pathways resulting in hyperglycemia. So a combination of SGLT2 inhibitor and DPP-4 inhibitor seems to be the perfect combination. But is it so? Let's have a look. It's been shown that this combination is actually better in lowering hemoglobin A1C than the individual components. And moreover, they also reduced body weight, reduced blood pressure, and reduced uric acid concentration, which are good for a patient who has diabetes. Now, you may question that why do we use so expensive medications to reduce the blood sugar level to below the target if we have alternate pathways or alternate medications which can do the same thing but at a cheaper rate? So, for example, let's look at sulfonylurea and insulin. Now, this cost-effective analysis showed that although it's true that sulfonylurea and insulin would be cheaper compared to the combination of SGLT2 inhibitor and DPP-4 inhibitors, but this combination of SGLT2 inhibitors and DPP-4 inhibitors would reduce to less diabetes-related complications and would be able to delay the initiation of insulin therapy. So this would actually reduce the indirect medical cost and would also improve the quality of life because a patient doesn't have to be on injectable preparation. So if you look at this, actually this combination is more cost effective and would be effective would be acceptable to the patient. Now, so we can say the endocrinologists are happy about it. They have found a drug which is cost effective and which can reduce the hemoglobin A1C to target values. But what about the cardiologists and nephrologists? Are they happy too? Now we know diabetes affects the heart and the kidneys, and the way it does is it increases cellular oxidative stress, it increases inflammation, all leading to cellular apoptosis, leading to nephron loss in the kidney and cardiomyocyte loss in the heart. And the end result would be on the kidneys, it would reduce the EGFR. It would may cause the development of chronic kidney disease. It increases albuminuria, and on the cardiovascular system, it may increase blood pressure, promote atherosclerosis, and result in heart failure and acute coronary syndrome. Now let's have a look at SGLT2 inhibitors. They have seen to prevent heart failure hospitalization in diabetic patients who are at high risk of cardiovascular events, but without any heart failure or sort of heart disease. And similarly, they have been seen to reduce or to slow down the progression of renal failure in patients with diabetes. Not all the SGLT2 inhibitors have been shown to do that. Apart from empagliflozin, canagliflozin, and dapagliflozin, we recently have some evidence for artegliflozin that it reduces heart failure hospitalization. But again, for others like remogliflozin, we do not have any cardiovascular outcome trial or any other trial, large-scale trial, to show that it does. Now, in patients with heart failure with the reduced ejection fraction, studies such as EMPEROR Reduce study or the DAPA heart failure study have shown that these drugs are able to reduce cardiovascular death and heart failure hospitalization. and that is the drugs used were empagliflozin and in DAPA heart failure study, dapagliflozin. Also, they're able to reduce the EGFR slope and thereby reduce the progression, slow down the progression of renal dysfunction. In heart failure with preserved ejection fraction, recently empagliflozin has shown in the Emperor Preserve study to reduce cardiovascular death and heart failure hospitalization. And it has also been seen that empagliflozin is able to reduce the risk of worsening nephropathy across all the all the categories of CKD and across all the categories of albuminuria. So SGLT2 appear to be appreciated by both cardiologists and nephrologists because they would be doing their jobs too. Now let's move on to the DPP inhibitors. How would the nephrologists and the cardiologists view them? Now, if you look at heart failure hospitalization, most of the DPP-4 inhibitors are neutral. They neither increase nor reduce the risk of heart failure hospitalization, except saxagliptin, which has been shown to increase the risk of heart failure. Similarly, we have some signs for alogliptin as well. If you come to the renal outcomes, then we have evidence from Carmilla study that at least it's neutral, because in Carmilla study, there was a high proportion of patients who had compromised renal function. Sorry, and we can say that it's safe to use linagliptin in such population, but we do not have such evidence for saxagliptin and sitagliptin, who did not comprise of a large population of renally compromised patient. And for drugs such as vildagliptin and teneligliptin, we do not have any cardiovascular trials. Rather, certain evidence are there that they could be harmful for the heart. This is what I just mentioned. In the Carmilla study, there was 62% of patients had impaired renal function, whereas it was a small proportion in the other studies with other DPP-4 inhibitors. Also, linagliptin was shown to reduce albuminuria. So among all DPP-4 inhibitors, linagliptin appears to be most acceptable to both cardiologists and nephrologists, because it doesn't increase the risk of heart failure, and also nephrologists can use them with confidence because they wouldn't really cause any detrimental effect on the kidneys. Now, we have several combinations available. We have empagliflozin linagliptin combination, we have dapagliflozin saxagliptin combination, we have artegliflozin and sitagliptin combination, and also we have combination with remogliptin, which I'm not going to mention because it's not really, it doesn't really help cardiovascular renal effects. Now, let's look at the first combination, empagliflozin and linagliptin. This combination would reduce 3-point MACE, cardiovascular death, heart failure hospitalization, and would also reduce the renal worsening of the renal function. But if you look at dapagliflozin and saxagliptin combination, here the beneficial effect of the dapagliflozin would be negated by the harmful effect of saxagliptin on heart failure hospitalization. If you look at the artegliflozin and sitagliptin combination, then again, then the sitagliptin has not shown to be any, we are uncertain about its effect in patients with renal compromise, and artegliflozin has been neutral in patients in renal compromise. So for the nephrologist and cardiologist, the latter two combinations may not be the best drug combination to choose. So just to summarize and say that this combination of empagliflozin and linagliptin would not only reduce the target hemoglobin A1c by 1.2 to 1.8%, but also would have favorable effects on the heart and kidneys. And also in patients with hepatic impairment, they are quite safe to use, and it doesn't really need dose adjustment. So to summarize, the combination of empagliflozin and linagliptin as a fixed dose combination would address multiple pathological mechanisms of diabetes, would cause robust reduction in HbA1c with low risk of hypoglycemia. It would reduce the weight, blood pressure, albuminuria, and would improve vascular function. There's evidence for robust cardiovascular and heart failure and renal benefits with the combination. and proven mortality benefit with empagliflozin in patients with type 2 diabetes and atherosclerotic cardiovascular disease, for which it has been recommended by the ESC/EASD guidelines. And both empagliflozin and linagliptin could be used in patients with diabetes and heart failure. And also, it has the convenience of once daily dosing, and and it's cost effective. So thank you very much. I would end it here. I would stop sharing my screen.
Thank you, sir. So if there are any comments, I would like for any comments from others. No comments. Okay, so
carry on. Next session.
Yeah, so we move on to the next session, and the session is on cardiomyopathy. The speakers for this session are Dr. Anjanlal Datta, Dr. Arup Das Bishwas, Dr. Dipankar Mukhopadhyay, and Dr. BP Chattopadhyay. The moderator for this session are Dr. Sunandan Sikdar and Dr. Monoranjan Mondol. The speakers are Dr. Priyam Mukherjee, Dr. Subhashish Roy Chaudhuri, Dr. Devopriya Mondol, Dr. Orijit Ghosh, and Dr. Dipankar Ghosh Dasdiyar. May I now request the chairperson to take over.
Good afternoon. Am I audible?
Yes, sir, you are audible, sir.
Yeah. We have a bunch of speakers on the subject of cardiomyopathy, covering from dilated, obstructive, and Takotsubo. All 5 lectures are there. Each lecture will be of 12 minutes. I will request to restrict to 10 minutes if meaningful discussion can be followed by that. Dr. Priyam Mukherjee, please start your deliberation.
The speaker's voice is not heard.
Yeah.
Priyam Mukherjee, sir, please unmute yourself.
Start from the beginning.
Yeah. Am I audible?
Yes, sir, you are audible.
Yeah. So it is a heterogeneous group of disease of myocardium with different pathogenesis, clinical presentation, diagnostic evaluation, and criteria, and obviously there's a specific treatment algorithm also there. They are associated with the mechanical and electrical dysfunction, and which is usually but not invariably exhibits inappropriate ventricular hypertrophy or dilatation. So difficult to move the slides.
Sir, kindly click on slide and move, sir. Double click.
Yeah.
Double click the slide.
Or on the number 2.
Yeah.
Did you
double click on the slide, sir? Double click on the slide.
Double click. Okay, fine. Now this is a WHO classification of cardiomyopathy. There is a dilated cardiomyopathy, hypertrophic cardiomyopathy. There is a restrictive cardiomyopathy. Also, there is arrhythmogenic RV dysplasia, and there is some cardiomyopathy which is unclassified. Now, regarding the genetical association, we all know there is different genes associated with different cardiomyopathy. I am not going into the details of this genetic association. Straightforward, we can go to the slides of etiology of restrictive cardiomyopathy, which is the today's topic of discussion. Now, it can be classified as a non-infiltrative, under which there is idiopathic, there is familial, there is hypertrophic cardiomyopathy. So definitely there is some overlapping between this hypertrophic cardiomyopathy and this restrictive cardiomyopathy. There can be systemic sclerosis. Other cases like infiltrative cardiomyopathy, under which this amyloidosis, sarcoidosis, and some storage disorder comes. Then comes these endomyocardial diseases like endomyocardial fibrosis, hypereosinophilic syndrome, carcinoid disease, metastatic malignancy, radiation, chemotherapy, and obviously drugs, particularly this serotonin and methotrexate. They are important drugs causing this restrictive cardiomyopathy. Now, it is a results of myocardial disease, and obviously the hallmark of the disease is that there should be a non-dilated ventricle, and there will be a significant diastolic dysfunction. The term infiltrative cardiomyopathy and restrictive cardiomyopathy are pathophysiologically and anatomic definitions of cardiomyopathy that have overlap with several well-defined clinical conditions. RCM not always isolated cardiac disease, but may arise secondary to acquired or genetic disease. There may be or may not be systemic involvement, or the systemic involvement may be subclinical. Now, it is a RCM. They are least common type of cardiomyopathy. There is increased stiffness of the myocardium. There is impaired diastolic filling. Ventricular volumes are usually normal or reduced. Wall thickness is normal or mildly increased in some cases. Systolic function is typically preserved, and poor ventricular compliance is a hallmark. Now, this is due to rigid myocardium. There is a forward flow decreases. Also, there is venous congestion, and considering different symptoms, I am not going to the details. Now, this is the pathophysiology. There is a ventricular volumes are usually normal or reduced. I have already told, and there is a systolic function is typically preserved, and the hallmark is the poor ventricular compliance. That is the dP by dV. This is very important, and intraventricular pressure rises considerably with small increase in the volume. So this is a pathophysiology of restrictive cardiomyopathy. Now, there are symptoms and signs. They have fatigue, dyspnea, orthopnea, with a low to normal blood pressure. Patient may have a inspiratory increase in the JVP. That's the Kussmaul sign. S3, S4 can be audible. Now, ECG not very pathognomic of this restrictive cardiomyopathy. There may be biatrial enlargement and non-specific changes. Some diseases, they have definite conduction system involvement, but otherwise ECG mostly very non-contributory. So this is the echo finding. You can see in the slide. So there is a significant biatrial enlargement in the echocardiogram, and you can well appreciate that LV LV is LV volume is normal, RV volume is also normal, and there is no significant hypertrophy. So this is another variety of restrictive cardiomyopathy where there is a definite increase in the your LV volume, LV wall thickness, and there is a granular pattern which can be found in your amyloid cardiomyopathies. Now, this is the Doppler parameters. That is the E velocity is higher, that is the 1 meter per second, and the A velocity is lower, that is the less than 0.4 meter per second, and the E wave distillation time is less than 160. Now, in this case, it is 145. So there is a marked reduction in the systolic annular velocities indicative of latent systolic dysfunction, and the E by E prime, this is very important, here is 16. So this indicates that there is increased left ventricular filling pressure. Now, in the top screen, that is the mitral annular velocities demonstrating the reduced systolic as well as diastolic velocities. That is the E prime, and in the bottom there is a Doppler from the mitral valve demonstrating very high early diastolic velocity. That is the E wave. Short distillation time less than 130 millisecond, low late diastolic filling of the transmitral velocity. The normal systolic contraction with a rapid but ill-sustained ventricular filling seen on pulse wave Doppler, that is the E wave, and with little or no left ventricular filling. So during the cardiac catheterization, it is a very important sign, which is called the square root sign. This square root sign is due to in diastole rapid early diastolic filling, that is the dip, followed by a plateau during the pressure tracing. And this square root sign it can be seen in both your restrictive and constrictive constrictive physiology. Now, the traditional hemodynamic criteria for the diagnosis of constrictive pericardial disease have been based largely on the diastolic equalization of the ventricular pressure, which is not usually seen in the restrictive cardiomyopathy, and there is an abrupt cessation of ventricular filling early in the diastole, and the restriction of the further filling demonstrated by a plateau of diastolic left and right ventricular pressure. This is another important CAT study, and perhaps the pathognomic in differentiating the constrictive and the restrictive cardiomyopathy. That is, it also demonstrates the interventricular interdependence, which is actually seen in your constrictive cardiomyopathies. Now, there is a discordant of the LV and RV simultaneous pressure tracing in case of constrictive pericarditis, but in the restrictive cardiomyopathy, the LV and the RV, there is a concordant pressure tracing. So this is very important in differentiating from restriction from the constriction physiology. So this is the ventricular interdependence, which is a very important pathophysiology in the case of constriction. Interdependence between the RV and the LV during respiration. During inspiration, there is a drop in the interthoracic pressure, which will be transmitted to the intracardiac chambers with a parallel reduction in the pulmonary capillary and the left ventricular systolic pressure, keeping the transmitral and the tricuspid diastolic gradient virtually unchanged. And there is an increase of venous return and a slight increase in the RV size. In constrictive pericarditis, the pericardium is thickened, forming a shell around the heart, so that the drop in the intrathoracic pressure will not be transmitted to the intracardiac pressure, so that the systemic venous and the RA pressure will not fall during inspiration, and the transmitral gradient will be reduced as opposed to the transtricuspid gradient, which will be increased. Consequently, during inspiration, the transmitral velocity will be reduced, and the tricuspid velocities increases in constrictive pericarditis, whereas in restrictive cardiomyopathy will remain unchanged. So this is the fundamental issue of ventricular interdependence, which is exerted is seen in the constrictive physiology, but not in restrictive physiology. Now this is a tissue Doppler imaging. Now there is a very interesting issue that tissue Doppler echocardiogram from the mitral valve inflow records a deep, narrow E wave and a diminutive A wave in both constriction pericarditis and the restrictive cardiomyopathy. Now tissue Doppler records a diminutive myocardial velocity E prime in the restrictive cardiomyopathy, but the E prime is similar to E in constriction physiology. So it is very important. In the restrictive physiology, the E prime is decreased, but in the constrictive physiology or in the normal, the E prime, the mitral annular E prime, is well preserved and normal. Now this is the difference between the CP and the RCM. Now septal motion, there is a definitely respiratory shift in case of constrictive physiology. In both cases, the mitral E by A ratio will be equal. That is will be high. That is more than 1.5, and the distillation time of the mitral E velocity will be less than 160. And the mitral, but there is a definite mitral inflow respiratory variation will be definite in case of constriction, but they will be absent in the restrictive physiology. Now, regarding the hepatic venous Doppler study, there is a very significant expiratory diastolic flow reversal, which will be absent in restrictive physiology. And I have already discussed this mitral and septal annular E velocity, that is will be reduced in case of restrictive physiology, but in the constriction, this septal annular E will be preserved, that is more than 7 centimeters per second. And ventricular septal strain will be reduced in the case of restriction, but it will be preserved in the constriction, because in the restriction there is a subclinical decrease in the ventricular systolic function, particularly the longitudinal function of the myocardium is decreased, but where is constriction, it is well preserved. Now, this is the, I have already discussed these respiratory variations in mitral valve, tricuspid valve, and the hepatic vein. So this is the catheterization details, which can be seen in the restrictive cardiomyopathy. There is the LV-EDP and the RV-EDP are almost equal in case of constrictive pericarditis, and there should not be difference of more than 5 millimeter mercury. But in case of restrictive cardiomyopathy, the LV-EDP more, and the difference is usually more than 5 millimeter mercury. If there is a significant RV systolic pressure and pulmonary hypertension, that is a 55 millimeter mercury, it favors the restrictive cardiomyopathy. In constrictive cardiomyopathy, usually the RV systolic pressure is less than 55 millimeter mercury. Now, regarding the other data, the RV EDP versus the RVSP should be less than 1/3, that is less than 33% in case of restrictive cardiomyopathy, whereas this ratio will be more than 33% in case of constrictive pericarditis. And definitely in the constrictive pericarditis, the inspiratory decrease in the right atrial pressure will be less than 5 millimeter mercury. So this is an echo criteria. So to differentiate between the two. Now, if the mitral inflow E by A is more than 0.8 with a dilated vena cava, there can be two possibilities. Either it's a and with along with that, if there is a ventricular septal motion abnormality, so there may be two possibilities. Either it is a constrictive physiology or the restrictive physiology. If the mitral medial E prime, that is the E prime is more than 8 centimeter, so it favors the constrictive physiology. If it is less than 6 centimeter, there is a decreased mitral E prime, then it is favors the restrictive cardiomyopathy. Now, in between, if it is between the 6 to 8, there will be mixed constriction or restriction. Now, there is another term called the annulus reversus. When the mitral lateral E prime is less than mitral medial E prime, then it is most likely constriction. Otherwise, if there is no septal abnormality and with the classical restrictive physiology, then further there is a restrictive physiology, and you need to do further imaging to assess the other diagnosis or other etiology of this restrictive cardiomyopathy. Now, cardiac MRI is very helpful. Cardiac is a versatile technique, and it provides anatomical, it provides morphological, and provides also the functional information about the cardiomyopathies. Now, regarding the endomyocardial biopsy, it is not a very not frequently done.
Unmute yourself.
Obviously, there is some acute indication. There is acute dilated cardiomyopathy with refractory heart failure symptom. We can do that. But
Dr. Mukherjee, your time is over. Please finish. Go to the last slide.
Yeah, sure. Yeah. So biopsy, new onset cardiomyopathy with recurrent ventricular tachycardia or high grade of AV block, and ideally biopsy should be currently be considered for patients participating in clinical trials and those with myocardial dysfunction and a treatable systemic disease known to affect the myocardium, such as amyloidosis, sarcoidosis, or eosinophilia. So these are the current recommendations. And regarding the treatment with the decongestive therapy, AC inhibitor, so they are the main stay of therapy. Otherwise, we have to treat the secondary causes according to the protocol. So I am not going to details in different types of cardiomyopathy due to the time constraints. So I can actually finish my talk. Thank you very much for patient hearing.
The organizer might decide whether we can have question answer session at the end of the deliberations or we go for the next speaker.
At the end, if there is any time.
So we are going for the next speaker, and if there is time left, we'll discuss at the end of the deliberation of all the speakers. So our next speaker is Dr. Subhashish Roy Chaudhary. He will be talking on hypertrophic cardiomyopathy, role of drugs.
Am I audible?
Sir, you're audible.
Okay.
Now your screen is not sharing. Before you,
I'll share.
yeah,
I'll
yeah.
share.
Okay, yeah, we can see.
Good afternoon, everyone. My topic for today is to discuss hypertrophic cardiomyopathy, the role of drugs, a topic less discussed perhaps in the wake of interventional therapy. HCM has been around for almost 60 to 70 years now, with a prevalence of 1:500 to 1:1000. So that constitutes a huge bulk of disease spread across the globe. And yet we do not have very specific evidence-proven pharmacotherapeutic agents in our armamentarium. One of the reasons may be because the pathophysiology of HCM itself is multifactorial, including mechanical and macroscopical abnormalities with varied expressions of these pathophysiological mechanisms, namely LVOT obstruction, diastolic dysfunction, ischemia, and mitral regurgitation, all of them contributing in its own way to cause various phenotypic and symptomatic groups. Of course, we should remember that HCM has got a genetic basis. It's autosomal dominant with mutations in the beta-myosin heavy chain, which is the basic pathophysiology of the disease. But again, there are more than 450 mutations to deal with. Having said that, and coming to the pharmacotherapy in HCM, no agent that we know of modifies the disease development or outcome, perhaps with the exception of diltiazem. So the target of therapy, whatever we use, is to restore the quality of life in terms of symptom improvement and exercise tolerance, to decrease the dynamic gradients on the echo, typical managements of heart failure to prevent complications like sudden cardiac death. But we should remember that whatever guidelines that we're reading is based more on opinions than on evidence-based trial. When we are dealing with a patient of HCM, we have to take care of varied symptoms like LVOT outflow tract related dyspnea, to the spectrum of heart failure symptoms. On the other hand, we may have microvascular ischemia, angina, and atrial fibrillation and ventricular arrhythmia like arrhythmias. All the yellow bubbles that you see here are the drugs that we have in our armamentarium, and I'll go through the different scenarios one by one. To start with, the LVOT outflow tract obstructive patient, and here we are speaking of more than 50 millimeter mercury gradient, either resting or provoked. The LVOT outflow tract obstructed patient who is symptomatic. Of course, the mainstay of therapy are the beta blockers, verapamil, and diltiazem. We should remember that nitrates and phosphodiesterase inhibitors, which are arterial and venous dilators, should be avoided. That's a class 2 indication. It should be avoided in these patients. And digoxin is class 3, so that's in red. It's not recommended in patients with LVOT obstruction. Beta blockers forms the mainstay of therapy, as we know. What we should remember, that these should be non-vasodilating beta blockers and which should be titrated to effectiveness or maximally tolerated doses in these subgroup of patients. A list of the beta blockers would show that all of the beta blockers that we use, except carvedilol, are non-vasodilating. So we have got a gamut of various beta blockers that we can use. What is important is we should go up to the highest possible dose. Look at metoprolol. We should be using 100 milligram twice daily, not something that we commonly use. In fact, atenolol has the highest dose of 150 milligram per day, and in fact is the drug of choice in hypertrophic cardiomyopathy with hypertension, which would be a very difficult subset to treat. Verapamil comes in next when to use if the patient is intolerant or has contraindication to beta blockers. That's class 1, both in the ESC and the ACC guidelines. Again, the maximum dose would be 240 twice daily, much higher than what we usually use in our day-to-day practice. The issue would be whether to use verapamil in patients with severe LVOT obstruction of more than 100 milligram mercury, and perhaps that's one of the contraindications to use this non-dihydropyridine calcium channel blocker. Diltiazem has got a class 1 indication in ACC, but a class 2A indication according to the ESC, which says that it should be used in patients who are intolerant or have contraindications to both beta blockers and verapamil. Again, the use dose should be high enough, slowly titrated up to 180 milligram twice daily for it to be effective. A few words about disopyramide in symptomatic LV outflow obstruction. It is the drug to be added to beta blocker. That's very important. It's a drug to be added to beta blocker to improve the symptoms. Whether it should be used as a monotherapy, the answer should be no, because it would increase the chances of AF. So that's a 2B indication as monotherapy, but a class 1 indication of adding disopyramide to the existing first-line drugs. The dose of diazepamide can go up to as high as 750 milligram in divided doses. But there are a few words that I'd like to mention about diazepamide, that though it is used as a class 1A antiarrhythmic agent due to its negative inotropic effect, and it's most effective on resting gradients in contrast to, let's say, beta blockers, which is more effective in dynamic gradients. QTC monitoring is very important, and we should limit the drug when QTC exceeds 480 milliseconds. Regular monitoring should be done, and perhaps the Friedreich's formula should be used over the Bazel's formula. There can be anticholinergic side effects for which low-dose pyridostigmine should be used. But if the patient had reduced LV function, congenital long QT, or a history of torsades in pregnancy, it's absolutely contraindicated. Also, avoid using it in patients with urinary retention, prostatism, glaucoma, or myasthenia gravis. Should we be using low-dose diuretics? Very, very cautious. That's a 2B indication. Very cautiously to improve symptoms of exertional dyspnea if it is not being controlled with the other drugs, and if there is clinical evidence of volume overload and left-sided filling pressures. Just to complete the list of symptomatic LV2 obstruction for patients presenting with acute hypotension, start off with oral and IV beta blockers, give fluids, and then, if it's not responsive yet, go for intravenous phenylephrine as the class 1 indication. Coming to the subgroup of asymptomatic LVOT obstructions, one thing that should be said with certainty is that many of these patients, they lack symptoms because they have modified their lifestyle accordingly. So questions should be asked whether they are truly asymptomatic or they have modified their lifestyle, and they should be offered the LVOT obstructed gradient reduction therapy to all of them. For the non-obstructive with the preserved ejection fraction and who are symptomatic, again, it is the beta blockers and the verapamil that we had discussed in the LVOT subgroup, keeping in mind that it's in ACM, these patients have got a small LV cavity and therefore supranormal ejection fractions. So even a normal ejection fraction of 50 to 60 reported would perhaps be associated with significant myocardial fibrosis. And so we should have a lower threshold of giving them our beta blockers and verapamil. In fact, lower doses are usually required, and symptomatic responses are better with lower doses, and it should be titrated accordingly. If the patient has decreased ejection fraction, we have in our armamentarium all the drugs that we have for heart failure: AC inhibitor, beta blocker, low dose diuretics, MRAs, all as class 2A. Don't discontinue the negative inotropic agents like verapamil, diltiazem, and diazepamide in these low ejection fraction patients. For patients of angina in HCM, majority of the microvascular angina, and the beta blocker and verapamil would be lowering the rate and work very effectively. Ranolazine has been reported to work in refractory angina. Much interest had been generated as ranolazine as a disease-modifying agent because it inhibits the sodium current, but the trials have not given any positive results. And so it should not be used as a disease-modifying agent. Whether nitrate should be used only if there is associated coronary artery disease and no LVOT obstruction, that too very carefully. For the patients of AF, it's important to anticoagulate these patients, and that is irrespective of whatever their CHA2DS2 score is. NOAC is the first option according to the latest guidelines. For the antiarrhythmic drugs, we have a choice of sotalol and amiodarone specifically, which has modest to high efficacy in AF, and so these are reasonably used in ACM. Which should bring us to the newer kids on the block. These are the targeted therapies, which is a targeted inhibitor of cardiac myosin, mavacamten, which has been much talked about in the last 1 year. It reduces the number of myosin-actin cross bridges and decreases contractility, and definitely also improves the peak VO2. And this is perhaps the only drug in HCM which has now got a trial-based evidence. So the Explore HCM study design, which evaluated mavacamten in increasing titrated doses over 3 to 4 months and showed a mean change in KCCU overall score, which was significant. In fact, one of the highest differences for any medications of all the heart failure trials. And the percentage of participants who changed and in fact showed very large improvement was very significant, with the number needed to treat only 5. So the conclusions from this trial very recently concluded was that it is associated with substantial health status improvements in patients with symptomatic obstructive HCM, benefits observed early after treatment, but regress with treatment withdrawal. So to conclude, hypertrophic cardiomyopathy continues to be an enigmatic disease. In fact, it's an umbrella of diseases rather than one disease itself. And so with its very genotypic and phenotypic manifestations, it's very difficult to formulate therapies algorithmically. the emergence of precision medicine like mavacamten is what is going to modify the disease process itself, and these are the promising agents. But till these comes into use, the judicious use of common pharmacological armamentarium that we have are the key to management, and in fact, serial assessment of these drugs and titrating them accordingly are of paramount importance. Thank you.
Thank you, Dr. Mukherjee, for your valuable inputs in terms of hypertrophic cardiomyopathy and treatment, the modern scenario. We have finished it on time. So second thanks is for that only. We'll have time enough after the deliberations to come back and discuss some question and answer sessions if time permits. Next speaker is Dr. Devopriya Mondal. He will be talking on management and strategies in the arrhythmogenic right ventricular dysplasia, ARVD.
Good afternoon, sir. Good afternoon, respected chairperson. At the outset, I would like to thank CSI West Bengal, Kolkata chapter for providing this opportunity and delivering this talk. I'll be talking today on the management strategies in ARVD, that is arrhythmogenic right ventricular dysplasia. So in the first slide, I talked about ARVD in a nutshell. So it is an autosomal dominant disease with incomplete penetrance, but we have a variant which is known as Naxos syndrome or Naxos disease, which is autosomally recessive with presence with woolly hair and palmoplantar keratosis. The prevalence in general population is 1 in 2,500 to 5,000 with a male and female ratio of 2.7:1. That is, it is predominantly found in males. LV involvement in ARVD is found in about 20% of the patients. And if we look into the genotype of those patients, we have desmoplakin and tocopherolin 2 mutations predominantly being found in the LV involvement group. ARVD causes 5 to 10% of sudden cardiac deaths in individuals who are less than 65 years old. And to note here, pediatric SCDs are more common than adults in this disease. We have 4 stages in this disease. The early stage, that is asymptomatic. The second stage, that is the electrical stage, or known as the arrhythmic stage. The third stage is the RV failure. And ultimately in the fourth stage, both the ventricles fail and what we call it as a biventricular failure. So how do you diagnose this disease? This disease is diagnosed in a quintessential way, that is taking an absolute clinical history, task force criteria in a MRI is based, which is already given in 2010. That is a updated task force criteria and other modalities which are mentioned. How does the management in a nutshell? We try antiarrhythmic drugs. We use intracardiac defibrillators, catheter ablation, cardiac failure treatment, and management of thromboembolism, which I'm going to elaborate in the next few slides. This slide is about the epsilon waves in the ECG, which we are all familiar with. The lower down slide shows monomorphic VT with the LVBP morphology arising from the right ventricle, could well be VT arising from the ARVD substrate. The picture on the right side is a cardiac MRI showing a delayed enhancement in the T2 sequence, showing an edema in the right ventricular wall, and which is very characteristic in ARVD. The third slide talks about the modified task force criteria, which I'm now not going to discuss in detail because all of us have already gone through all these slides in multiple talks. The important part is how do you diagnose in ECG as well as a family history, and certain very discrete points like the use of Holter in clinical scenario where more than 500 ventricular beats become important. And obviously, not to mention more, the extremely useful modality nowadays is MRI, which gives absolutely clinical diagnosis of ARVD. So now come into the modalities of management. So what do you do in all those stages? I'll come stage by stage. So stage 1 is wait and watch. If the patient is asymptomatic, we don't need to do anything. We need to risk stratify them as to find out who are in the high risk and who are in the low risk. The second phase is the clinical phase or the electrical phase, where the actually antiarrhythmic drugs and ICD come into play. There is a role of catheter ablation, which I'm going to talk about in the next few slides. Then ICD as a primary prophylaxis, is it necessary? Is it helpful? That is also a matter of concern and a debate. Then prevention of thromboembolic complications. And when we have the biventricular cardiomyopathy onset in stage 3, we need to manage heart failure per se, forgetting everything about the ARVD. And when you have a burnt out phase, that is stage 4, the cardiac transplant becomes the only modality. So what is the first step? The step 1 is medical management. Whom do you do? We choose beta blocker as a reasonable therapy who do not have an ICD. That is a class 2A recommendation to start beta blockers in patients who do not have an ICD. But in patients who already have an ICD in place because of a documented VT because of ARVDs, and who do have inappropriate ICD therapies in the form of supraventricular tachycardia, sinus tachycardia, or AF atrial fibrillation flutter with a high ventricular rate, we give them beta blockers with a class 1 recommendation. The amiodarone recommendation comes in symptomatic arrhythmias. Amiodarone and sotalol, they are both reasonable, that is class 2B recommendation for the control of arrhythmic symptoms or to reduce ICD shocks. And as usual, amiodarone cannot be given in patients with reduced left ventricular function, where flecainide in combination with beta blockers are actually the drugs of choice. But the remembering point here is both amiodarone as well as flecainide, they are class 2B recommendations here. And in the right-hand slide, if we see the most effective arrhythmic agents, these are all studied in the like 10 years back, which showed that sotalol is the most effective beta blocker here compared to all other beta blockers. And amiodarone actually is the next best choice after sotalol. So a combination of beta blockers and amiodarone is a good choice. And if we are asked to say one drug, that could be sotalol in most of the patients. So what we do in drug refractory cases, and then drug refractory, where does this happen? This happens in extensive RV dysfunction and in patients who have easily inducible VT in the electrophysiological study. So those drug refractory cases, we have to think of other advanced options in the form of either ablation, or we have to put an ICD with the beta blocker, or else if it doesn't work, nothing works, then we have to go for cardiac transplant. What is the dose of sotalol? Sotalol is given in the dose of 320 to 480 milligrams per day. Maximum dose is 640 milligrams. It has a 68% overall efficacy rate. And a combination of amiodarone with beta blockers has a similar anti-arrhythmic profile and was reported with comparable efficacy by French group of authors. So this is a graph which shows the evidence of beta blockers, which shows that if we use drugs in a very effective way, the freedom from VT recurrence over a period of about, say, let's say 6 years is about 50%. And if we stop the drugs, the VT recurrence starts developing from the first year end onwards. What is the recommendation for using an ICD? The 2019 HRS guidelines say that the decision of ICD is absolutely in a clinical decision. If a patient has a documented VT in a patient who has an ARVD or is likely to be an ARVD or a known family history of ARVD, ICD forms a class 1 recommendation. But ICD, as we already see in these cases, in the yellow boxes, those class 2 recommendations are in individuals with ACM, like arrhythmogenic cardiomyopathy, and syncope suspected due to be a ventricular arrhythmia, and ICD is reasonable. So these are all the same as in all ventricular arrhythmias. So if we have a diagnosed case of ARVD, we have a documented case of VT due to that, which is an LBBB VT, we put in ICD without any choice or without any further thinking. But if it is not documented, then we have to put ICD as a class 2A recommendation. And the green boxes, these are all actually documented VTs or a suffered cardiac arrest, where obviously ICD is a class 1. The important remembering point is in individuals with phospholamban cardiomyopathy and an LVEF of less than 45%, ICD is reasonable. So here in these guidelines, we have these certain genetic mutations also, which shows the preponderance to developing VT. And in this case, ICD will be a good choice. So ICD mortality benefit, the secondary prophylaxis, obviously, as we all know, is the treatment of choice. What about primary prophylaxis? So in this study by Rugin et al. In the year 2004, he studied 42 patients. Most of them were primary prevention. And the overall mortality was 2% with the appropriate ICD therapy of 78. That means to say that this data is actually very encouraging, showing that primary prevention of sudden cardiac death using ICD may be effective, but we don't have any further studies or any other detailed documentary evidence so as to show that this actually is helpful. And the below graph actually shows that event-free survival in patients with ICD over a period of 10 years is much more better than in patients without an ICD. So the next modality is catheter ablation. So what is the mechanism of arrhythmia in catheter ablation cases? I mean, in cases with ARVD, it is predominantly reentrant. It is like a scar VT in cases of ischemic heart disease. We have RV, which is diseased in some part, and it is not diseased in other parts. So the basic mechanism is reentrant. What are the mapping techniques used? We use pace mapping, we use mid-diastolic potentials and entrainment mapping. Then we have to identify the critical exit points and to apply the radiofrequency ablation energy. The modalities are 3D cartomapping, insight mapping for substrate modification. What are the indications? Current indications include those patients with localized forms of the disease with a monomorphic, well-tolerated VT and with frequent recurrences of drug refractory or an incessant VT or frequent ICD discharges. So this is again a standard recommendation for all arrhythmias. We have drug refractory ICD frequent shocks, and we found out there is a monomorphic VT arising from single source. We can actually try to ablate them. The recommendations are still class 2A. We do not have a class 2, one recommendation for ablation as of now. Why? Because it is very difficult to ablate these subsets who have a very diffuse disease. Why is it difficult, and why does RFA fail in the long run? Because disease progression actually changes the arrhythmogenic substrate, and that leads to various different types of morphologies of VT, which keeps on recurring once the patient starts deteriorating or once the disease progressions happen. So the freedom from VT recurrence happens just after maybe 2 years or 2.5 years after a VT ablation, and keeps on progressing relentlessly over a period of time. So now, what are the treatment strategies to prevent sudden cardiac death? We have to have the risk stratification strategies, which involves severe right ventricular dysfunction, left ventricular involvement, a history of syncope or a cardiac arrest, a family history, inducible VT, VF, and ECG abnormalities in the form of epsilon potentials, late potentials, who are more prone to life-threatening VT and sudden cardiac death. Exercise recommendations, just to put on this point one more time, we all know this, the exercise recommendations says that heavy exercise or competitive sports are absolutely contraindicated in ARVD. They have been shown to improve, to deteriorate symptoms and cause sudden cardiac death. What are the management of asymptomatic patients? Regular clinical checkup along with a Holter, a TMT, echo. Advice against competitive sports. ICD as primary prevention still a query, but yes, families to sudden documented SCD due to arrhythmia, we actually don't know what to do. The efficacy of this modality is also not known. So this is the same what I have discussed till now. Symptomatic, we treat for the arrhythmia with the beta blockers. We put ICD if the patient has a VT, and then we actually ablate if there is a VT recurrence. But if nothing works and the patient goes into heart failure, we have to manage heart failure. And in the most worst case scenario, if the patient goes into biventricular dysfunction, develops a flow rate heart failure, he becomes a transplant candidate. So let's come on to the next slide. That is a transplantation. This is an experience from the Nordic ARBC registry. This came into the International Journal of Cardiology in 2018, which shows they had 31 patients aged 31 to 38 years. The most common indication for heart transplant was heart failure, and they had ventricular arrhythmias in about 10% of the patients. But the median follow-up for over 5 years showed that 91% of the patients did well. So still, it's in a very, very new stage. But yes, cardiac transplant is an option. So summarizing, risk stratification is very important. Counseling of genotype positive but phenotype negative is necessary. Asymptomatic individuals, no treatment except for the very high risk subset where beta blockers sotalol or imidazole plus a beta blocker is useful. ICD plus beta blockers for secondary prevention is absolutely proven, and catheter ablation has a very limited role here. Thank you.
Thank you, Dr. Mondal. It was an excellent deliberations of a conditions about which we don't know very much.
Thank you, sir.
Important thing is we have pointed out rightly how to prevent as a primary prevention or as a secondary prevention. We'll come to it later on. Next speaker is Dr. Arijit Ghosh, atrial fibrillation in dilated cardiomyopathy.
Kindly unmute, sir. Kindly unmute.
The speaker is neither visible nor audible.
Yes, sir. Now doctor unmuted. Yeah. You can able to see the PPT, sir?
You can see the slide.
So due to some technical glitch, I am not being able to move my slides. So the back office will be moving the slides for me. So at the outset, I want to thank
double click the slide. Yeah.
No, sir. I am sharing the slides. So Arjit sir, kindly say next whenever you want to go for next.
Yeah, that will be better. So you
can you enlarge? Can you enlarge the slide?
Yes, sir. It's a full screen mode only.
It is full screen mode already.
So kindly turn your mobile into horizontal mode and switch to your.
Actually, I am participating from the laptop itself.
Okay, let the slide be played by someone from the organizing team.
Can we move to the next speaker so that I can I am not being able to share my
So
screen.
you'll be waiting. So we go for the next speaker. Is it?
I am not being able to share my screen.
So let
Okay,
us.
okay. I think my slides are visible right now.
Yes, sir. Visible, sir. Visible.
So I can change the slides from my end only.
Yeah.
So, so without wasting much time, today's topic that I am given to discuss is AF in DCM. The thing is that whenever we encounter a patient with DCM and AF, we fight on the matter whether the DCM has given rise to this AF or AF giving rise to the DCM. So it is always a controversial topic. In today's topic, we will be discussing patients of a subset of AF with DCM with an ejection fraction of less than 40, as is being the definition. Epidemiology in the 2019, the prevalence of AF or atrial flutter is around 60 million all over the world. In patients who are at the age of 55 years and not having atrial fibrillation, have a lifetime chance of developing AF between the range of 22 to 48%. And the patients, almost 40% of the individuals will be developing AF and heart failure at any point of time together. So AF was associated with greater increased risk of major cardiovascular events and in patients with HFrEF. In HFrEF, the prevalence is higher with worsening NYHA class 4, ranging from 4.2% to almost 50% as the NYHA class progresses. So these are the incidence or prevalence of AF in the various heart failure trial, which ranges from 5% to 50%. The vicious cycle that goes on whenever a patient of HFrEF goes into AF. With the HFrEF, there is an increase in ALA enlargement, which subsequently gives rise to LA pressure. There is functional MR, which gives rise to AF. And this AF in turn decreases the cardiac output due to rapid ventricular rate and irregular rate. There is a loss of atrial kick and really giving rise to tachycardia-induced cardiomyopathy. So atrial fibrillation cardiomyopathy, when do we suspect? We suspect an AFCM when a non-ischemic cardiomyopathy and persistent AF is not improving after appropriate medical therapy and rate control. Unclear, however, the time course, clinical and laboratory or imaging features and how does it differ from AF-induced cardiomyopathy and DCM leading to AF? We are still clueless. Finally, AFCM diagnosis can only be corroborated if the LV systolic pressure improves or normalizes after ablation or control of atrial fibrillation. So what happens during atrial fibrillation? During atrial fibrillation, there are heart rate irregularity, sympathetic dysregulation, calcium mishandling, and there is contractile dysfunction, which gives rise to this non-ischemic form of cardiomyopathy. And after the treatment of AF with ablation or antiarrhythmic agent, if the LV function recovers, we designate this term as AFCM. So the survival of DCM, as this Kaplan-Meier curve shows that with DCM and AF, the overall outcome of DCM worsens. So AF in DCM, rate control or rhythm control. What are the evidences of pharmacotherapy? We have two large trials. The only two drugs which have been tried for treatment of AF in reduced ejection fraction is amiodarone and dofetilide. We have two major trials for that. One is the AFCHF trial, which is a trial which had tried rhythm control versus rate control. And these patients were followed up for up to 37 months and without any difference between the cardiac vascular mortality benefit or total mortality or worsening of heart failure between the rate control and the rhythm control group. The next trial is the Diamond AF trial, which tried dofetilide. Dofetilide was also not effective in decreasing the overall mortality. What are the criticism of this trial? The comparison of the Diamond AF trial was with placebo instead of a proper rate control agent. Only 12% of the patients were receiving beta blockers at baseline in the Diamond as compared to the AFCHF. So a part of the reduction in hospitalization seen in the dofetilide compared reduced ejection fraction showed that there was no evidence of benefit in terms of cardiovascular morbidity and mortality and symptom control or quality of life in patients with strict control group. So strict control versus lenient control. In contrast to the Swedish registry, in contrast to this trial, the Swedish registry found that AF-HF had a greater mortality when the resting heart rate was more than 100, and the use of beta blockers was associated with an improved outcome. So what does the current guidelines say? Lenient rate control strategy, that is resting heart rate of less than 110 beats per minute, is reasonable when the patient is asymptomatic and the LV function is preserved. While if a patient is symptomatic, then the lenient approach may not be a good option. So CRT in AF-HF patients. What we find in this study is that CRT response predicts occurrence of non-response predicts occurrence of atrial fibrillation in non-ischemic dilated cardiomyopathy. That is new onset AF in the non-responder patients with respect to responders. If the patient is a non-responder in the first year, then there is a chance of 18% chance that this patient might be a non-responder due to a new onset AF. And as the patient becomes non-responder to AF in the second and third year, the chances of AF development increases. So what about the non-pharmacological measures? The non-pharmacological measures might be catheter ablation of atrial fibrillation or AV nodal ablation with CRT. So this is a PABA-CHF trial which had compared 40 patients in two groups with pulmonary valve isolation and atrioventricular nodal ablation with biventricular pacing. And they had followed up this patient for the next 6 months with definite symptomatic improvement in 6 months walk test, Minnesota Living Score, and heart failure at 6 months. So in these trials, the AV nodal ablation along with biventricular pacing scores over pulmonary vein isolation. So whenever we tried the results, we find that the catheter ablation results in 88% AF-free survival and absolute increase in LVEF of 8% at 6 months. The functional capacity and quality of life also improves. The APAF-CRT trial is a similar kind of trial which had definitely shown mortality benefit in patients of AV nodal ablation along with CRT when compared to medical therapy. The results show that the patients with atrial fibrillation narrow QRS complex AV nodal ablation plus CRT was beneficial compared to medical therapy, both in terms of decreasing in mortality and hospitalization for heart failure. So there are similar trials which show that AF-free survival as well as there is definite mortality benefit when a patient of atrial fibrillation with reduced ejection fraction are treated with catheter ablation as compared to medical therapy. So these are the various trials. The Castle AF trial, the trial which is a landmark trial, which also compares catheter ablation versus medical therapy with rate control in patients of AF with reduced ejection fraction. The primary endpoint being a decrease in all-cause mortality, the secondary outcome, heart failure. What are the results? The inclusion criteria of this trial was symptomatic than one, unwillingness of taking antiarrhythmic drugs, LVEF of less than 35%, NYHA more than class 2, ICD or CRT at home monitoring capabilities already implanted due to primary or secondary prevention. So what do we find? We find that the primary composite endpoint of the Castle AF trial showed that the ablation was definitely better in reducing the primary endpoints. LVEF improved by 8% in the catheter ablation. Castle AF trial. It included a reasonable large sample, that is N363, evaluation of the relevant clinical endpoints, and long-term follow-up with continuous AMM monitoring through implantable cardioverter defibrillator was done in more than 70% of the patients. The Cabana trial, which is also a similar kind of trial, did not show any benefit of decreasing cardiovascular mortality and cardiac arrest when the two arms were compared. But the Cabana trial had a subgroup of heart failure patients. 9.3% of the patients had an ejection fraction of less than 40%. Paroxysmal AF was present in 32% and persistent in more than 55%. The primary endpoint was significantly reduced with ablation. There was no reduction in the CV mortality and heart failure hospitalization. AF recurrence was definitely lower in the ablation group. The RAFT-AF trial is also a trial which compared ejection fraction AF with an ejection fraction of less than 45% with catheter ablation along with medical therapy. It was a trial which had included a huge number of patients, more than 400 patients, 200 in each group. And when the ejection fraction patients were divided between less than 45% and more than 45%, it was shown that the ablation-based group, the ablation group, had a definite decrease in the primary outcomes. But there was, I should say, there was a decrease in the events, but the decrease was not statistically significant. When we go on to analyze the secondary outcome, that is the outcome regarding the symptomatic benefit, 6 minutes walk test, NT-proBNP, change in VF, these were all statistically significant in the RAFT-AF trial. So to conclude, the RAFT-AF trial did not show any mortality benefit or any up to the statistical significance, which rose up to statistical significance, but the ablation group had a better quality of life, more significant increase in LVEF and decrease in NT-proBNP. So if we go on to compare the landmark AF trials, we find the antiarrhythmic drugs fail to demonstrate any benefit, including heart failure or admission in patients of heart failure and cardiomyopathy. This in contrast to the RCTs comparing AF ablation as rhythm control versus rate control, because the ablation strategy was definitely better. Whenever we go on to select our patients for catheter ablation, we likely want to decide who are the patients who are going to benefit from a catheter ablation. We should be considering the facts that whether the AF-mediated cardiomyopathy is suspected, whether the patient is in a low NYHA class, there is no significant ventricular scar on LG MRI, there is no atrial fibrosis, paroxysmal and early persistent AF, younger patients, and no significant comorbidities. These are the patients who are likely to benefit from cardiac catheter ablation. In the 2019 ACCHA guidelines, we find catheter ablation to be a class 2B1, but in the recent 2020 guidelines, we find it to be a class 1 indication to reverse LV dysfunction in patients with AF and tachycardia-induced cardiomyopathy is highly probable and should be considered in selected patients with AF and HFrEF to improve survival. This becomes a class 2A indication. So what are the lessons learned? AF can be a cause and a consequence of HFrEF, and AF in patients with heart failure is associated with worse prognosis and supports the need for aggressive management of both other conditions. In patients with AF and HFrEF, anticoagulation therapy for stroke prevention should be instituted on the basis of the CHADS-VAS score, with DUAX being the first-line option and warfarin as an alternative. In patients with AF and HFrEF who are deemed candidates for rhythm control, catheter ablation is preferred over pharmacological therapy alone. In patients with AF and HFrEF, catheter ablation success depends on the severity of LV dysfunction, functional class, comorbid conditions, hemodynamic stability, ventricular scar burden, and duration of AF, and atrial structural abnormality. So, in patients with AF and HFrEF who are not deemed candidates for catheter ablation, rate control does not score over rhythm control or vice versa. AF and HFrEF with CRTD and LVVB in whom AF remains poorly controlled despite maximum therapy, catheter ablation AV nodal ablation along with CRT should be considered. In patients of AF and HFrEF deemed potential candidates for rhythm control with CA, it is reasonable to consider doing the procedure early in the natural history of AF-HFrEF. Knowledge gaps and future direction of research. Specific mechanism of AFCM is still not known. Better refinement of patient selection for the timing of ablation of AF in HFrEF should be addressed in the future studies. Long-term outcomes of AF ablation in this population are not understood. The optimal ablation strategy for persistent and long-standing persistent AF remains uncertain. Should continuous AF monitoring for AF burden assessment be the standard of care in patients with AF and HFrEF undergoing ablation? If so, how long? Thank you. The role of AV nodal ablation with CRT implantation compared with AV ablation is definitely beneficial in the patients who do not respond to CRT alone. Thank you.
Okay, Dr. Ghosh, for giving us a lot of inputs in terms of heart failure with AF or the vice versa. Our next speaker is Dr. Dipankar Ghosh-Dastidar. Multimodality imaging in the Takotsubo cardiomyopathy?
Good evening, sir, and thanks to the organizers for having me here. I start my screen sharing. Hopefully, I am audible and visible.
Yes, you are audible, but not yet visible. Now you are visible and audible both.
Okay. Thank you so much, sir. So today I'm going to talk on multimodality imaging in evaluation of Takotsubo syndrome. Now, in Takotsubo, patients show transient left ventricular dysfunction presenting as apical ballooning or mid-ventricular basal or focal wall motion abnormalities. Right ventricular involvement can be present. The regional wall motion abnormality usually extends beyond a single epicardial vascular distribution. Now, as you can see in the systolic phase, there is likely to be apical ballooning and basal hyperkinesia. And it mimics the disease, the picture mimics Takotsubo, which is an octopus trapping pot. The most common involvement is the apical type, but other regions can also be involved like mid-ventricular basal type and focal type. It is almost always offset by emotional or physical triggers. The several of them are mentioned here. The ECG and the clinical presentation mimics acute coronary syndrome, from which it is at times very difficult to distinguish. Now, whenever the patient presents with ACS-like symptoms, one must look at the intertac diagnostic score, which includes whether the patient is of female sex, whether the emotional or physical stress are there. ST, should not be any ST segment depression, but only ST elevation. Whether there is a background of psychiatric disorders or neurologic disorders. So the total point, if it is more than 70, there is a high likelihood of the patient having Takotsubo syndrome. Now, in that case, if the patient is stable, one can go directly for a CT coronary angiography without going for the invasive coronary angiography. And if the CT angio shows normal vessels, then one might rule out myocarditis by looking at the symptoms or echo, like whether any pericardial effusion or something of those things are present or not. And if there is, all these are ruled out, one may do a cardiac magnetic resonance imaging to rule out any form of gadolinium enhancement or evidence of necrosis. There should not be any evidence of necrosis in cases of Takotsubo syndrome. So the main differential diagnosis of Takotsubo are ACS and other clinical conditions like myocarditis. So once those are ruled out, the condition is high probability of having Takotsubo. You can see the ECG changes and they mimic ACS a lot. So right now you can see the case of Takotsubo syndrome in the echo. You can clearly see the apical ballooning and basal hyperkinesia. And at times this basal hyperkinesia creates left ventricular outflow tract obstruction. And there are evidences of LVOT gradient also in Takotsubo syndrome. The angiography, if done, it typically reveals normal coronary vessels, like in this case, you can see, and there is a huge apical ballooning. Now, CT coronary angiography can show normal coronary vessels also. And you can see the CT scan of brain, there is a intracranial hemorrhage, which offset this case of Takotsubo syndrome. Now, this is evidence of LV angiogram where you can see the apical ballooning clearly and basal hyperkinesia. So other mid-ventricular or basal hypokinesia can also be there as rare presentations of Takotsubo. Now, this is a CMR sign imaging, and you can clearly see there is apical hypokinesia and basal hyperkinesia. So MRI seems to be a very important imaging modality to pick up in Takotsubo syndrome. Now, not only it can pick up the global and regional wall motion abnormalities, it can detect myocardial inflammation, it can detect myocardial necrosis, which should not be present in Takotsubo syndrome. Also, it can detect myocardial perfusion by doing a fast pass imaging. And it can also pick up complications like any evidence of pericardial effusion or LV thrombus or evidences of LV outflow tract obstruction. So these are evidences of MRI imaging, and you can see there is increased intensity in the apical region, mainly because of myocardial edema. By definition, Takotsubo should not have any myocardial necrosis or late gadolinium enhancement. So absence of myocardial necrosis in the matched late gadolinium enhancement images is a very important marker for diagnosing Takotsubo. So this is another sign imaging, and you can clearly see that there is some amount of recovery in this patient in this case. Now, this is you can see there is a LV outflow tract gradient associated with the systolic anterior motion of the mitral leaflets, suggestive of left ventricular outflow, dynamic left ventricular outflow tract obstruction in cases of Takotsubo, and there is also evidence of functional MR. Now, this is a strain imaging, and you can clearly see that there is red scale in the most positive radial strain. They are seen in the apical region. So again, suggestive of Takotsubo. So these are short axis views of the same patient, and again picking up that there is apical hypokinesia, again suggestive of Takotsubo. Now this is a 4D radial imaging, which has of late have come up, and 4D radial imaging is a lot better modality to detect mechanical abnormalities than our standard 2D or 3D echo imaging. Now, recovery after 3 months, you can see in the CMR imagings that there is now increased contraction in the apical region. Similarly, in the echo, previously there was apical hypokinesia, but now you can clearly see that there is good LV apical contraction. So recovery occurs after a gap of 2 to 3 months. Now coming to metabolic markers, which are very important, and these are also a good part of the imaging, you can see that there is a mismatch between the metabolic markers like 18F FDG vis-a-vis perfusion imaging by ammonia. The top panels, they show that initially there is reduced FDG metabolism in the apical region, but with normal perfusion. At 3 months of follow-up, you can clearly see that there is a good FDG uptake in the apical region, and the perfusion as usual was normal. So again, this kind of metabolic perfusion mismatch again is suggestive of Takotsubo. And there are a host of studies of FDG PET in Takotsubo. Now again, if you do a fatty acid metabolic marker like 123 iodine BMIPP scan, you can again see the same metabolic versus perfusion mismatch. Initially the apical region there was reduced 123 iodine BMIPP imaging with normal perfusion, and in the chronic phase you can see that there is resolution but good BMIPP imaging modalities at 3 months. Perfusion was as usual normal at all times. Again, host of studies with BMIPP imaging in Takotsubo cardiomyopathy. Now, a good marker is to look at the norepinephrine markers, like doing a 123 iodine MIBG scan, which we often do in cases of pheochromocytoma. Now, this is a marker of non-epinephrine. What exactly happens in Takotsubo is that now, whenever there is a stress, whether it is emotional or physical, there is a huge catecholamine surge. So immediately, the catecholamine, such huge loads of catecholamine, the cardiac, they go in the inhibitory mode to prevent myocardial necrosis. So basically, the apical region has got more beta-2 receptor supply, and there is selective preponderance of the beta-2 receptors in the apex. So what cause is that whenever there is a high norepinephrine spillover, these beta-2 receptors, they go in the inhibitory mode to protect the myocardium. So there is a mismatch of the MIBG marker also, which is found in Takotsubo. But when there is chronic catecholamine surge, as in cases of dilated cardiomyopathy or cardiac dysfunction in pheochromocytoma, or cardiac dysfunction in subarachnoid hemorrhages. When there is chronic catecholamine oversurge, this inhibitory mechanism is overcome and there is permanent damage and necrosis with biomarker release, which is not seen in Takotsubo. So in Takotsubo, the protective mechanisms, they prevent myocardial necrosis in the apical region by going in the inhibitory mode. But whenever there is chronic catecholamine surge, like in cases of pheochromocytoma, no more this protective mechanism can protect the apex. So there occurs contraction band necrosis and fibrosis. So there is late gadolinium enhancement in cases of pheochromocytoma, DCM.
Dipankar, please go fast.
Not in Takotsubo. And you can go for some other modalities of imaging like GRK2, beta arrestin, and CRB, which all are involved in cardiac protection. In Takotsubo, you can see the levels are all raised. So these are other myocardial marker imagings. Imaging can pick out complications of Takotsubo. Like can pick up pre-wall rupture, ECG abnormalities, LVOT obstruction, as already discussed. Sorry. So my take-home message is that it's a case of transient LV dysfunction. The regional wall motion abnormality extends beyond a single epicardial coronary artery, and there are several imaging modalities which can pick up this disorder. I thank you for your time and attention. Thank you.
Thank you, Dr. Dipankar Ghosh. It was a really excellent presentation and excellent colorful imaging display. I would now request the moderators and Dr. Dipankar Mukherjee or other co-chairs, if they have any point to make, they can do it within 1 minute. From moderator?
Yes, yes sir. Myself, Dr. Manoranjan Mandal, moderator. Every speaker has done very well in their respective field of topic. I think Dr. Devopra Mandal has given an excellent speech on the RVD. The first speaker, Dr. Priyam, has done a good disposition of the subject of restrictive cardiomyopathy, encompassing every subject. But I want to add one thing, that in some cases of restrictive cardiomyopathy, we encounter hemochromatosis with iron overload. And possibly this is the only subset of restrictive cardiomyopathy where it can be to some extent reversible with chelation therapy of iron. In other cases, there is no any specific treatment, and except we have nothing to do, we have to offer only transplant at the end. And Dr. Dipankar Ghosh has done very well in the field of Takotsubo. It is not very rare now in our continent. It is frequently encountered in our day-to-day practice.
Okay, fine.
Thank you, sir.
Sunandan, any comment to make? Brief. The other co-chair, I can see Dr. Dipankar Mukherjee. I don't know whether others are present here or not. So Dr.
Yes.
Dipankar Mukherjee may make some.
Yes, as the paucity of time, I think the speakers have given their good best, and we should now conclude the session. If you want to have any remark, you just say, sir, in 1 minute, and then you conclude it.
Dipankar Mukherjee, do you like to make any comment?
No, no further comment.
Thank you very much. The only small comment I have, that hypertrophic cardiomyopathy or left ventricular hypertrophy or any situations where end diastolic pressure is raised, there the atrial contraction is very important, because rapid filling phase, slow filling phase, is very little blood is poured into the left ventricle because of raise. If these patients have atrial fibrillation disturbed, the rhythm is gone, then the patient will be hemodynamic and very much disturbed. So in some situations, where rhythm control is more important than rate control. Okay, fine. Thank you very much all for being with us.
Thank you. So it was a session. Now we move on to the next session, that is listen from the masters. The chairperson for this session are Dr. Monotosh Paja, Dr. D.P. Sinha, Dr. Alok Majumdar, and Dr. Shantanu Guha. The moderator are Dr. Ashok Malpani, Dr. Raja Ray, Dr. Torun Praharaj. And the speakers of this session are Dr. Shoubhik Kanjilal, Dr. Bishwajit Majumdar, and Dr. P.K. Sahu. Now I hand over to the speakers, to the chairperson.
Now it's a good evening, very important challenging cases to be presented. And I think Dr. Kanjilal is the first speaker to present the case. Dr. Kanjilal?
Yes, sir.
Yes, please.
So good afternoon, everybody. First of all, I must thank the organizer to allow me to be present here and present a very important case. Well, it's an imaginary case though. We have a 36-year-old female patient with mitral valve replacement that presents with acute onset pulmonary edema, hemoptysis, and hypotension. And in emergency, there is no CTVS help available, which is very common in some places of our country. Now, how to go about it? Well, as the case suggests that this is possibly and most probably is a prosthetic valve thrombosis because the patient is having a prosthetic valve implanted, and the presentation is suggestive of thrombus itself. Well, by definition, valve thrombosis is any thrombus in absence of infection that is attached to or near an operated valve that occludes the part of blood flow or that interferes with the function of the valve. Now, though this is a very rare but a very serious complication, and fortunately, the annual incidence of mechanical valve thrombosis is only 0.5 to 8%. And it has been found that the obstruction of a right-sided mechanical process is almost 20 times more frequent than left-sided thrombosis. At the same time, mitral processes thrombosis is 2 to 3 times more common than aortic processes thrombosis. Well, it usually peaks around 1 to 2 years after valve implantation. And for the bioprosthetic valve, the chance of valve thrombosis is very, very rare, and it amounts to only 0.03%. Well, according to Virchow's triad, the main cause of this thrombus is basically three. One is endothelial or surface factor, which includes the biocompatibility of the prosthetic material with the surrounding tissues. At the same time, the hemodynamic factors, and these hemodynamic factors not only includes the hemodynamic of the prosthetic valve, but also the hemodynamic of the cardiovascular system as a whole. And similarly, hemostatic factors like hypercoagulable states, and the most importantly, the inadequacy of anticoagulant therapy, all might lead to thrombus formation. Well, the clinical manifestations are very much variable. The severe obstructive prosthetic valve thrombosis is typically associated with overt heart failure and cardiogenic shock, whereas non-obstructive prosthetic valve thrombosis, which is much more common, is often an incidental finding after an operation, or it can present as an embolic manifestations. Partial obstructions, for example, obstruction of a single leaflet, can manifest itself with an abnormal dyspnea or a systemic embolism. Well, whenever we suspect a case of a prosthetic valve thrombosis, we should go with some specific investigations, and we have transthoracic echocardiography and transesophageal echocardiography as a first-line agent to diagnose or to proceed with such cases. Along with that, we need to take help with scintillofluoroscopy and in some cases, multi-detector computer tomography. Well, according to SEC and AHA 2014 guideline, transthoracic echocardiography and transesophageal echography both are considered as a class 1 indications for suspected prosthetic valve thrombosis to assess the hemodynamic severity as well as to follow up the resolution of valve dysfunction after treatment. Scintillofluoroscopy or MDCT is also a class 2A indications, and they are required in some cases. Well, whenever we are talking about echocardiography, we should know the basic changes that we might expect to get in a patient of prosthetic valve thrombosis. Well, the most important will be elevated transvalvular gate gradient, and depending on the type of valve and the location of the valve, the gradient might change. Well, there are some direct signs of valve thrombosis in the form of abnormal cusp motility, as well as the presence of or the direct visualization of the thrombus itself. Along with that, reduced effective prostatic area, abnormal transprostatic flow, and the central prostatic regurgitation that suggests that incomplete closure of the valve are all the features of prostatic valve thrombosis in echocardiography. Well, when we talk about valve obstruction criteria for mitral processes, a mean gradient of 8 millimeter or more and an effective area of the process is less than 1.3 centimeters is indicative of prostatic valve thrombosis. Well, Fernandez et al. Also identified some other criteria, especially in case of mitral valve processes, and they showed that the peak E velocity of greater than 1.9 meter per second and the ratio of VTI in mitral to aortic more than 2.2. At the same time, the pressure half time more than 130 milliseconds are all indicative of mitral valve prostatic thrombosis. For aortic valve processes, the criteria of PVT are a mean gradient of more than 45 millimeter mercury and an obstructive index of 0.25, less than 0.25. And these are followed meticulously while we suspect a patient of prostatic valve thrombosis. Well, transesophageal echocardiogram is also very important because for proper thrombus size as well as localization, it is much better than transthoracic echocardiography. And another important point is that it can differentiate thrombus from pannus, which is very frequent in occurrence. And pannus, though it is a chronic representation, but pannus occurs much more frequently than thrombus. And it's very difficult to differentiate pannus from thrombus in transthoracic echocardiography. Similarly, vegetations also need to be excluded in such cases. Well, the mitral and tricuspid processes are better seen with transesophageal echocardiography, but aortic processes and the ventricular side of the mitral processes are not properly seen with transesophageal echocardiography. Well, this is how we differentiate pannus from thrombus. Usually the pannus are smaller in size and their distributions is peripheral, especially around the line of suture. And these pannus are usually very much echodense compared to thrombus, and they are usually immobile. So that is how we differentiate pannus from prostatic valve thrombus. Well, in some cases where we're expecting an aortic valve prostatic problem, and if you want to differentiate pannus from thrombus, multi-detector CT will be much more helpful. And the disc mobility, the change of disc mobility is almost equivalent with the fluoroscinography, and the biological leaflet thickening is better taken up with this MDCT. The limitations of MDCT in such cases are non-sinus rhythm in the form of atrial fibrillation, and in some cases, poor functional class patients can also be a problem in while we use multi-detector CT. Xenofluoroscopy was first used in 1980s, and it shows the leaflet motion opening and closing angles much more better than any other forms of investigations. And for to get a proper opening and closing angle, we need to have a proper views. And it has been found that the side-on view, also known as a tilting disc view, is better suited to assess the opening and closing angle of in xenofluoroscopy. And for that reason, if you consider mitral processes, the areocranial view, and for aortic process, the alocranial view are better suited to assess the opening and closing angle of such processes. Now, these are opening and closing angles. These angles are basically the distance between two processing leaflet. The opening angle when it is in systole and when in diastole, or when it is closed, the distance between two leaflets are known as closing angle. Well, manufacturers specify what are the normal range of opening and closing angle, and depending on that, we assess whether the valves are functioning properly or not. And of course, we need to assess 3 or 5 consecutive cardiac cycles to get a proper or better assessment of the opening and closing angle. Now, this is how opening angle and closing angle looks like in side-on view. Now, whenever there is a persistent restriction of leaflet motions, especially when the opening angle is greater than the normal reference value provided by the manufacturers, they are very helpful to diagnose a case of prostatic valve obstruction, possibly because of thrombosis. Now, whenever we have diagnosed a case of prostatic valve thrombosis, Well, the treatment is the most important part, because the choice between surgery and medical treatment sometimes will depend upon the location or size of the functional class of the patients. Now, if we consider the left-sided non-obstructive prosthetic valve thrombosis, now if the thrombosis is very small, of less than 5 millimeter in diameter, and they are non-obstructive in nature, medical treatment is preferred. By medical treatment, we mean heparin for at least 5 days. For larger non-obstructive prosthetic valve thrombosis, that is more than 5 millimeter, surgery are usually indicated in case of failure of medical treatment, or especially in case of a larger thrombus, which are mobile or pedunculated. For right-sided obstructive prosthetic valve thrombosis, well, fibrinolysis is straight away a treatment of choice, because the benefit of fibrinolysis clearly outweighs the risk of complications of fibrinolysis that we will discuss later on. Well, when we are talking about left-sided obstructive prosthetic valve thrombosis, well, then the options are the emergency surgery or thrombolysis, though emergency surgery is more preferred, and in some cases only thrombolysis are preferred. For surgery, we can do either a valve replacement or a selective thrombectomy. Since there is no specific randomized controlled trial comparing these two strategies, it's very difficult to formulate a specific plan of action. However, in 2008, ACCHA has provided a guideline that for obstructive left-sided prosthetic valve thrombosis, surgery is a treatment of choice. In earlier days, the mortality with surgery in very high NYHA class 4 patients were very high. It was about 50%, but with the development of surgery, with the anesthesia and the operative care, the operative mortality has reduced to a significantly lower level, to that in NYHA class 1 to 3 patients, the mortality is only 4 to 7%, and in NYHA class 4 patients, the mortality is only 17.5%. Now, if you consider the effectiveness as well as the complications of thrombolysis, hemodynamic success is almost 64 to 89%. But look at the complications here. The systemic emboli, the major bleeding, and the recurrence are significantly high. And Rodet et al. In 2009 has provided a comparative study of thrombolysis and surgery in obstructive left-sided prosthetic valve thrombosis. And though the mortality were almost equivalent, but the complications, especially the embolic complications and total overall complications, were significantly high with thrombolysis, and that has caused, or rather they relegated the thrombolysis as a second line treatment in such cases. Sorry. Now we have different thrombolytic agents for the management of prosthetic valve thrombosis. Now, if you are supposed to go with rescue fibrinolysis, where the patient is very ill and the surgery and the medical therapy with the heparin has not succeeded properly, then we go with this rescue fibrinolysis and with a shorter protocol. That means duration of therapy will be very short, and that can be done with either a RTPA with the 100 milligram total 100 milligram dose to be given over 90 minutes, or a streptokinase 1.5 million unit over 60 minutes without heparin. Now, in a hemodynamically stable patients, a longer protocol is followed with either urokinase or a streptokinase or RTPA, and this duration may be spread over 24 to 48 hours. Well, thrombolytic success is assessed with the reduction of more than 75% of thrombus burden in the largest diameter, as well as reduction of the transvalvular gradient to a normal level. And partial hemodynamic success is defined as a partial improvement of the transvalvular gradient. So according to the recommendations, the emergency surgery is recommended for patients with a thrombus left-sided prosthetic valve with NYHA class 3 or 4 symptoms. And emergency surgery is also reasonable for patients with a thrombus left-sided prosthetic valve with a mobile or large thrombus, even when it is a non-obstructive in nature. Fibrinolytic therapy is reasonable for patients with a thrombus left-sided prosthetic heart valve with a recent onset, that means less than 14 days, with NYHA class 1 to 2, and the thrombus has to be a small one. And for that, the fibrinolytic therapy occupies 2A recommendations. Similarly, fibrinolytic therapy is also reasonable for thrombus right-sided prosthetic valve. Now, this is a summary of different guidelines since 2005. As per SCCHA, emergency surgery is indicated in NYHA class 3 or 4 patients with a mobile or large clot burden, whereas fibrillatic therapy is mainly reserved for right-sided valves or in patients with very new onset thrombus with the class 1 or 2 symptoms, and the thrombus burden has to be lesser than 0.8 centimeters square. Similarly, ESC and SCCP, the guidelines are almost similar in the recommendations. That means that the more severe patient, more critical with the patients, surgery should be the treatment of choice, but only options where there is no possibility of availability of surgeons, or if the surgery is contraindicated because of the poor functional status of the patient, or if because of the repeated multiple surgeries prior, then femoral assist therapy can be resorted to. Now, this is the summary of how we approach a suspected case of prostatic valve thrombosis. The first and foremost would be a transthoracic echocardiography to evaluate the hemodynamic severity. And if there is suspicion, then we can go with CT or fluoroscopy to assess the valve motion. Now, if it is a right-sided prostatic valve thrombosis, then the choice will be very simple. It will be femoral assist therapy only after an IV heparin therapy. However, if it is a left-sided prostatic valve thrombosis, then transesophageal echocardiography has to be done to assess the proper size of the thrombus as well as the location of the thrombus. And depending on the size and location, if the patient is having a class 3 or 4 symptoms, then emergency surgery has to be undertaken. And if the patient's having a large thrombus burden or a mobile thrombus burden, then again, emergency surgery should be preferred. However, if the patient is not that much symptomatic, if the patient is only class 1 to 2 symptomatic, and if there is a recent onset thrombus, and if the thrombus burden is very, very low, that means the diameter of less than 1 millimeter or 1 centimeter, or the total area is less than 0.8 centimeters square, then fibrinolysis may be given to the patient in absence of surgical intervention. In other way, if a patient is critically ill, that means if the patient is having an NYHA class 4 symptoms, then either a rescue fibrinolysis if there is no surgical center available, or we can go directly to the surgery. And in stable patients, if the thrombus burden is large, or if we're not sure about the possibility of venous, go with surgery. And if there is a small thrombus of less than 0.8 centimeters square, then surgery or fibrinolysis both can be offered to the patient. Finally, if there is evidences of leaflet restrictions without any visible thrombus, then fibrinolysis may be of choice. So to conclude, prostatic valve thrombosis is a serious complication, though it's a rare one, and it associated with a significant morbidity and mortality. The incidence is higher for mechanical than biological valve thrombosis, and similarly, the right-sided prostatic valve has got higher propensity to develop thrombosis than left-sided valve. Non-obstructive thrombi are more frequently observed than obstructive thrombi, and that underlies the importance of adequate anticoagulation after surgery. Mobile or large thrombi, mainly more than 0.8 centimeters square, are usually treated with surgery. Critically ill patients with an NYHA functional class of 4 or obstructive prostatic valve thrombus or a large non-obstructive prostatic valve thrombus are all the indications for surgery. Obstructive prostatic valve thrombus with a small thrombus and stable clinical status can be treated with either a surgery or fibrinolysis. And non-obstructive prostatic valve thrombus with a small thrombus burden can be treated with fibrinolysis therapy or heparin itself. Finally, fibrinolysis has a good success rate in the treatment of right-sided prostatic valve thrombus with a low rate of associated complications. So thank you for your patience, and over to the moderator, please.
Thank you, Dr. Kanjinal. I can request Dr. D.P. Shina and Alok Majumdar and Dr. Malpani, Dr. Rajarai to participate in the discussion. Just 1 or 2 questions, please. Anyone? So, okay, Dr. Kanjala, if the patient reach in your hospital and the midnight, nothing, even tea and full school, nothing available. You have to diagnose with index of suspicion, acute pulmonary edema hemoptysis. So what will you do at moment?
Sir, could you put the questions at the end of the session, sir?
Okay, not individual.
Yeah,
okay. Yeah. Oh. So then there will be no interest at this. Okay, does not matter. Please, Kanjila, please share with us. Please wait after the end as per instruction of the.
Sure, sir. Sure, sir.
Okay, next. Next speaker, Dr. Biswajit Majumdar.
Good
Dr.
afternoon.
Majumdar, Associate Professor of Arjigar Medical College. He worked with my team in SSK Hospital for a long time. He is very, very sincere doctor and most dynamic intervention cardiology. Dr. Majumdar, please.
Good afternoon, sir. Respected chairperson, my teacher, Professor Monotos Maja, and distinguished audience and distinguished moderators. Today, my topic is a case-based presentation, recurrent angina in a young 36 years old man with severe triple vessel disease and familial hypercholesterolemia. So familial hypercholesterolemia is one of the common cardiovascular condition, but exact data is not known, especially in India. Its incidence is higher among Jews, French, Canadian, and Lebanese. Though it results in accelerated atherosclerosis and considerable cardiovascular mortality and morbidity, yet it remains widely underdiagnosed, undertreated, and understudied. It generally develops from several mutations involving the cholesterol processing like LDL receptors, FOB, and PCSK9 inhibitors. This is the short slides. I am not going in detail. There are two forms of familial hypercholesterolemia, both heterozygous and homozygous. In heterozygous familial hypercholesterolemia, without statin therapy, by 60 years of age, the risk of development of clinically significant CAD may be around 50% for males and around 40% for the females. In homozygous familial hypercholesterolemia, atherosclerosis and cardiovascular events may even begin very earlier, even in the second decade of the life. And it is often associated with other manifestations like tendon xanthoma, corneal arcus, etc. So it is a very important disease. It needs early detection because nowadays various therapy of lipid lowering strategies available that can prevent the premature development of aggressive atherosclerosis and may alter the prognosis of this very important disease, which is often undiagnosed. These are the diagnostic criteria. I am not going in detail. Usually Medfed criteria, Simon-Broom criteria, and Dutch criteria. Among Medfed is the simplest, and the Dutch criteria includes most variables, score more than 8 signifies familial hypercholesterolemia. I am not going in detail. Now coming to my case, the patient is very young, only 36 years old. He has recurrent chest pain. Exact classification and characteristic of the pain is not given. Probably he is suffering from chronic coronary syndrome. There is no suggestion from the history that it is a SCS. He has already diagnosed severe triple vessel disease, and there is family history of hypercholesterolemia, and most probably patient is non-diabetic and without any other addiction history. So while managing such cases, we must focus on the following points. Lifestyle modification is utmost importance in every cardiovascular case, and in this case also. Prevention of any adverse cardiac event that can be done by antiplatelet therapy and management of the lipid lowering therapy and relief of symptoms. Now management, lifestyle management, it is very important. It is one of the most important aspects of therapy and which often overlooks. It includes complete cessation of smoking or alcohol if these addictions are present. Physical exercise often neglected, that should be 30 to 60 minutes moderate exercise for at least 5 out of 7 days in a week. Healthy diet, that is also very important. Diet should be high in fruits, vegetable, whole grains. Ingested fat should be higher in PUFA, and saturated fat should be less than 10% of the total intake. And processed food should be avoided. Alcohol should be limited to less than 50 milligram per day, and BMI should be tried to maintain less than 25 kg per meter square, and waist circumference should be maintained less than 90. Now psychological risk factors should be also addressed, like stress, depression, anxiety, all should be treated and all should be tried to be avoided. And patients should also avoid pollution, especially heavy traffic congested area. Now coming to the next important medical therapy, role of antiplatelet, as the patient is suffering from probably chronic coronary syndrome, so single antiplatelet therapy like aspirin may be helpful. The role of dual antiplatelet therapy is very not approved at all, but in some special situation when there is aggressive atherosclerosis, it may be considered in the earlier studies, but Now, because of the availability of the COMPASS trial, this patient may probably benefit from addition of low dose of rivaroxaban in the form of 2.5 milligram twice daily. The management of dyslipidemia, this is the most important part of this patient. Since the patient is a known case of familial hypercholesteremia, management of the dyslipidemia is of utmost importance in this situation. A recommendation is to lower LDL-C by at least 50% from the base level and preferably to less than 55 milligram per DL. And our Indian guideline, LI guideline, has also become much more stricter. They targeted in these groups of patients to be LDL should be less than 30. The main drugs in our armamentarium are high dose atorvastatin, rosuvastatin, or simvastatin. If statin cannot achieve the target, ezetimibe can be added in the dose of 10 milligram per day. Now, often these patients cannot achieve the LDL level by combination of maximum tolerated dose of statin and ezetimibe. Here comes the role of PCSK9 inhibitors. And it is usually used in the form of evolocumab 140 milligram subcutaneously every 14 days or 420 milligram subcutaneously every month based on the Fourier trial, or aluricumab, probably not available in India, based on the Odyssey trial. PCSK9 have proven to be very effective in containing LDL-C levels. However, cost has been a big hindrance to their wider use. Very low level of LDL has been well tolerated. Fourier trial, the study was a randomized controlled double-blind trial. 2756 patients were included. Among these, 1378 received evolocumab and 13780 received placebo. Median duration of the follow-up was 26 months. The results were evolocumab significantly reduced primary outcome, CV death, MI, stroke, unstable angina, coronary revascularization. We reduced total CV events by 18%, fast CV events by 15%, and subsequent events. Side effects were same in the both groups and no neurocognitive decline was noted. The Odyssey trial, here alirocumab was studied and patient was 18924 patient and median follow-up was 2.8 years, and these results was alirocumab significantly reduced ischemic events including all-cause mortality, and it was a landmark trial which showed therapeutic benefit with reduction of lipoprotein LPA level independent of the LDL-C. So these cumab have shown effect on LPA. That is a very important, because LPA now has been considered a very important factor, risk factor, especially in India, that may be a role in the premature atherosclerosis in India, and this molecule has shown benefit in terms of lowering LPA. If patient fails in spite of all this therapy, then there are various novel therapies. One of them may be lipid apheresis. Other novel anti-lipid drug which can be tried in this patient if the patient do not fulfill the target LDL level in spite of all this therapy. These are mipomersen. This is an antisense oligonucleotide, inhibits ApoB synthesis. Lomitapide inhibits MTP, that reduces LDL-C, starts with 5 milligram daily and gradually titrated to maximum 60 milligram per day. Bempedoic acid, that is inhibits ATP citrate lyase, an important step in the synthesis of LDL. 180 milligram per day is the dose, found is highly effective in familial hypercholesteremia. Evinacumab, this is an FDA approved drug for homozygous familial hypercholesteremia. It is an antibody acting against angiopoietin-like 3 protein, and ELIPS trials has showed reduction of LDL by 49% at 24 months. Inclisiran, this is a very important molecule that has got EU approval, though FDA has not approved. This is an interesting molecule. It interferes with RNA that inhibits PCSK9 production by selectively silencing the mRNA of PCSK9. It is an also very advantage of this molecule. It can be given subcutaneously twice in a year. So that is a great advantage of this molecule. Other drugs like bile acid sequestrant like polycivalam may be also added, but it has a side effect of hypertriglyceridemia. ACE inhibitor may be added in this patient because ACE inhibitor has shown mortality benefit in these groups of patients. Now coming to the relief of symptoms, first medical therapy for angina, beta blocker, if contaminated calcium channel blockers can be given. Other drugs like Nicorandil, ivabradine, ranolazine, trimetazidine can be given to relieve the symptoms of angina. But the most important thing in this patient will be probably revascularization. Revascularization is generally considered if there is persistent angina despite adequate therapy. I think this patient was getting adequate therapy, and in spite of therapy, patient has got symptoms. And in this case, this patient is a high degree stenosis of TVD. He falls under the high risk category, more than 3% annual risk of death and MI. And as he is symptomatic with very high risk, revascularization may be beneficial. As we know, there are two options. One may be PTCA, another may be CABG. There is no clear-cut recommendation regarding PCI in familial hypercholesterolemia. According to Frame 2 trial, FFR guided PCI was superior to OMT regard to primary composite endpoint that include all-cause non-fatal MI and unplanned reverse hospitalization with urgent revascularization. And the IFR Heart study showed that the FFR was subsequently equivalent to those with FFR. Theoretically, we may assume that the study result will be extrapolated in the ER patient of familial hypercholesterolemia as well. If PCI is done, the points of consideration are complete revascularization will lead to high stent burden, which may increase the chance of stent thrombosis. It may miss the lesion which may develop in future. If CABG is done, points of consideration are complete revascularization cannot be obtained, which has additional benefit in the lesions of both present and future. It provides complete revascularization, thus more freedom from symptoms and outcomes. However, we have to keep in mind that rate of venous graft failure by 10 to 15 years, maybe 50%, which makes CABG less viable option in young patients. So take home message, patient with familial hypercholesterolemia are at increased risk of cardiovascular disease. The main target is to lower the LDL level. High dose statin is started initially. If target level of LDL is not achieved with, then ezetimibe is added. If still target not reached, PCSK9 inhibitor, then other novel therapy may be tried. For revascularization, CABG may be a better option. However, because of the young age of the patient and chances of venous graft blockage in the long term, complete arterial revascularization may be a viable option. Thank you.
Dr. Majumdar, excellent presentation, a very rare case. And of course, it may happen. It is a great problem how to manage the patient. Now, I think, please wait a couple of minutes. And we have to call the next speaker, Dr. P.K. Shao, who one of our friend. He's a dynamic interventional cardiology from Bhubaneswar. I think he will present the interesting case of the COVID situation, pandemic, and revascularization strategy. Dr. Shao, please.
Thank you, Dr. Panja, for your kind words of introduction. And in fact, this is the off-the-track topic because in this COVID-19 pandemic, what should be the revascular strategy? This is, at the end, I'll just present two short cases so that it will highlight how important revascularization is in COVID-19 patients. Now, I dedicate this talk to two of our Eastern India cardiologists whom we lost due to COVID. And because it's a topic on revascularization, we give our respectful homage to them. Now, what does this virus basically do? This virus causes a lot of problems, and among them, one of them is the acute coronary syndrome. Previously, we used to only realize that possibly venous thromboembolism and pulmonary embolism was something which is important. But gradually, we have come to the fact that acute coronary syndromes are also equally important, and quite a number of patients can have any of these cardiac problems. If you try to see the cardiovascular complications, you'll see basically that there is a decreased rate of acute hospitalization STEMI. That was why when at the beginning of the pandemic, we started thinking why the STEMI patients are not coming to the hospitals. There's increased risk of coronary stent thrombosis. We should be aware that these patients of post-stenting can have a risk of stent thrombosis. Most importantly, MI occurs in patients under the age of 30 years, and it has been seen also in post-vaccinated patients also sometimes MI does occur. There are many STEMI mimics where the ECG might or the TROP-T might increase and we might be confused. And there's an increased risk of arterial thrombosis, whichever part of the coronary or the vascular tree you consider in the whole human body. Now, initially when the COVID-19 came in 2019, we all have started thinking at where have all the MIs gone? there was a study which came up in 2021 which stated that there is a U-shaped phenomena which demands attention because a potential cause for decrease in STEMI incidence may include the avoidance of medical care. So it was seen that from this line, straight line, it started decreasing. Incidence of MI started decreasing because people were afraid to enter the hospital because they used to be afraid that COVID patients are there. But then came the lockdown, which started causing more problems. In fact, the Lancet came with an article in 2020 which stated that possibly the lockdown effect was something because of which patient would not be able to reach the hospital. Again, we're revisiting the same. The cases are rising in US and UK and in European countries, and we don't know what will be the situation in our country. Now, if I ask a question, is the coronary intervention management different in COVID era? Yes, it's different. Now, when the clinical challenge of ST elevation MI and COVID-19 was considered, this was an editorial from 2021, which I take from the JAC, which stated that there was an overlap in presenting symptoms. Included to this, there was elevated cardiac biomarkers, which would confuse us whether the patient really has MI or not. So the myocardial infarction that occurs in COVID-19 infection is basically two types. One is STEMI or non-STEMI, in which there is a total occlusion of the coronary artery, and the other one is just an injury without any obstructive coronary artery disease. So any of this, either of these two, we do counteract in our daily practice, and I'll try to show you certain cases to show there's an obstructive reason, there's a non-obstructive reason also. Now, something very important to know is that when the patient presents with STEMI, if he is treated early, the outcome is very good. Now, most of the times we have a delay in treatment. Because of this delay in treatment, you will see they have a downhill course, and this delay in treatment causes a bad LV and the LV dysfunction. And of course, if it is untreated, death will come fast because we have to recognize these cases early, electively in the window period, and have to see that delay does not occur, and we start treating these cases fast. Now, if you try to see what were the delays, first of all, the biggest delay was an emergency, where they would never let a patient get admitted unless the tests were done. All patients were treated like COVID. Sometimes they used to come with left ventricular failure, sometimes they used to come with chest pain, sometimes it has myocarditis. So there used to be a delay in the EMS. Next, the delay was in the diagnostics, because all hospitals never had a 24/7 COVID lab in which they could diagnose it. So patients used to be kept in the emergency, used to be treated like untouchables, and problems started. And finally, the biggest delay was in decision making. But after this whole thing was decided that the patient has got COVID and has got MI, decision making was a really big thing, whether the patient should go for thrombolysis or for a primary PCI. Now, why is there a poor outcome in COVID-19 STEMI? Because it was seen at the end of the first wave of COVID-19 outbreak, which experienced longer total ischemic time, which was translated into a major severe disease status. This is basically because of the delay that used to take place in identifying these cases and treating these cases. Even when this patient presented, if you see a non-COVID patient versus a COVID patient, you'll see the heart failure is more, the mortality is more, the cardiovascular mortality is more, the stent thrombosis is more, and the cardiogenic shock is more. So COVID patients usually come with all these entities in which they are in a higher Phillips class, in which they are really at high risk of death. Next, the challenge of AMI in COVID was basically three in nature. The risk of MI had to be diagnosed. Whether they will seek medical facilities or not, it was discussed. Lastly, whether they should be thrombolized or undergoing a primary angioplasty is very important, because what was in 2019 was that once they used to come to the emergency department, they used to be triaged, and only the very high-risk patients, high-risk STEMI or the very high-risk non-STEMI, would get the opportunity to go to the cath lab, and doctors used to shirk away from the duty of taking the patient to the cath lab because they always used to thrombolize them. But it was always said, first do no harm, thrombolysis is good, so definitely we thought that thrombolysis would be the best way to treat them. As we passed on, when we compared the patients who underwent primary PCI versus thrombolytic PCI, it was initially shown that the cardiac resuscitation, mechanical ventilation, the death was much higher in the primary PCI arm. This was a study which was published in 2020 in the American Journal of Cardiology, which showed that complications were more in primary PCI. Now, why these complications are more? There are more hypotension, more requiring vasopressors, more infarction, more dialysis, and of course, ischemic stroke. Basically, these were because of the fact that they reached late. Identification was late, and that is why they were treated late. Whereas the thrombolysis was given early once they were diagnosed, and the results were good. So then came the therapeutic challenge or the implications for the interventional cardiologist. That role of thrombolysis, as we came to 2020, it was shown that thrombolysis was definitely did not have a good role so far as COVID-19 patients were considered. Primary angioplasty was something which was more important. So is thrombolysis risky? Yes. In STEMI patients, thrombolysis first approach would yield more risk than benefit. This came in the European Society of Cardiology Journal in 2020, where they stated that we believe that coronary angiography should remain the cornerstone of the diagnosis strategy of STEMI patients, even in the context of COVID-19. So we're gradually moving from the paradigm of this thing that is thrombolysis to the paradigm of doing an early angio and doing an early intervention. Then why was it that thrombolysis was not a good choice? Why did this fibrinolytic therapy for escalation MI is not a good friend in the COVID-19 pandemic? Two Indians, Ajay Kirtane and Shripal Bangalore, gave a full perspective on this and showed that thrombolysis especially had a poor TIMI3 flow, there was recurrent ischemia, there was major hemorrhage, and non-obstructive disease was more in the COVID patients, and so they were not identified. So the same truth of the window of the golden hour stood good even for the COVID-19 patients. And we used to prefer thrombolysis basically to prevent staph exposure, and there were the chances of delay to reach a primary PCI capable center. Because at the primary center, they used to catch hold of the patients, and there was never a switch to the primary PCI capable center. 2020 came when a call for vigorous action was done from multiple centers. Study was done. This registry clearly stated that our data suggests that the health authorities, supported by the scientific societies, should take vigorous action to prevent patients from neglecting characteristic symptoms of an acute MI, especially among patients who suffer from hypertension. So we were moving from 2019 to 2020, where people started becoming more aggressive and started calling for vigorous action. Now, the EAPCI came in 2020 a statement that for emergency invasive management are not to postpone these cases of STEMI, non-ST elevation acute coronary syndrome were very high risk or patients with cardiogenic shock. The other patients fell into an urgent category, for example, unstable angina, left vent PCI, the last remaining vessel, angina pectoris class 4 were urgent, and the lower proximity, lower priority were where we could wait for certain at least 3 months or more than 3 months, especially CTOs and patients who are hemodynamic stable. Now, if you see these guidelines of EAPCI, it clearly stated that primary PCI has to be done. Once the network will come in the ambulance, they have to inform the capable center and primary PCI done. If the patient is self-presenting, then also primary PCI should be done as early as possible. If there is a hospitalized COVID patient and in hospital develops MI, primary PCI should be done. Any STEMI patient should be managed assuming positive COVID-19 status. So this is very important that one has to do, and they consider that ventriculography should be done at the time of prime PCI, know the LV function. For non-SPCS, the EAPCI statement was also very clear that especially patients having recurrent angina, unstable cardiogenic shock with any mechanical complication, acute heart failure, recurrent ST elevation should undergo immediate invasive strategy. Others were included in the high risk, intermediate risk, or the low risk, depending on the stability and also how much the symptomaticity was of the patient. Then came what were the lessons learned from 2020, how to prepare for 2021. You will see this arm in India, which showed that patients who had thrombolysis had done a poor outcome compared to those who had undergone intervention. And if you see the other countries, in our country, it was seen that 73% reduction in deaths and in primary major events occurred if you would do a primary angioplasty in these patients. So the emerging data in 2021 clearly states that obstructive CAD is quite common in these patients. We should not forget about it, and primary PCI remains the main strategy. High thrombosis is in previously stented patients were seen, and we have to accept that these patients have a heavy thrombus load. So in 2021, the swing came towards primary PCI when we moved from 2019 to 2020, gradually started climbing up the steps and started thinking that primary PCI should be the primary thing that should be done in cases of STEMI. But one should know that why primary may be a failure. Primary angioplasty is a failure because of the extensive coronary thrombus in patients present with STEMI and COVID-19 infection. What was concluded was that there is an increased thrombotic burden. The cytokine storm that occurs with AMI, there's a heavy micro and macrovascular thrombus burden, which results to poor PCI results. Now, this is something which you have to accept, that this was an article which appeared in 2020, that the high thrombus burden was seen in COVID patient with this thing that is COVID-19 patient. And what was seen that compared to the non-COVID patient, the COVID patient thrombus burden was to the tune of 80%, which is very high. Modified thrombus grade 4 to 5 and statistically significant also. One has to be very careful that these patients may require intracoronary thrombolysis because they have a high incidence of coronary thrombosis. So it was clearly stated that in 2021, when you become prepared for these patients, one should know that one has to only touch the culprit vessel, only revascularization. Don't try to open up all the arteries unless the patient is cardiogenic shock. Don't try to go for a complete revascularization. Just open up the culprit artery and just try to complete the job. So as we stand in 2021, where do we stand? So what is the current data and the future implications? The conclusion of this article, which appeared in Nature Review, clearly stated that early diagnosis of MI should be there. Do not miss the diagnosis. Take all safety precautions, take protection, and get a timely primary PCI done. And if there's no cath lab facility, then thrombolize the patient. That should be the dictum which we commonly follow and is recommended for the non-COVID patients. So the delay at whatever level is there should be avoided. The dictum should be prevent delays because we know these patients can be salvaged if early angioplasty is done. And in 2021, EAPCI again came up with a statement that urgent to be performed within hours or within days, a coronary angiogram in patients with class 4 angina, left main PCI, remaining vessel PCI. These were not non-urgent. In fact, it started becoming urgent. Coronary angiogram in decompensated ischemic heart failure or a non-infarct related artery where you have to do a staged PCI if the patient is having ongoing angina. Semi-urgent if there is class 3 symptoms, proximal LAD, and there's LV dysfunction and the stage PCI to be done. And electively beyond 3 months, the coronary angiogram of class 2 CTO interventions and patients who have diagnostic catheters of asymptomatic LV dysfunction. So you see in 2021, EAPC changed its dictum and put a grade higher so that people could be caught earlier and they could be intervened earlier. But the final play has to be in the cath lab. And the most important thing, you have to protect yourself and your staff from COVID-19. So recommendations were there how to protect yourself. The circulating staff, which is known to all, use the cap, the splash goggles, the effective mask, the fluid impermeable gown, the nitrile gloves, and shoe covers. The donning and the doffing should be done properly as per the guidelines. For the patient, just a surgical mask is more than sufficient, and this was the ESC guidelines, and this was a chart that was circulated. So I finally come to what are two real life scenarios of STEMI. This is just a 21-year-old male, which was on September 2020, almost a year back. The patient came with an antiviral MI and was COVID positive. What we see is a large chunk of thrombus. And whether to really do what is to be done here, as you said, as I have already said, is that we just go for maybe a thrombosuction and finally do. What I did over here was that I did an OCT in this case, just to know what was going wrong. And what you see in this OCT was very interesting, that you could just see large chunks of thrombus. Intracoronary thrombolysis was done. There was no fibrous plaque, or there was no atheromatous plaque for which I had to deal. And after giving them intracoronary thrombolysis, the patient did well and the coronary is cleared out. This is a case, another case of a 52-year male comes with antiviral MI, which was also done in 2020. Just few days after that first case, in the first the wave, in which also came with a total occlusion, in which I had to put a stent. Now, why did I put a stent over there? This was the pre and the post results. And the reason for putting a stent was that when I did an IVUS in this case, because the patient's creatinine was a little bit on the higher side, I saw that there was a plaque which was mainly fibrofatty plaque. There was an atheromatous plaque in addition to thrombus. And this was the post-stent results. So you have to be very vigilant about which cases you have to thrombolize which cases needs a PTCA. Especially if they are the elderly patients, they have a high burden of atherothrombosis, and these plaques rupture in COVID-19 situations and cause thrombosis. So to clear the thrombus and posterior to stent it. But younger group of patients, you can escape by just doing a thrombolysis in this patient. So what have been the paradigm shift in management? It was in the past, in 2019 to 20, it was just thrombolytic therapy when you should think that is more than sufficient. But as we step into 2021 and 2022, it is no more the pharmacoinvasive therapy. It is just that you have to take the patient to the cath lab and finish off the job, know what is the pathology by doing an imaging if required, and then finally finish off the job. Thank you very much for the patient here.
Thank you, Dr. Shah. Excellent presentation, a brilliant experience of work in field of this intervention cardiology, the COVID situation. So one or two questions can be asked. Dr. Sheena, other moderator and chairperson, anybody is there? Alok Mujumdar. Okay, first I think Dr. P.K. Shah, very excellent present, actually young patient, 21 age, you see, and OCT shows there are no atherosclerotic disease. Really, it is only the thrombus. So rightly he managed the aspiration sufficient. Where the IVAS study is done, or it is OCT done, that is plaque burden, you are rightly point out this stain is better. Anyhow, for the intervention cardiologists, we maintain a balance between the risks and benefit of the patient as a whole. You have to keep in mind. So any comment, Dr. Minal?
Yeah, I think all the speakers have done excellent job. Dr. Shovik Kanjilal on the valve thrombus, then Vishwajit Majumdar on familial hypercholesterolemia, and with the CCS, and lastly PK Shahu. PK Shahu, your lecture was really mind-boggling. Thank you so much for your beautiful presentation. And really, most of the points have been revealed in a very clear-cut way. In fact, CSI had his position statement on the management of acute coronary syndrome, and because of the heterogeneity of the various factors, especially the logistics, our recommendation for the the management of STEMI or ACA, especially the STEMI, was that if they come within 6 hours or 8 hours, then they can be thrombolized. And then depending on the various factors, improvement, then this can be subjected for CAG, and pharmacoinvasive therapy was recommended. But definitely in Western countries, they have shown more benefit of PPCI because they have the advantageous logistics as compared to our people. And we had to recommend that, and that was relevant at that point of time and even today. And otherwise, Shahu described everything in great detail, and that was a fantastic lecture.
Thank you, sir.
Thank you. Yes. So one question I have to ask Dr. Kanjilal, the acute pulmonary edema and hemoptysis at the midnight, patient reaching the hospital, when the fluoroscopy, nothing be possible at that moment, what will do that situation, Dr. Kanjilal?
If fluoroscopy is not available, at least transthoracic echocardiography should be available in such in our hand. So if that is available, then our job will be a bit easier in such cases. And if, say, in case of a primary care center or even a secondary care center, if even those things are not available, then I think we should give benefit of doubt to the patient and should start thrombolysis. Though the chance of thromboembolism in such cases is pretty high, but still we have no other options in order to take a chance for the patient.
Yes, absolutely correct. In my opinion, same. There is acute left ventricular failure, then the indexes of suspicion must be maintained. So thrombolysis, particularly streptokinase, who is available lower cost, so definitely we can give it to save the life of the patient. Right, in my career, altogether 7 cases. I can remember out of 7, that is 5 cases still alive. They are doing well. Thank you. All the speakers done well. Dr. Mujumdar, also great chronic problem, peripheral vessel disease, familial hypercholesterolemia have nicely presented. And whether the surgery or the PTCA or it is angioplasty is controversial. So, Dr. Biswajit, what your final opinion regarding the surgery versus PTCA presence of multiple vessel young patient with hypercholesteremia? In conclusion, this. Okay, I think you are missed it. Anyhow, so therefore you have to, because young patient, familial hypercholesterol vessel disease, definitely we have give the medical therapy, just like a chronic stable angina. If it's very symptomatic, if it is lemon disease or a proximal LAD disease and other main vessel disease, that case is definitely surgery to be considered. Okay, thank you. Dr. Minal, all the speakers done wonderful job for us and for greater upgradation on knowledge, all the listeners as well as ours among ourselves. Thank you, Dr. Sao and Biswajit Majumdar and Kanjila.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Thank you, respected speakers, for that brilliant and enriching session. Our next session deals with antiplatelets. Speaking on this topic will be our esteemed speakers, Dr. Debabrata Roy, Dr. Arnab Datta, Dr. Shoujata Chakraborty, Dr. Tanmay Mukhopadhyay, and Dr. Manish Shah. Moderating this session will be Dr. Pranab Kumar Biswas, Dr. Shourangshu Chatterjee, and Dr. Lipika Adhikari ma'am. Chairing this session will be Dr. Ajit Shatpati, Dr. Shivananda Datta, and Dr. Jayanta Datta. May I please request the moderator to carry forward this session.
Dr. Datta is here. If
I'm here, sir.
Dr. Sahu.
Yes, sir.
Just chair the session.
I'm not aware of the program also, sir. I'll have to see this payment, sir.
Okay, we'll guide you. Now the first speaker is Dr. Debabrata Rai, DAPT, duration of DAPT following ACS recent modification. It's a recorded lecture.
Yes, sir.
Good evening, ladies and gentlemen. I am proud and privileged to deliver this talk on duration of DAPT in patients undergoing PCI for acute coronary syndrome. Now, DAPT is almost an established modality after PC. But as suggested by Stuart Pocock and Bernard Gash, sometimes we should do trials to see whether the so-called established therapy really produce benefit to the patient, really helps the patient in terms of causing no harm, or if there is no difference compared with continued medication. So why we don't want DAPT? So what DAPT means? It means usually combination of a P2Y12 inhibitor with aspirin. Now, many of us, we want an aspirin-free strategy after ACS-PCI, the rationale being to reduce the gastrotoxicity and bleeding chance, to avoid vasoconstriction that you can have at a higher dose of aspirin, and because we now have more potent agents in the form of P2Y12 inhibitors. And of course, we cannot forget about the issue of aspirin resistance. Now, why bleeding is important? Because both Acuity and Adaptase showed that if you have any major bleed after discharge and within 30 days after discharge, it is going to increase your risk of mortality significantly. Now let us see what the trials tell us. The first is the DAPT trial conducted in 2014, where both patients with stable ischemic heart disease and ACS who underwent PCI with DACE, they were randomized to receive either a dual antiplatelet therapy comprising of clopidogrel and aspirin for 18 months versus aspirin alone for 18 months after an initial phase of DAPT with clopidogrel and aspirin for 1 year. It has demonstrated that if you continue with long-term DAPT, definitely you are going to have a reduction in ischemic events or MACE, but that comes at the risk of increased bleeding. So this led to more newer trials. And the first is global leaders in 2018 conducted over 16,000 patients where ticagrelor monotherapy was tested against a DAPT of clopidogrel and aspirin. So with this ticagrelor monotherapy, there is a decrease in mortality and new QFMI also, and there is no significant difference in bleed. Then we have two trials in 2019, stopped DAPT-2, where clopidogrel as monotherapy was tested against DAP after an initial period of DAPT for 1 month, where again we have a reduction in ischemic events as well as major bleed with clopidogrel monotherapy. And then we have the Twilight ACS sub-study, which includes more than 4,000 patients of ACS undergoing high-risk PCI, were randomized to receive ticagrelor for 12 months versus ticagrelor plus aspirin for 12 months after an initial 3-month period of DAPT comprising of ticagrelor and aspirin. Again, with ticagrelor monotherapy, we had no difference in death, MI, or stroke, but at the benefit of substantial low bleeding. In 2020, we have a smaller trial, that is Smart Choice, where the patients received clopidogrel and aspirin for 3 months, followed by 9 months of clopidogrel monotherapy, or the clopidogrel or aspirin was continued for 12 months. Again, there is no difference in death, MI, or stroke with lower bleeding. There are a few trials where enteric-coated aspirin is used, but it is better, it is to be avoided because enteric coating reduces the efficacy of aspirin. Now, what about patients who are at a low bleeding risk? So this is a latest trial, OPT-PEACE from China, which was presented in TCT in November 2021, where 505 patients with low bleeding risk who had either stable ischemia or non-STEMI underwent PCI with DES. They received 6 months of DAPT comprising of clopidogrel and aspirin, followed by only clopidogrel or aspirin for 6 months, or this DAPT was continued for 12 months. Again, there is decrease in, not only there is decrease in bleeding in the monotherapy arm, there is also a decrease in gastrointestinal injury in the form of erosion or ulceration or bleeding. What is important is to observe that when we come to the secondary outcome, we found that there is no difference in ischemic events between clopidogrel or aspirin SAPT strategy. And quite rightly, an editorial came out in JACC along with this trial, and the editors, they requested us and they commented that this trial should compel cardiologists to start thinking like gastroenterologists. So how we go about this? On one hand, we have the bleeding risk. On the other hand, we have the risk of ischemic events and MACE. So this risk difference for long and or short-term DAPT can be decided on the basis of precise DAPT score in patients with or without complex PCI. As you all know, the precise DAPT score is based on 5 factors, that is age, creatinine clearance, hemoglobin, WBC count, and history of previous significant bleed. So based on that, we can divide the patients into 2 groups who had a score less than 25, who belong to the non-high bleeding risk group, and with a score more than 25, who belong to high bleeding risk group. So less than 25, non-HBr, more than 25, HB. So if you have a patient with bleeding risk, so the short DAPT reduces the bleed for both types of PCI, complex or non-complex. Now, if you consider ischemic events, if a patient belongs to the non-HBr group, non-high bleeding risk group, long DAPT performs better for complex PCI. However, if you have high bleeding risk, short DAPT has better outcome for both complex or simple PCI. What about MACE? Again, if your patient belongs to the non-high bleeding risk group, long DAPT gives better outcome for patients undergoing complex PCI. But if your patient belongs to the high bleeding risk group and is undergoing a non-complex PCI, short DAPT will be better. Now, which monotherapy we should choose? As you have seen in the DAPT trial where we basically used aspirin, the risk of ischemic events was high. But in the newer trials where we have used the P2Y12 inhibitors, there is a consistent improvement in outcome as regards ischemic events and MACE. So based on the trials, we can say that ticagrelor and prasugrel, which are more newer agents, they will perform better than clopidogrel. Why? Because they have a more rapid, more greater, more consistent inhibition of platelet aggregation, which is likely to translate into more clinical benefit. And more importantly, that both ticagrelor and prasugrel is immune to any effect of CYP2C19 as shown by the principal TIMI44 and DISPERSE-2 trial. Now, which one to choose between these two newer agents, ticagrelor or prasugrel? As the ESA React 5 trial has showed us that the prasugrel has performed better than ticagrelor for reducing death, MI, stroke, or stent thrombosis as compared with no difference in bleeding events. However, this decision of starting prasugrel, there are still some debates about it. But if you plan your patient for early invasive strategy, prasugrel is recommended for loading before PCI. What about cangrelor? We know it's an IV antiplatelet and can be used as a peri-procedural therapy. It is definitely better than clopidogrel and even better than crushed ticagrelor or prasugrel. And we have seen that in patients who has a larger CKMB elevation, the beneficial effect is more pronounced, as demonstrated by the Champion Phonics trial. And what is important, you can administer opiates along with cangrelor, and there is no diminution of efficacy of cangrelor with co-administered opiates. Is there any role of genetic or platelet reactivity testing? As per the recent data, there is no proven efficacy. However, we have seen that if you use newer generation stents, the third generation stents, they give better result with monotherapy. So this is basically the summary of what I have told so far. This is the ESC 2020 guideline on STEMI, where they have classified the patients based on bleeding risk, low, high, or very high. So if you have high bleeding risk, your DAPT should be limited to first 3 months. And if it is very high, it should be limited to first month. And your monotherapy for very high can be clopidogrel, and for high, it can be aspirin. However, in many trials, they have shown that clopidogrel performs better than aspirin. Now, what about low bleeding risk? In low bleeding risk, either you can go for a 3-month initial therapy with ticagrelor and aspirin and follow it up with ticagrelor monotherapy. Or if you think you have done a more complex procedure, then you continue with the DAPT in different combinations of aspirin and P2Y12 inhibitors for 12 months and follow up with DAPT if you think the ischemic risk is high, maybe for beyond 12 months. Thank you.
I think the next speaker is Dr. Arnab Datta on coronary artery disease and atrial fibrillation. What is the role of antiplatelets and antithrombotics? We know that there has been a change in the strategy for polyvascular disease, and that is why the role of antithrombotics also come into play. So can we hear over to Dr. Arnab Datta, please?
Thank you, Shahu sir. Good evening, my seniors, colleagues, friends, and juniors. At the outset, I would like to thank Dr. Lipika Udhikari for giving me an opportunity to speak on this August occasion of CSI West Bengal Branch Update Session 2021. I will be speaking on coronary artery disease and atrial fibrillation and the role of antiplatelets and antithrombotics. In my talk, I'll be focusing mainly on acute coronary syndrome, presentation of coronary artery disease in patients with pre-existing atrial fibrillation, as well as I will be focusing on patients of chronic atrial fibrillation who suddenly develop acute coronary syndrome. Right. What is important to understand in the mechanistic approach is that atrial fibrillation and coronary artery disease, PCI, are two separate things we are dealing with in the same patient. On the one hand, we are mainly concerned with stent thrombosis in PCI, where we know that platelets act better than anticoagulants. On the other hand, thromboembolism due to or cardioembolism due to atrial fibrillation is better taken care of by antithrombotics rather than dual antiplatelet therapy. So we have to balance between the high shear states platelet-rich thrombi on one hand for stent thrombosis and acute coronary syndrome and PCI, with the low shear stress thrombus-rich less platelet-dependent thrombus, which act better with anticoagulation. So striking a fine balance between the two is very important at the expense of bleeding, which is always on the back of the mind in these patients, many of whom may be quite elderly. What is important to remember that oral anticoagulation therapy and antiplatelet therapy are synergistic, in the sense that direct thrombin inhibitors of factor 2A and 10A, as well as antiplatelet agents, may it be aspirin or P2Y12 inhibitors, synergistically target two different but essential components of thrombosis. One is coagulation factor, coagulation pathway, and the other is platelet activation. There you can see in that diagram that the mechanism of action of the antiplatelets and the antithrombotics is quite different but interrelated to one another. The WOES trial was the first trial in 2013, which actually made opened our eyes regarding this regimen of combining antiplatelets with antithrombotics. Prior to WOES, you can see here in this meta-analysis of 2010 that we really did not have the NOACs or the novel oral anticoagulants. So in these cases, bleeding risk was really very high, particularly with triple therapy as well as with warfarin with a single antiplatelet agent. With the advent of NOACs in the last 5 to 7 years, the risk of combining NOAC with a relatively safer P2Y12 inhibitor, that is clopidogrel, so it was thought that the bleeding risk could have been much lesser. So the VOICE trial, which was published in 2016, took up patients on dual therapy, either with clopidogrel with oral anticoagulant versus triple therapy, that is dual antiplatelet therapy along with oral anticoagulant therapy, and then 1 month initially for a bare metal stent and 1 year for a drug-eluting stent. This was actually a European trial done in Netherlands and Belgium. And there you can see for the first time that compared to triple therapy, double therapy with clopidogrel and an oral anticoagulant agent was associated with much lesser event rate, combining both ischemic and bleeding events together. So the risk of death, MI, stroke, stent thrombosis, and target vessel revascularization was much less with double therapy rather than with triple therapy. So VOICE study was the first study which actually focused our attention on the feasibility of giving dual therapy in patients of atrial fibrillation who have undergone an PCI in the setting of an acute coronary syndrome. So this was the final data where you can see compared to triple therapy, double therapy group fared much better in all endpoints, safety endpoints regarding bleeding. The p-value was very highly significant. You can see here that there was approximately 25% bleeding risk reduction, and follow-up after 1 year also had a significant lower bleeding risk. But on the other hand, compared to triple therapy, double therapy did not have higher rates of death, MI, TVR, stroke, or stent thrombosis. The other important trial was the Pioneer AF-PCI trial for prevention of bleeding in patients with atrial fibrillation undergoing PCI. And here, a newer NOAC, that is rivaroxaban, was used along with aspirin and clopidogrel, and the patients were followed up for 1, 6, and 12 months. And the primary and secondary endpoints were bleeding was the primary endpoint, and the efficacy endpoint was the secondary endpoint of death, MI, stroke, and stent thrombosis. The other most important trial, which has been published later, was the redual PCI with dabigatran compared with warfarin. And that again showed that combining NOAC in the form of dabigatran with a P2Y12 inhibitor had a much lower primary endpoint as well as safety endpoint on intermediate and long-term follow-up. So there you can see that instead of giving warfarin triple therapy, if you combine dabigatran with a P2Y12 inhibitor, particularly clopidogrel, there was significant reduction in major bleeding, in non-major bleeding events. So that is why in 2017, there was a revision of the guidelines of the ESC, where it was shown that patients who of atrial fibrillation who are on oral anticoagulant therapy and have undergone PCI, they said that there was no default strategy. That is, same size does not fit all, but you have to consider the bleeding and the ischemic risk against each other before making the final decision. But what was important, which was highlighted again and again, that triple therapy, the role of triple therapy, particularly warfarin, aspirin, and clopidogrel, probably its days were numbered and it was a therapy of the past. Maybe in the very limited patients with very high ischemic risk and relatively low bleeding risk, a triple therapy for a duration of at the most 1 month could be done for these patients, and then you could always shift to a dual therapy with a P2Y12 inhibitor, particularly clopidogrel, along with one of the NOACs. So this was what was the recommendation by the ESC, final recommendation, which said that maybe triple therapy with aspirin, clopidogrel, and an oral anticoagulant agent for maximum in-hospital stay of up to 1 week. And then maybe for those with a very high ischemic risk, a triple therapy for 1 month may be acceptable for some patients, but for standard risk patient, a dual antithrombotic strategy with a NOAC, with a single antiplatelet therapeutic agent, preferably a P2Y12 inhibitor in the form of clopidogrel for the next 1 year, followed by oral anticoagulation alone, where you withdraw all antiplatelets. Latest trial to be presented in this category of patients was the Augustus trial, which was comparing the newer oral anticoagulant agent apixaban and a dose of 5 milligram twice daily with oral VKA agent. And there was a double-blind study and 2x2 factorial where aspirin also was added to selected patients on the day of ACS, and they were followed up with either apixaban and aspirin or warfarin with aspirin. And there you can see that the combination of apixaban and aspirin had a much lower non-major bleeding risk compared to combining warfarin with aspirin. So that was the Augustus trial, which was published in 2019. And you can see that giving only apixaban in these patients on long term also had an 11.4% risk reduction of bleeding, which was very significant in the sense that only 9 people were needed to be treated to reduce one event. So that was a great conclusion from this trial. And there you can see that using a single NOAC in the form of apixaban for 5 milligram twice daily was associated with the least chance of death and hospitalization in these patients. In 2020, I have been talking about ESC till now. ACC also come out with an expert consensus decision pathway for anticoagulation and antiplatelet therapy in patients with atrial fibrillation who have either are undergoing PCI or have underlying coronary artery disease. Just to remember that approximately 10% of patients with a recent PCI may have or will develop concomitant atrial fibrillation in the future. So choosing the optimal antithrombotic regimen should be a challenge in these patients. But what it has highlighted is that the use of triple therapy is not recommended for most patients due to an increased risk of bleeding. If triple therapy at all is needed, a short duration, maybe 7 days in hospital, but definitely not more than 30 days is recommended. And that too, it is better to combine a NOAC with a P2Y12 inhibitor, in most cases clopidogrel, and if aspirin has to be combined, the dose should be definitely less than 100 milligram per day. But you have to remember that for these patients taking more than 2 antithrombotic agents together, it is essential to keep these patients continuously on PPI and avoid all other anti-inflammatory agents because of the high GI bleeding risk in these patients. Also, for patients with atrial fibrillation who are already on anticoagulation, who might need PCI due to coronary artery disease in the course of time, use of a direct oral anticoagulant, that is either likely a factor 10A antagonist or a factor 10A antagonist, is preferred over VKA when appropriate. Oral anticoagulation, that is a NOAC plus a P2Y12 antiplatelet combination, preferably clopidogrel, is recommended for the first 6 to 12 months, potentially switching from clopidogrel to aspirin after 6 to 12 months if the patient is a case of stable ischemic heart disease who has undergone PCI. And after 12 months, only NOAC monotherapy should be the way to go about in these patients. For patients on antiplatelet therapy who develop new atrial fibrillation in the course of time, for primary cardiovascular prevention, switching to anticoagulation monotherapy is recommended. But for PCI with stable ischemic heart disease or acute coronary syndrome, use of oral anticoagulant plus a P2Y12 inhibitor for not more than 12 months is recommended, which I said earlier also, which is now we are saying double therapy, combination of a NOAC with clopidogrel. For patients with cerebrovascular disease without carotid stenting or peripheral arterial disease, a short course of anticoagulation with clopidogrel may be recommended, followed by oral anticoagulation alone. This is for those who have not undergone a stenting in either the cerebrovascular tree or periphery. That is conservatively managed, medically managed patients of cerebrovascular and peripheral arterial disease. Maybe you give double therapy for a short course, followed by long-term anticoagulation, provided the patients have not been put in a stent. And for patients taking NOACs who require PCI, most NOACs can be withheld for not more than 36 to 48 hours prior to the procedure. But if you need to hold the DOAC for longer periods of time, that is only for patients with concomitant renal dysfunction, moderate to severe, with estimated GFR maybe less than 30 mils, especially if these patients have been previously on dabigatran. And to conclude, when used in combination with antiplatelets, it is very important to remember that the dose of NOACs should follow the FDA recommendations for stroke prevention in atrial fibrillation. That is the standard dose, except that rivaroxaban may be administered at a dose of 15 milligram or a reduced dose of 10 milligram if the estimated GFR is less than 50 when combined with P2Y12 inhibitor based on the study which I said earlier, the Pioneer AF PCI study. So to conclude, triple therapy is now only of academic importance and should only be given to those with highest ischemic risk for a minimum period as possible, but never more than 30 days. For other patients, the best therapy of combining novel oral anticoagulant agent along with clopidogrel for the next 12 months is the best strategy as far as coronary artery disease treated with PCI in the setting of ACS with atrial fibrillation is concerned. And if the patients remain stable after 6 months, you can substitute aspirin for the P2Y12 inhibitor, continue aspirin and NOAC for another 6 months, and then switch on to NOAC for the next, after 1 year, for the next lifetime. So more is not better. That is the strategy for managing coronary artery disease with atrial fibrillation. You have to be prudent because bleeding is a very important consideration in these patients. And hence, to balance and the risk between ischemia and bleeding is important, and maybe less is better in this important but difficult to treat group of patients. Thank you very much.
Thank you, Dr. Datta, for giving a extremely good exposition on the common problem of coronary artery disease with atrial fibrillation. In fact, this is a very practical problem, and many a times we're confused about what we have to give and what we do not have to give. So you have made all the points clear based on all the trials that have been studied and what is to be given in which this thing that is subset. can I invite Dr. Saujatya Chakrabarti to talk on the TB major bleeding following thrombolysis, how to manage, because this is a very important topic. And can I ask, because is Dr. Any of the panelists there? Yes.
Dr. Saujatya Chakrabarti is not present. So we can call the next speaker, Dr. Tanmay Mukhopadhyay. See, and he will be speaking on ICER-React 5 critical analysis.
All right. Dr. Chakrabarti, Dr.
Tanmay Mukhopadhyay.
Dr. Mukhopadhyay, please. Dr. Soranshu, can you take over this session as
Yes,
you're there?
please.
And yes.
I'm here.
Yes, yes.
Here, the next topic is ICER-React 5, a critical analysis. Basically, non-ST segment elevation ACS, whether to choose prasugrel or ticagrelor will be discussed in the ICER-React trial. I would request Dr. Tanmay Mukhopadhyay to start the proceeding.
Good evening, everybody, respected chairpersons. This is a privilege to present the topic here. My topic is critical analysis of ICER-React 5 trial. Before going to trial proper, a few words about the background. Why ICER-React trial was conducted and what was the necessity. We all know about two landmark trials, that is Triton-TIMI 38 and Plato trials. Triton-TIMI 38 compared clopidogrel versus prasugrel, and Plato did it with ticagrelor versus clopidogrel. And it has been seen that prasugrel is superior than clopidogrel in Triton-TIMI 38 as far as primary outcomes are concerned, and ticagrelor is better in Plato. And again, primary outcomes were better in ticagrelor group. So based on these landmark trials, prasugrel and ticagrelor both received as one recommendation for use in patients who have acute coronary syndrome with or without ST segment elevation. Head-to-head trial was
So, share your slides, please. Your slides are not visible.
Should I rewind?
Yes, sir. Kindly share it, sir. Can you able to see share screen option, sir, bottom center?
Do we have a recorded version of this topic?
Is it okay now?
No, sir,
only
you are unable
being
to.
seen,
So you have to
not your
share the
slides.
screen. So just
You have to
click on
share the
share.
screen.
Just click on share screen, green icon.
I did it.
Yeah, then you have to select your PPT. Then again you have to click share.
Yeah, I have done. I'm rejoining.
Yes, please rejoin.
When Dr. Tanmay's slide is getting ready, can we ask the next speaker, Dr. Moni Shah? Dr. Moni Shah, are you ready? Dr. Moni Shah?
Yes, madam, I am ready.
Okay, then you can present prior to Dr. Tanmay Mukhopadhyay. Welcome, Dr. Moni Shah. Your topic is prosthetic valve and TAVR, the current guideline for anticoagulation.
Okay, let me share my screen first.
Okay, proceed.
Is it visible?
Please enlarge your slide.
It is visible.
Yeah.
Yes.
Slide show.
Visible, the slides are moving on the screen.
Slides are
First slide is
visible, but
visible,
make it full screen.
Second
but you have to
slide,
enlarge it.
slides are visible, sir.
Sir, slides are visible. Kindly make it full screen. Slide show.
I have made it full screen.
No, then you have to stop share.
Stop share.
Yeah, stop share.
Yeah.
Then
Yeah.
again click on share screen.
Share
You
screen.
can select a full screen option. There are two PPTs available in your application window. Just
Yeah.
select full screen one and
Okay. Tormada is trying to share his screen.
yeah. Okay, so yeah.
Okay,
Sir,
Dr. Tanmay, please start your proceedings.
Okay.
so this is coming from okay. Sir, kindly
So you have
unmute.
to start from the
Sir,
beginning.
kindly unmute, sir. Kindly unmute. Yeah, please proceed.
Should I restart?
You start from your first slide.
Okay. So in background, we see that that there are two landmark trials. One is Triton-Timi 38 and another is Plato. Triton-Timi 38 compared prasugrel versus clopidogrel, and it came out to be superior results with prasugrel as far as primary outcome were concerned. And in Plato trial, ticagrelor did better, and primary outcomes were favorable for ticagrelor. Now, based on these trials, prasugrel and ticagrelor both received class 1 recommendation for use in patients who have acute coronary syndrome with or without ST segment elevation, but there is lack of head-to-head trial. So we didn't have any answer which one is better, ticagrelor or prasugrel. So that was the unanswered question, and for that reason, there is need for head-to-head trial, and ISAR-REACT 5 trial was conducted. That's why. This ISAR-REACT 5 trial is the multi-center randomized trial, and patients are randomly assigned who presented with acute coronary syndrome and for whom invasive evaluation was planned. They received either ticagrelor or prasugrel, and primary endpoint was composite of death, myocardial infarction, or stroke at 12 months. Major secondary endpoint, that is the safety endpoint, was bleeding, and that was assessed according to BARC criteria. Now, study design, patients are categorized into STEMI and non-ST elevated. After randomization in STEMI group, all patients receive pre-treatment with either ticagrelor or prasugrel according to randomization. Then coronary angiogram and invasive strategy was taken, and they were followed up with ticagrelor or prasugrel maintenance dose for next 12 months. For non-ST elevated groups, the pre-treatment with ticagrelor was given, but prasugrel was used as pre-treatment agent only after knowledge of coronary anatomy after doing angiogram. And then follow-up was done with ticagrelor or prasugrel maintenance dose for 12 months. Inclusion criteria: ST elevated myocardial infarction, non-ST elevated myocardial infarction, unstable angina, and adult patients, that is age more than 18 years. Major exclusion criteria: intolerance to the agents, history of stroke, TIA, intracranial bleeding, neoplasm or aneurysm, active bleeding, fibrinolytic therapy in less than 24 hours of randomization, thrombocytopenia, unfavorable INR, recent oral anticoagulation, CKD with dialysis, and so on. Now, if we consider there is not much difference. Only thing is a little bit of more number of patients with ST elevated MI and NST elevated MI in ticagrelor group, although these are statistically irrelevant. The primary endpoint, after analyzing everything for 12 months, it was seen that ticagrelor is clear winner here, and all cause death, MI, they have favorable outcome Prasugrel is clear winner here, and all-cause death, MI and MI stent thrombosis, everything was in favor of Prasugrel. And the safety profile, that is bleeding, here Prasugrel again did better, but statistically this is not that much important, as p-value is just 0.46. So clinical endpoints, we can see that MI is more in ticagrelor group than Prasugrel group. It is 96 and this is 60, and this is the classification of MI, and others are not that much different. So based on this trial, ESC has recommended Prasugrel should over ticagrelor for non-ST elevated SCS patients who proceed to PCI. This is class 2A recommendation. But thing is that whether this is so straightforward that Prasugrel should get better place in recommendation than ticagrelor. And there are some debates regarding the outcomes of ISERDIAC 5 trials. So to start with strength of the study, and this is large multi-centered randomized control trial. It has included almost more than 4,000 people. It included 2 countries, one is Germany and another is Italy, 23 centers involved. Analysis of primary endpoint were according to intention to treat principle. The safety endpoint of bleeding was analyzed with modified intention to treat principle. That is, any medicine, any person who received at least one medicine were taken into account, and after discontinuation of that medicine, 7 days were the cutoff value. That for 7 days the patient was followed up for any bleeding. Groups, that is, we have already discussed the baseline characteristic groups were fairly well balanced. 1 year follow-up was almost perfect, except 90 patients in total. Outcome assessors were blinded. And importantly, it did not simply compare just 2 antiplatelet drugs, rather it compared 2 treatment strategies. Now, having talked with the strengths of the trial, coming to loopholes. We first start with the hypothesis that any trial should begin with some hypothesis. And the hypothesis was ticagrelor will do better than Prasugrel. We had experiences and expectations from Plateau and Triton-Timi 38 that ticagrelor will do better. And as a mechanism of action and pleiotropic actions of ticagrelor, if we take into consideration, then we will see that ticagrelor is a better antiplatelet agent than Prasugrel, and given increased release of adenosine favors ticagrelor. But here the result shows that Prasugrel is better. Now, we know that randomized control studies should be double-blinded. Here it is open-label study, that is the patients who received or physicians who gave the therapy, they knew the drug. Some say that only two countries involved, and it was preferentially in Germany. 21 centers were in Germany and 2 were in Italy only. So widespread experience was not present. The important part is astonishingly high compliance. This is 99.1% in Prasugrel group and 99.6% in ticagrelor group. Usually it is seen that around 80 to 85% compliance is noted in large randomized control trials, and even landmark trials like Plateau has a compliance as high as roughly around 83%. So there is some school think that this is a little bit doubtful numbers, that is more than 99% compliance. Then non-adherence. As follow-up was basically telephonic, based on telephonic conversation. As high as 83% of patients were followed up by telephonic conversation, and 7% had face-to-face analysis. So there was some doubt that whether there was proper assessment of non-adherence,
And as there is no specific method of adherence evaluation, that is like medication event monitoring system, so probably adherence was underestimated. Now, another thing is the outcome of the study. We have already discussed the clinical outcomes. MI was more important. The other part, the incidence of MI, other than incidence of MI, there is not much difference between ticagrelor group and prasugrel group. Here, we see that in ticagrelor group, that is 4.8% in ESR React 5, whereas in prasugrel group is 3%. But if we compare Plato study, then it is seen that it is 5.3 versus 4.8. It is almost comparable, but there is notable difference observed with prasugrel, that 7.3% in return TIMI 38, which is much higher than 3% in ESR React 5. But in favor of this result, it can be said that during Triton TIMI 38, they didn't use universal definition of MI. In contrast, during ESR React 5 conducted, they have universal definition of MI. So maybe that caused some difference here. Now, intention to treat analysis that includes all patients according to randomly assigned trial group, irrespective of actual treatment received. In intention to treat analysis, it is seen that there is 20.4% in each group. They were discharged from hospital with the P2Y2 inhibitor as during randomization process. So this may have distorted the outcomes, and that may lead to the outcome. Then again, we see that inclusion of more than 1,200 patients were there in this React 5 trial who were initially not treated with the assigned medication. That 653 of 2012 subjects at 32.5 and 30.4% in ticagrelor and prasugrel arms respectively. So these are all loopholes, and if we think that outcome in favor of prasugrel, we have to clear the confusion regarding these loopholes raised by some schools. So we cannot take straightforward, we cannot take the results straightforwardly that prasugrel is clear winner here. So the take is it may be premature to recommend in this broadly for prasugrel in favor of ticagrelor based on this study, and this is yet to tell that ticagrelor should be discarded, and so ticagrelor should not be discarded as one of the antiplatelet options for patients with acute coronary syndrome in whom a decision is made to proceed, especially with invasive strategy. And so further studies or further deep investigation in this trial should be done so that we can have a clear picture which one is better, ticagrelor or prasugrel. Thanks for patient hearing.
Thank you, Dr. Tanmay. And as we are running out of time, I will call upon the next speaker, Dr. Manish Shah, to deal with the topic prosthetic valve and TAVR, recent guidelines for anticoagulation. Please start. Slides are visible.
Slides visible, but it is not moving. I have to do stop share again. Can
Stop sharing and read it.
No, sir, not required. Okay.
Just try now.
Share screen. So the full screen, open full screen, or it is the
open full screen.
No, open full screen. Start full screen only.
But slide is not moving.
Just a minute, sir. Just a minute. Just double click on the slide. Just select the slide. So kindly double click on the slide.
What to do?
Kindly double click on the slide.
Double click.
Yes.
Yeah. And if I want to go back previous slide, then what to do?
You can use my arrow keys.
Okay. Thank you. Slides are visible right now.
Yes, please
Yeah.
enlarge your slide. Yes.
Okay. Good evening, my seniors and my respected chairperson. First of all, I want to give thanks to CSI West Bengal chapter to give me an opportunity. Today, my topic of discussion is recent guidelines for anticoagulation following prosthetic valve and TAVR. As you all know, mechanical valve causes abnormal flow pattern within the zones of low flow within the components of the valve, as well as areas of high stress, which causes platelet activation and may lead to valve thrombosis and embolic events. And as you all know, that in order to prevent thrombosis, we have to give some agents which will prevent thrombosis at cost of bleeding chances. Then therapy with an oral anticoagulant at an INR goal appropriate for the comorbidities of the patient and the type and position of the mechanical valve prosthesis is crucial to decrease the incidence of thromboembolism and as well as the morbidities of the patient. These are the two recent guidelines that has been published. One is 2020 by ACCH and 2021 by European Society of Cardiology and European Association for Cardiothoracic Surgeon. Both guidelines are of valvular heart disease, which includes this therapeutic regime for anticoagulant following and after the prosthetic valve implantation. In a nutshell, types of prosthetic valve, we know these are of two types: mechanical, biological. Ball and valve, ball and cage prosthetic mechanical valves are nowadays obsolete. Tilting disc type and bileaflet types are available. And regarding biological, it is stented or stentless. Regarding stented, Protestant valve and pericardial valves are available. And these are different type of TAVR valve, like these are balloon expandable, they may be self-expandable, and some other designs TAVR valves are also available. Now, choice of prosthetic valve, as per ACCH 2020 guideline, while decision making over the type of prosthetic valve, the class 1 recommendation is the shared decision making. We, the doctor, should discuss about the pros and cons of different type of valves with the patient. If vitamin K antagonist is okay with the patient, then we have to look whether it is aortic valve. Then we have to consider the age. If it is less than 50, we have to consider mechanical AVR. 50 to 65, both mechanical or bioprosthetic AVR as an open choice, and more than 65 years, bioprosthetic AVR is the class 2A indication of choice. If it is a mitral valve, we always think that MVR is always better, mitral repair is always better than replacement. But if repair is not possible, then we go for replacement. If less than 65 years, then it will be mechanical MVR. If it more than 65 years, it will be bioprosthetic MVR. And if BK anticoagulation is not okay with the patient, either it is contraindicated or it cannot be managed by the patient or the physician, or it is not desired by the patient, then bioprosthetic valve implantation is then class 1 recommendation of choice. Now, this is most important: choice and duration of anticoagulant and target INR. As per ACCHA, if it is mechanical valve, and patient should be given vitamin K antagonist as class 1 recommendation. Then next part is what will be the target INR to prevent excessive risk of bleeding as well as fear of thrombosis. Then we have to think there are some risk factors of excess thrombosis is there or not in the patient. What are the risk factors? These are atrial fibrillation, previous thromboembolism, is there any hypercoagulable state, older generation valve, nowadays it is not available, this is not used, and LV dysfunction, predominantly left ventricular ejection fraction less than 35%. If mechanical AVR without this type of any other risk factor, then our target INR will be 2.5. If mechanical AVR with this one of these risk factors are there, then our target INR will be 3. And if mechanical valve is placed in the mitral valve position, again our target INR will be 3. These are all class 1 recommendation as per ACCHA. And if any antiplatelet is to be given on top of this vitamin K antagonist for mechanical prosthetic valve, antiplatelet low dose aspirin 75 to 100 milligram can be added as a class 2B indication. Next, if the patient has given bioprosthetic heart valve, it may be surgical bioprosthesis or transcatheter bioprosthesis, that is TAVI. If it is surgical bioprosthesis at aortic valve or mitral valve region, initial 3 to 6 months, we can give vitamin K antagonist and we will target INR as 2.5. It will be class 2A indication. And after 3 to 6 months, lifelong low dose aspirin, that is 75 to 100 milligram aspirin to be given. And in case of TAVI, initial 3 to 6 months, we have to add clopidogrel for 75 milligram on top of aspirin low dose or as a class 2A indication, or vitamin K antagonist can be added on top of aspirin 75 milligram for first 3 to 6 months with a target INR 2.5 as a class 2B indication. And following after 3 to 6 months, where the patient has to be under aspirin 75 to 100 milligram as a class 2A indication. We have to keep in mind that NOAC is still not recommended for mechanical valve or bioprosthetic valve implantation patient as a valve concern. If a patient of bioprosthesis valve, if the patient is on AF, we can give NOAC, but not as a concern of anticoagulant in prosthetic valve. Now, ESC, there is a proposition given by ESC in 2021. They have reviewed the target INR for mechanical heart valve. They have classified this recommendation into two parts. They have divided the prosthetic valve according to thrombogenicity into low, medium, and high, and patient-related risk factors from patient-related risk factors. They are given patient-related risk factors: mitral or tricuspid valve replacement, previous thromboembolism, atrial fibrillation, mitral stenosis of any degree, LV ejection fraction less than 35%. And they have given different types of prosthetic mechanical valve as low, medium, high, like different valve of different companies. They have mentioned all these. And if the prosthesis thrombogenicity is low and patient has no other risk factor, then target INR is 2.5, medium 3, and high 3.5. And if as well, if the prosthesis thrombogenesis is high and patient has more than one risk factor, then target INR may be as high as 4 as per 2021 ESC recommendation. This is another thing. This is Onyx valve. This is a specific type of valve. This is a specific type of valve. For this valve, it has been given as class 2B recommendation. That's that if this valve is placed at aortic valve region for initial 3 months, INR to be kept as 2 to 2.5 as with aspirin plus VKA. After 3 months, on top of aspirin, low dose VKA can be given to keep the INR at a lower level, that is 1.5 to 2. It has been given as class 2B recommendation. Now, in continuation of previous speakers' speeches, that is a common algorithm what has been given by ESC and ACC for last 2 to 3 years, whether OAC with oral anticoagulant is dual antiplatelet, that is the anticoagulation in patients of mechanical heart valve with indication of concomitant antiplatelet therapy. After ACS or uncomplicated PCI, dual antiplatelet for 1 week, and along with OAC, dual antiplatelet maximum for 6 months to 12 months. Following that, only oral anticoagulant. This is class 1 recommendation. And after uncomplicated PCI or ACS in patients requiring both OAC and antiplatelet therapy, triple therapy, aspirin, clopidogrel, OAC for more than 1 week, but less than 1 month, it can be given as a class 2A recommendation. In patients treated with VK for mechanical heart valve, clopidogrel alone should be considered. In selected patient where Has-bleed is too high, that is more than equal to 3, ARC, HBR met, and low risk of stent thrombosis for up to 12 months. In patients requiring aspiration and clopidogrel in addition to VK, the dose intensity of VK should be considered and carefully regulated with a target INR in the lower part of the recommended target range and a time in the therapeutic range more than 65 to 70%. Now we'll discuss some complication and special situation. That is thrombotic episode after prosthetic valve implantation. If a patient with prosthetic heart valve, if there is any thromboembolic episode, then we have to check whether the valve in aortic mechanical valve and INR is in range or not. If it is in range, we have to increase INR to 3. Is mitral mechanical valve with INR in range, we have to increase the INR to 4. And we have to add aspirin in both of the cases. If the patient has bioprosthetic AVR or MVR and on antiplatelet treatment, we have to add vitamin K antagonist anticoagulation instead of antiplatelet therapy as a class 2B. Is suspected mechanical valve thrombosis, we have to do CT, fluoro or imaging. If there is left-sided mechanical obstruction, urgent slow infusion fibrinolytic therapy or emergency surgery, whichever is available as a class 1 recommendation. And suspected bifosthesis valve thrombosis, we have to treat with vitamin K antagonist as class 2A recommendation. This recommendation is given by ACCHA. This further elaboration is has been given by ESC in 2021. If there is left-sided obstructive and non-obstructive mechanical prosthetic valve thrombosis, if there is obstructive thrombus, the patient usually becomes critically ill. We have to search for immediate surgery, whether available or not. If surgery is available, we have to go for surgery. If surgery is not available, we have to go for fibrinolysis. We have to check whether the patient has omitted any anticoagulation therapy or not. If the patient has omitted, we have to give unfractionated heparin to overcome the inadequate anticoagulation. If it is a success, then we have to follow up. If it is a failure, we have to go for urgent surgery. It is not available, then fibrinolysis. If non-obstructive thrombus, patients are usually not critically ill, then we have to think whether the patient is having any thromboembolism or not. How can we come to a diagnosis of thromboembolism? Either by clinical or by cerebral imaging. Then we have to consider the size of the thrombus, whether it is more than 1 centimeter or less than 1 centimeter. If it is more than 1 centimeter and the patient has clinical or cerebral image evidence of thromboembolism, then and the thrombus is more than 1 centimeter, we have to go for surgery. If it is not more than 1 centimeter, it is less than 1 centimeter and patient has thromboembolism evidence, then we have to optimize the anticoagulation and we have to reevaluate. If persistence of thrombus, we have to go for surgery. If there is no thromboembolism, large thrombus, again we have to optimize anticoagulation. If failure, then surgery. And if no thromboembolism and small thrombus, we have to give optimization of anticoagulation and we have to do follow-up. Now, guideline for management of excessive bleeding after prosthetic valve implantation. If the patient of mechanical valves has uncontrolled bleeding who require immediate reversal for hemodynamic stabilization, we can give 4-factor prothrombin complex or its activated form as a class 2A indication. For patients with mechanical valves and uncontrolled bleeding who have received 4-factor prothrombinase complex, on top of that, we can give vitamin K as factor 2A. And bioprosthetic valve or annuloplasty ring who are receiving direct oral anticoagulant or who require immediate reversal of anticoagulation because of uncontrollable bleeding, for hemodynamical stabilization, we can give anti-dabigatran therapy like idarucizumab or adenoxide alpha for factor 10A anti-factor 10A agents. And for patients with mechanical prosthetic valve and supratherapeutic INR, but no active bleeding is there, we can give vitamin K. We can't give it. Can be treated as class 2B indication. Vitamin K oral given can be given as a class 2B indication. Now, guideline for bridging therapy for non-cardiac procedure in patients with prosthetic valve. If minor procedures and bleeding can be controlled, there should be continuation of routine VK with continuation and the target INR should be maintained. If it is bileaflet mechanical AVR and no other risk factors of thromboembolism, as I discussed earlier, who requires invasive procedure, temporary interruption of VK can be done as a class 1 indication without bridging agents. While the INR is subtherapeutic, the patient can be given certificate for proceeding of OT. And for patient with a mechanical valve prosthesis receiving VK therapy who require immediate or emergency non-cardiac surgery or invasive procedure, administration of 4-factor prothrombinase complex can be given as factor 2A. And if the patient is having bioprosthetic heart valve, annuloplasty F and AF, we have to consider bridging therapy. And patients who are undergoing invasive procedures and a mechanical AVR and antithrombotic risk factors, either an older generation mechanical aortic valve, a mechanical mitral valve replacement, bridging anticoagulation to be given in the preoperative time interval when the INR is subtherapeutic is reasonable on the individual basis. Now, lastly, the management of antithrombotic therapy perioperative period that given updated by ESC as as per ACCHA, VKs are timely discontinued prior to elective surgery to aim INR less than 1.5. But in those patients where mechanical prosthetic heart valve older generation, AF with significant mitral stenosis, CHA-adverse more than 3 for women or more than 2 for men, acute thrombotic event within previous 4 weeks, high acute thromboembolic risk, bridging therapy is required. Bridging to be done with unfractionated heparin or subcutaneous LMWH. All of these are recommended as class 1C or 1B. In patients with mechanical heart valve, it is recommended to reinitiate the vitamin K antagonist on the first post-operative day as a class 1C recommendation. In patients who have undergone valve surgery with an indication for post-operative therapeutic bridging, it is recommended to start either unfractionated heparin or LMWH 12 to 24 hours after surgery. Patients undergoing surgery, it is recommended that aspirin therapy, if it is indicated, to be maintained during the peri-procedural period. In patients treated with DAPT after recent PCI who need to undergo heart valve surgery in the absence of other indication of OAC, it is recommended to resume P2Y2 inhibitor post-operative as soon as the bleeding concern is over. In patients treated with DAPT after recent PCI, bridging can be also be done as a class 2BC indication with short-acting glycoprotein 2B3A inhibitors or cangrelor can be considered. Thank you.
I think we are running out of time. My other chairpersons are there for any comment?
No, sir, no comment. You can conclude the session.
Yes.
And you can proceed to the next session, that is on echocardiography. And for this, we have 4 speakers, Dr. Aniruddha De, Dr. Devika Chatterjee, Dr. Bashavendra Choudhury, and Dr. Dhritabruta Das. And to moderate the session, we have Dr. Sauramshi Chatterjee, Dr. Debashish Mukhopadhyay, and Dr. Shankar Mitra. And in chair, Dr. R.S. Joshi, Dr. Ashok Dhar, Dr. Saurav Mukherjee, Dr. Devika Chatterjee, and Dr. D.P. Shenan. Our first speaker is Dr. Aniruddha De, and he will be speaking on COVID surveillance role of echocardiography.
Dr. Dev, please.
Dr. De, please.
Yes. Good afternoon, everybody. Am I audible and my slides are visible?
Yes, sir, audible as well as visible.
Okay. Today's, thank you for the organizer for giving me the opportunity for this important topics of the post-COVID surveillance. What is the role of echocardiography? See, if you see the total number of cases still now in throughout the world, is a number huge. It is near about 25 crores. And total number recovered near about 23 crores. And it's not that, even in India, it's near about more than 3 crores and reaching up to the 4 crores. So you can find out the burden of this for the patient, actually, which are the patients developing the cardiac problems is a Herculean task to divide. Well, researchers have found in the different literature for the last 1.5 to 2 years that evidence of cardiac involvement in the 30 to 40% and as much in some studies up to 60%. See, there is this broad spectrum of presentation starting from asymptomatic disease to severe respiratory failure, myocardial injury and death. We know there is a 20 to 30% of patient hospitalized evidence of myocardial involvement is there, and which can be easily determined by elevated troponin level, but always in the acute stage. I'm not concerned about that. The multiple pathways to myocardial injury that we already know. There's either a type 1 type 2 myocardial infarction or the myocarditis or the vasculitis or the mechanism related to inflammation, thrombosis or stress. Depending on the type of injury, that there may be the important sequelae if a residual inflammation, not fibrosis, exists. It's a new pathogen, and there is still no long-term data on the cardiovascular abnormalities or dysrhythmias that may occur in the convalescent phase. We know that there is some myocardial involvement can be an initiator of pathway of inflammation and the subsequent fibrosis and that may lead to life-threatening atrial fibrillation and the ventricular arrhythmias. There is a different mechanism for involvement of the cardiac muscles that we already know, and this is beyond the scope of discussion in these topics. So I'm concerned with the patient with the subclinical disease may be the subset for cardiac arrhythmias. Therefore, identification of the survivors of COVID-19 with subclinical myocardial disease and arrhythmias, which are potentially protective, can be protected by the cardioprotective drugs like mineralocorticoid, beta blockers, or the statins. If we identified them, that would be a real pleasure. Given the large number of COVID-19 survivors, so enhanced surveillance and treatment for those whose significant electrophysiological abnormalities could substantially lower the burden of subsequent morbidity and mortality. It is unknown whether why this cause of myocardial injury, whether it is the severity of the cardiopulmonary injury, or the type of treatment, or any other host factor that influence the long-term sequelae. So the heightened surveillance is therefore warranted in this region with consideration of primary prevention approaches. Given the high prevalence of cardiac, it is reasonable to expect some residual post-myocardial abnormalities. In fact, some patients suffer from new onset cardiomyopathy during the convalescence phase after the COVID-19 infection. But presently, unfortunately, there is still no data, there is no organized data. And if otherwise, this data would be relevant for patients recovered from COVID-19 associated cardiac injuries. Autopsy studies with certain cardiac identified myocarditis as the potential explanation in a significant number of cases, even with a grossly normal appearing heart. And the finding of myocarditis as a significant cause of sudden death in the young is often noticeable and relevant to the survivor of COVID-19. One of the important factors is the obesity. Obesity has been observed as a risk factor of worse outcome during COVID-19 infection, as ACE2 is also expressed in the adipose tissue. And not only that, obesity modulates inflammatory response to the secretion of the pro and the anti-inflammatory adipokines and the interleukin-6. Moreover, inflammation involving the epicardial adipose tissue may be affected by myocarditis because of the close proximity of the myocardium and the epicardial adipose tissue. There is still much unknown about, but patients with ostensibly recovered cardiac function may still be at a risk of coronary artery disease, atrial fibrillation, and the ventricular arrhythmias. Given the size of the pandemic, it is important to determine whether acute delivery of antifibrotic therapy or the anti-inflammatory therapy, cell-based therapy, or antiviral therapy affects long-term as well as the short-term outcome. But still, we do not know which is the optimal screening test. One paradigm is to define the population of risk by identifying patients with the COVID-19 infection and the elevated high sensitivity troponin of the BNP, as this has already been shown to provide important but short-term prognostic information. And these patients should be followed to monitor and assess the long-term prognostic effect of COVID-19 myocardial involvement. Here is a very important chart. Forget about the left side. Concentrate on the right side in the convalescent phase, mainly in the 2 to 6 months. So I'll zoom it. There are 4 important parameters should be noticed. One is the ECG. Second is the baseline echo. Then you have to monitoring the cardiac events depending on the symptoms and consider patient-specific cardiac risk factor. If these are normals, then you have to resort to 2 important modalities of investigation, either echo with strain or MRI with LG, because these are very, very important in the next subsequent slide I'll show you. Screening for the convalescence is needed because trial of prophylactic therapies is very, very important. But we have to find out the cost effectiveness of the screening test. We cannot do MRI with LG in each of 23 crore patients. So if you have some symptoms like that, where we can do the standard ECG, echocardiogram, cardiac abnormalities, even this test may not detect subtle clinical abnormalities, then we can detect the subclinical myocardial dysfunction by the longitudinal strain. because this is very important that basal left ventricular longitudinal strain on speckle tucking echocardiography is first affected. Global longitudinal strain has been shown to be more sensitive, we know, than even from the LV ejection fraction. So patient all with the normal LV ejection fraction may have the reduced longitudinal strain, particularly in the basal segment, as you've seen in this photograph. So I'll give you some example of the cases. So 40-year-old lady, non-diabetic, non-hypertensive, treated with the standard therapy with high flow oxygen, recovered within 14 days and discharged. Bedside echocardiography and troponin level was normal. Presented 1 month after discharge with persistent weakness, and presently lab parameter is normal. You can see the normal ejection fraction in all the 3 views of the longitudinal sections. And when you did the GLS, you found the absolutely normal GS of 22.6%. Now come to the another case. 52-year-old man, non-diabetic, non-hypertensive, treated with the standard therapy with the high flow oxygen, recovered within 21 days and discharged. Bedside echocardiography troponin level was again normal, but presented 15 days after discharge with persistent weakness and dyspnea on exertion. Again, the lab parameters are normal. You see the ejection fraction is relatively preserved, and all the views you can see, this is the 3 views. And now if you the GLS is a little on the lower side, is in the range of -17%. So that means this patient might have affected some subclinical dysfunction, probably recovering. Now is the case number 3, 48-year-old man, well-controlled diabetic and non-hypertensive, treated with the standard therapy and the high flow oxygen, recovered within 10 days and discharged. Bedside echocardiography and troponin level was again normal. Presented 21 days after discharge with respiratory distress and hospitalized again. Presently lab parameter raised CRP and increased troponin level. You see, still the ejection fraction is looking normal. Even in all the views, it's a good contractility, all the 3 chambers views, and now see the ejection fraction, GLS is in the tune of only 10%. So these are the subsets of patients. It's very, very important to recognize where you can do further investigation, even give the prophylactic therapy. Another case, 40-year-old man, hypertensive and non-diabetic, angioplasty done at LAD after acute anterior wall MI. Patient was doing well for the next 6 months. Echocardiography, LVF 45% with akinetic ventricular septum and interval in the median apical region. Developed COVID-19 infection subsequently and admitted with respiratory distress and discharged in a stable condition after 14 days. Presently, complaint of DOE and referred to our lab for echocardiography. You see, still there is a akinetic ventricular septum, but the other one seems to be look good. There is maybe some mild dilatation of the left ventricular dilatation, but other walls seems to be looking good, and see the GLS is in the tune of 9.8%. Well, even with the acute anterior wall myocardial infarction in the recovering phase, these type of GLS only happen. And you can see the GLS, in fact, almost involving all the segments, keeping aside the anteroceptor walls, other walls also involved there. So see, these are the representative samples. Based on these, we are having one ongoing study is going on, where we have evaluated total number of 486 cases, and this study is still on, because for that I am not able to statistically analyze all the data, but I can give you a clean overview of this, what is the studies going on. This criteria for selection, all patients are COVID-19 positive detected by RT-PCR. They stayed either in the hospital or in home isolation. We evaluated after 2 weeks of RT-PCR become negative, and then we have divided into 2 groups. One group is we have divided into 2 to 12 weeks, and another is 4 to 12 months. Age range 5 to 86 years, and these are the 40 years is near about 20%, below 40 years, 40 to 60 is near about 45%, and above 60 years, 37%, 6 days is almost matched. Here, cases with abnormal ECG and the RWMA, we have 49 cases are excluded from the study. All other patients is 37 cases, baseline ECG and the LVAF is normal. That one means above 55%. Hospitalization is in near about 30% patient, domiciliary people in 70%. The two group in the almost same in between if we evaluated between 2 to 12 weeks, or rather between 1 to 3 months or 4 to 12 months, almost same. Comorbidities like hypertension, diabetes, and dyslipidemia is yes, please.
Please come to.
I'll come to conclusion. Hello. Okay, I'll go first with the slides. So these are the oxygen requirement, bronchial asthma. Here are other issues: use of steroid, not used, pulmonary artery pressure. We have required the BMI, pulmonary artery pressure, left ventricular filling pressure. The dominant presenting symptoms usually either the dyspnea on exertion or the respiratory distress. So now come the important slide. If you see the GLS is very moderate to severe reduction of GLS is found in almost 15% patient, and another 35% patient there is some reduction of GLS. This may be attributable because of some comorbidities, but if I go to so these are in different analysis. I'll not go into the detail. I'll come to relation to directly to the summary. So if summarize these, mild to moderate reduction of GLS is found in 35% patients, moderate to severe reduction in GLS in near about 15% patients. Cardiac involvement increases as age advances, and the reduction of GLS is more in male. Hardly any difference between whether you take it on within 3 months or within 12 months. Greater reduction of GLS in hospitalization patient. Requirement of oxygen is proportionate to reduction of GLS, whether it is a low flow or the high flow or not at all. Oxygen is not required at all. Reduction of GLS is more with comorbidities like diabetes, hypertension, the dyslipidemia. Ironically, no difference was observed in GLS in between the patient with the COPD and the bronchial asthma and the control. Reduced GLS were observed after steroid use, and increased BMI lead to more reduction of GLS. Reduced GLS is also seen in moderate to severe pH only, not with the mild elevation of the pH, probably because of the lung involvement. No relation with increased left ventricular filling pressure as derived by E by DAS. And reduced GLS observed also where patient was put on ventilator, of course the serious patient after remdesivir therapy, but not with the BiPAP. And the two most important presenting symptoms, dyspnea on exertion and the respiratory distress, are associated with the significant reduction of GLS. So if you summarize it, young patient, less hospital stay, patient in home isolation, minimum no comorbidities, these are the representative pictures. And if you found the group 2 between 14 to 80%, aged patient with the comorbidities and the prolonged hospital stay, these are the representative samples. And the last group below 40%, middle age and the old patients, patient with multiple comorbidities, prolonged and stormy ICU stay. So these are the representative samples. So GLS we found is the more sensitive marker of early myocardial dysfunction, and the cardiac magnetic imaging also supported the evidence. So future studies will clarify whether there will be post-COVID-19 cardiac syndrome and how best to manage the patient recovering from COVID-19 cardiac involvement. We are currently facing a pandemic unseen in our lifetime. So now is the time for Accent to plan appropriate registry and clinical studies to assess the incidence and significance of potential mid and long-term cardiac abnormalities and dyslipidemia, with the hope to promise to mitigate these long-term sequelae. Thank you.
Thank you, Dr. De. We'll proceed with the second speaker, Devika Chatterjee.
Yeah. Is my slide visible? Hello?
Not yet.
But okay.
Yes.
Yeah, now visible.
Kindly make it full screen.
Yeah,
visible.
Thank you, Chairperson, for inviting me, and thanks to the organizers also. And good evening, everybody. I'm going to talk on the echocardiography of tricuspid valve disease with few case demonstration. As all of us know that majority of the serious heart valve problems involve the mitral valve and the aortic valve. Tricuspid valve disease is relatively rare, and that is why we have developed a stepmotherly attitude towards the tricuspid valve. We never look at the tricuspid valve the way we look at the mitral valve and the aortic valve. Here is a patient who is 50 years old female, was referred to our hospital for surgical mitral valve replacement in a case of, and she was a patient of severe mitral stenosis of rheumatic origin. The patient was sent to me for preoperative echo. Well, I got severe MS with a mean gradient of 11 millimeter of mercury and a valve area of 0.71 square centimeter. But as I looked at the tricuspid valve, what I found, the tricuspid valve also is equally in.
Slides are not moving, ma'am.
Yes. Yeah. Just a second. What I found, the tricuspid valve is equally diseased with severe stenosis, a mean gradient of 4 and a valve area of 0.98 square.
You can double click to for move, madam. You can double click on slide and move. Just click. Double click.
Yeah. Okay. So
it's not moving. Still, it's not moving.
It's not moving.
No. We can see only first slide. Your first slide.
But I am able to see. Okay.
No, okay. Kindly stop share and you can share again, madam. I'll do it for you. Yeah, you can kindly click on share screen.
Yes, I've clicked and I have opened my presentation. Just a second.
You can open. Which you opened the full screen. Yeah. Now we can see.
Can you see now?
Yeah. Perfect.
Okay, so it was a case of mitral valve severe stenosis, and I got severe. Can you see now? Hello?
Yes, madam. Yes.
Okay, so tricuspid valve stenosis, in this case, changed the line of management. The surgeon went for DVR with replacement of mitral valve as well as the tricuspid valve. If I wouldn't have looked at the tricuspid valve, we know the consequences. So that is why the tricuspid valve should not be considered as a forgotten valve, and echocardiographic imaging provides beautiful insight to the pathophysiology of tricuspid valve, which improves the risk stratification, and that results in more timely intervention of the tricuspid valve. As we know, it is the most apically placed largest cardiac valve, having 3 leaflets, septal, anterior, and the posterior. And if you see, it is not possible to visualize all the leaflets in the single view. In apical 4-chamber, parasternal short axis and subcostal, we see septal and the anterior leaflet, whereas it is the RV inflow view where we can see the posterior leaflet along with the anterior leaflet. In transesophageal echo, in the mid-esophageal 4-chamber view and RV inflow-outflow view at 60 degrees, we can see the septal leaflet and the anterior leaflet. Whereas in the mid-esophageal bicaval view and transgastric RV inflow view at 120 degrees, we can see the posterior leaflet along with the anterior leaflet. And it is only in the 3-dimensional echo that we can see all the 3 leaflets in the same view. If we look at the normal inflow velocity and gradient, it's 0.7 meter per second. And since it's a right-sided structure, so it gets accentuated in inspiration, and mean gradient is less than 2 millimeter of mercury. And we know mild tear of low velocity is present in 80 to 90% of normal population. So after knowing the normal morphology and normal flow pattern, let us go to tricuspid valve stenosis, which rarely occurs in adult. And even if it occurs, it's almost always rheumatic in origin and is usually associated with mitral valve and aortic valve involvement. Very rarely, it might be congenital or due to carcinoid heart disease, and functional TS might be there because of the tumor in the region of tricuspid valve causing obstruction to the tricuspid inflow. Now, when we get a rheumatic tricuspid valve stenosis, it is a bit difficult to appreciate unless we provide careful attention to the imaging of the tricuspid valve, and we should look for the rheumatic involvement, rheumatic changes in the tricuspid valve leaflets. You see, this is the tricuspid valve. Here there are thickening of the leaflets, shortening, restricted mobility. There is diastolic doming of the tricuspid valve leaflets, just like mitral stenosis, small areas of calcification, and along with that, dilated RA and the enlarged annulus may be dilated. When you look at the flow in the tricuspid valve stenosis of rheumatic origin, we get a candle flame appearance just like mitral stenosis, that is the turbulence, and there might be some tear, as in this case, there is a trivial tear. So, and if we look at the velocity and the gradient, it's always increased in stenotic valve. Here also it is increased, and a mean gradient of more than 5 millimeter of mercury suggests severe tricuspid valve stenosis. We need to take precaution because it increases during inspiration. So we need to take the average of inspiratory cycles of 5 cycles at least. Now, valve orifice area can be obtained by pressure uptime method, where we divide 190 instead of 220 as what we do in mitral stenosis. In tricuspid valve, we apply 190 and we divide it by pressure uptime. So the tricuspid valve area of around 1.3 to 1.5 square centimeters is significant enough to cause the symptoms, cardiac symptoms. The validity is said to be low than mitral stenosis, validity of pressure uptime method. Nevertheless, if the pressure uptime is more than 190 millisecond, it indicates severe stenosis. We might get a combination of TS and TR, as in this case. You see the turbulent flow across the tricuspid valve along with at least moderate TR, and there is mitral valve involvement. And in this case, we may get a bit higher pressure gradient because of the presence of TR, as in this case, it's around 15 millimeter of mercury. Now, after looking at the rheumatic tricuspid stenosis, let us see some other causes of tricuspid valve stenosis. This is a patient which we got. It was an isolated tricuspid valve stenosis. Mitral and the aortic were absolutely normal. Well, these are the cases which are very, very rare, and etiology is either congenital or carcinoid heart disease, where serotonin released from the GI tumor bypasses the liver and gets, damage the right-sided valve and can never cross the lung to reach the left side of the heart, and because lung is a barrier for the serotonin to pass. And a functional TS might be due to a vegetation in the tricuspid valve. As you can see, a large vegetation causing obstruction with a mean gradient of 3 millimeter of mercury. Similarly, a tumor, a large tumor in the tricuspid valve area causing severe obstruction. These are the transphysial echo views. Severe obstruction. Look at the 3-dimensional image. A large tumor. It was found to be sarcoma, a very, very rare cardiac tumor with a mean gradient of around 18 millimeter of mercury. So these are the cases of functional tricuspid stenosis. Now, from tricuspid stenosis, let us move to the tricuspid valve regurgitation. Here is a patient who presented to us with shortness of breath in NYHA class 3 and ankle edema. This patient had a BMD 2 years back for severe MS. At that time, she had moderate functional TR. So nothing was done for TR. And when we did the echo, we saw that mitral valve is quite open with an area of 1.65 square centimeter and a mean gradient of only 4. Then why there is shortness of breath? Now, as we put the color flow, as you can see here, this is severe tear. See, severe tear. So this tear actually was the cause of shortness of breath. Similarly, there is another case of MVR who had an MVR 5 years back, presented to us with acute exacerbation of shortness of breath in NYHA class 3. The prosthetic valve was behaving absolutely normally and with a mean gradient of only 3 millimeter of mercury. So again, in this case, as we put the color flow in the tricuspid valve, we found there is severe tricuspid valve regurgitation. So that so we see that tricuspid valve regurgitation in mitral valve disease is highly prevalent, and it's much more common than TS. If untreated, less than severe TR might not resolve after correcting mitral valve lesion. On top of that, RV systolic dysfunction may set in, as happened in this case of BMV, and also the presence of moderate to severe TR during follow-up after MVR, as in this case. This is an independent predictor of heart failure. Also, these patients have a very low exercise tolerance. So because of these factors, there is a total paradigm shift in the current surgical guidelines of tricuspid valve. More preemptive treatment of TR is done nowadays, regardless of its degree, because we have very improved techniques of tricuspid valve repair as well as replacement. And tricuspid valve intervention should be performed during the initial mitral valve surgery before the RV dysfunction or severe TR or advanced heart failure sets in. And for that, we need to know the mechanism or the etiology of TR in these cases of rheumatic mitral valve. Or we should have the knowledge about the etiology of TR. So it might be primary or organic, where there is structural abnormality. It occurs in 20 to 30% of TR. Or it might be secondary or functional, as occurs in 70 to 80% of TR, where there is normal, structurally normal tricuspid valve. It is the annular dilatation or RARV remodeling which cause the TR. The causes of primary or organic TR may be acquired heart disease like rheumatic heart disease, endocarditis. Iatrogenic may be pacemaker lead. Congenital may be the Epstein anomaly. So in functional TR, the causes are left heart disease like valvular heart disease, left ventricular dysfunction, RV dysfunction from various causes like ischemia, cardiomyopathy, or volume overloaded RV, PH due to chronic lung disease, pulmonary embolism, or even atrial fibrillation where RA is enlarged. So after knowing these causes, let us see some cases of TR. This is a patient who had the acquired non-rheumatic organic TR. Here, pacemaker lead is the cause which prevents the leaflet coaptation, or it may perforate the leaflet, or even it may get entangled in the cordae and interfere the coaptation of the leaflets. This is the pacemaker lead leading to severe TR. There is a vegetation also, as you can see. And here is the case of a RV cardiomyopathy patient where severe TR is due to non-rheumatic functional TR. As you can see, there is papillary muscle displacement, increased tethering of the leaflets, and leaflet malcoaptation. As you can see, this is the septal and anterior leaflet. There's a large coaptation failure leading to severe low pressure TR. We may get this type of TR even in non-rheumatic atrial fibrillation. As you can see, the mitral valve is absolutely normal. Structurally, the tricuspid valve also, but since there is RA enlargement leading to the annular dilatation has caused severe tricuspid valve regurgitation. Now, when this TR is seen in presence of mitral valve disease, we are really worried. Even if it is mild, we want to know, as in this case, we want to know whether it's functional or organic. We do careful two-dimensional imaging to look for the morphology of the tricuspid valve. If we see that leaflets are thin, normal looking, as in this case, look at the leaflets. There's no restriction of mobility, but RA is dilated and annulus is dilated. So it's a functional TR. So that that decides the surgical management of this tricuspid regurgitation.
Dr. Chatterjee,
Yeah, just
we are running out of time. Please continue.
okay. And the organic tear, where the valve leaflets are diseased, almost finished. And so we look at all the views before we confirm the organic tear. And here is here are the, just a second. The annular measurement is very, very important. It's the distance from the base of the septal leaflet to the anterior leaflet. And if we get this information, these diagnostic features will differentiate between functional and the organic tear. And depending upon this surgically relevant echo information, surgeon will decide whether he or she will go for the replacement or repair, or will not do anything if there is severe systolic dysfunction. So if this way we look at the morphology of the tricuspid valve disease, and as well as the pathophysiology of the TS and TR, this leads to timely intervention of the tricuspid valve with improved technique and good result, as happened in this patient. A young girl had a mitral valve repair and as well as tricuspid valve repair in our hospital, showing no residual mitral regurgitation or stenosis and no TR. Thank you. Thanks.
Thank you, Dr. Chatterjee, for an excellent presentation. Our next speaker will be Dr. Basavendra Chaudhary, who will be talking on point of care echocardiography in critical care. A very interesting topic. Dr. Basavendra Chaudhary.
Yeah. Thank you to CSI West Bengal chapter for giving us this opportunity. After the excellent presentation of ma'am, it is really a privilege to present this topic, which is a very upcoming thing. And as we are all becoming dependent on newer and newer modalities of diagnostics, it was about time that point of care echocardiography has become mandatory in the treatment of critically ill patients, not only in the Department of Cardiology, but overall critical care medicine. So we know that the critical care ultrasonography refers to the use of ultrasound patients who are critically ill or in the CCU. The diagnosis may be, there can be a variety of illnesses, often overlapping diseases, and it incorporates different aspects like a point of care ultrasonography, thoracic ultrasonography, abdominopelvic, vascular, and of course cardiac ultrasonography. So if all this can be incorporated and special training programs can be made for the intensivists and the doctors and the personnel who are present in the CCU round the clock to perform this test, that will be really beneficial, not only for the diagnosis, but also altering the management and modifying the management of those critically ill patients. And as we all know, always it is not possible for the cardiologist to attend the patients within a short notice. And so if those persons who are treating the patients round the clock can perform this test, it will be really beneficial. Next slide. So a portable echocardiography machine or a ultrasound machine with updated modalities can be used, and the intensivist can perform the test by himself and actually can immediately integrate the information into a comprehensive management plan. It is best suited for life-threatening processes like shock and its categorization, respiratory hypoxic respiratory failure, to check for other morbidities and coexisting diagnoses, complications of interventions and other therapies, like even chemotherapy or percutaneous procedures, which are becoming more and more common nowadays, and to track the evolution of the cardiac illness by serial examination. And there have been enough studies which have shown that CCE or a critical care echocardiography can result in immediate change in the management in up to 50% of patients. Next slide. So can it be done by a non-cardiologist, which is a very valid question, which was a very valid question. However, recent studies have shown that even after a short course, maybe a 10-hour course or a 2 weeks course, the gross things like the global LV systolic function, severe RV dilatation, inferior vena cava dilatation, and variation of the IVC diameter with respiration, pericardial effusion or its compressive pericardial effusion. These things can be picked up by a person who is treating patients in the CCU who may not be a cardiologist, but with a short training program, the pickup power to 100%. So based on this, the ESC have come up with guidelines on the use of echocardiography in the acute cardiovascular care in 2013, and then it was updated in 2015. And my presentation is based mostly on the line of these guidelines. Next slide. So they have divided the competency level of the operators. So the emergency echocardiographer should be able to acquire the standard transthoracic views and should be able to recognize the major causes of cardiac arrest and shock, and should be able to refer for second opinion when indicated without delay. And level one operator should be able to take not only the transthoracic but also the esophageal echocardiography views, and should be able to diagnose the common abnormalities, and also he or she should know when to refer for a level 2 or a level 3 consultation. Level 2 and level 3 operators should be specialists and should be also engaged in teaching and research activities. So for an independent operator, according to this guideline, whether he or she is a cardiologist or a non-cardiologist, 350 transthoracic echocardiography should be performed before he is considered to be competent to be an individual operator. And for non-cardiologist operators especially, adequate knowledge, theoretical knowledge on the different cardiological emergencies and cardiovascular disease conditions is a must. And an expert operator obviously should have the experience of a large number of cases which he or she has performed. So in our country, there are no dearth of patients and no scarcity of patients, only protocol programs and well-designed programs are necessary to make our health care personnel more efficient and technically suitable to perform a point of care echocardiography. Next slide. So the common clinical scenarios in which this modality becomes very important is a patient coming with acute chest pain or acute dyspnea, hemodynamic instability or shock with a new murmur, or in the case of a cardiac arrest or ongoing cardiopulmonary resuscitation and chest trauma. And the ESC has advised an ABCD approach that the operator should be aware of what he or she is looking for, and they should be suspicious to find out extra informations and not just rely on the referred diagnosis. The examination should be as comprehensive as possible, keeping in mind the condition and the unstable condition of the patient, and should not hamper the treatment as such, but as comprehensive as possible. And for D, it is a double R. That means the study should be recorded for further review in the future. Next slide. So on the left hand, we can see a host of disease conditions which can make a patient land up in a CCU. Acute coronary syndrome, its complications, acute aortic syndrome, especially aortic dissection, acute pulmonary embolism, tamponade, to name a few, and also some thoracic conditions like pneumothorax, which is often missed and is often diagnosed only at a very late stage. So when we are performing echocardiography in a CCU on a critically ill patient, what are the basic questions that must be answered? What is the LV function? Not only the systolic function, but also the diastolic function, which plays a vital role not only to explain the symptomatology, but also to guide the treatment regarding how much fluid is to be given or whether diuretics is to be administered or not, which is often a very confusing thing for the intensivist. So next comes what is the RV function? as ma'am was saying, the detail and the care we give to the left heart, often we do not do so for the right heart. However, often the right heart evaluation holds the key to the quick and successful recovery of the patient. Is there any evidence of pericardial effusion and cardiac tamponade? Is there any evidence of pulmonary embolism in the form of RV dilatation, RV dysfunction? Often we may, in most of the cases, we may not actually visualize the thrombus. We may be lucky in some of the cases. So whether there is aortic dissection for which a proper view of the aortic root imaging is necessary by not only of the standard echocardiography, also we should take help of the suprasternal and the subcostal view if needed. What is the filling pressure, which is also helps us to determine the diastolic function of the left ventricle, and also for the right side, the RARV sizes, the different parameters of diastolic function, IVC status, which we will touch upon in detail later. So fluid responsiveness, we will come to that later, how much fluid is to be given or whether at all fluid is to be given or not. Acute ischemia and mechanical complications of acute ischemia like MR, ruptured cordy, or ventricular septal rupture, or maybe a pericardial effusion. And last but not the least, intracardiac source of infection should be searched for in respected patients, because that can change the line of management and save the patient before it's too late. Next slide. So there have been several studies like this one, which has shown that use of bedside focused cardiac and thoracic critical care ultrasonography in acute hypoxic respiratory failure results in early identification of underlying etiology, and obviously early identification will lead to early management and will improve the chances of survival. And this has become especially relevant in nowadays because after the onset of COVID-19 pandemic, more and more patients are landing up in the ICUs with acute hypoxemic respiratory failure, where the cardiac versus the non-cardiac pathogenesis has to be differentiated as early as possible. Next slide. So we can incorporate the echocardiography with overall rapid ultrasound examination for shock and hypotension patients. We should not only look at the heart, but also the other aspects, not only the great vessels, but also the abdomen, as is done in a fast, and the pipes, that means the aorta and the femoral or popliteal veins, which also reveal important information and can prevent VTE. Next slide. So chest pain with hemodynamic instability, more often than not, we think of acute coronary syndrome or a myocardial infarction. However, I can go on and on with several cases which I have encountered in my short practice. However, I will just touch upon 2 or 3 cases which I can remember. You can go to the yeah. So one patient was a 50-year-old male with multiple CV risk factors, presented with 5-6 hours of chest pain with radiation to back, and he was given loading with DAPT, and the ECG showed some STT changes and widening of the QRS, and I was called upon to give my opinion whether he should be thrombolized or not. So when I did the bedside echo, I could see that the aorta was dilated. There was severe aortic regurgitation, and actually I could see the flap suggestive of the acute aortic dissection. So the whole line of management changed, and if those patients are given thrombolysis or management on the line of MI, actually it can do more harm, and we can even lose the patient. So after the diagnosis, actually instead of increasing the doses of antiplatelets and ionotropes, actually we had to start beta blockers and vasodilators and refer the patient before it's too late. So similarly, in many cases of chest pain with hemodynamic instability, pulmonary embolism, RARV dilatation with RV dysfunction, often we miss, and actually we lose the patient for for not starting the adequate therapy on a timely basis, or doing the further mode of investigation, which confirms the diagnosis. So similarly, pericarditis with tamponade can also present with hemodynamic instability, and it can also have chest pain and shortness of breath. And we should be able to identify, differentiate from a compressive from a non-compressive pericarditis, because a compressive effusion with features of tamponade must be drained on a timely manner. Next slide. Next slide, please. So sepsis is a very common diagnosis in the CCU setup. However, we should not forget that sepsis can also itself lead to some cardiac abnormalities like global and or segmental cardiac dysfunction, and also diastolic dysfunction. And even the cardiac structures themselves can be a source of sepsis, especially large vegetation or endocarditis. So we should not miss upon those things. Now, after we have diagnosed, comes the management part. That means echocardiography can also help us to assess the hemodynamic state of the patient, or the fluid requirement and the fluid responsive nature of the patient. So for that, we can calculate the cardiac output or the stroke volume by simple echocardiographic measures from the VTI of the LVOT and multiplying with the LVOT diameter. And if we multiply the stroke volume with heart rate, we get the cardiac output. So one thing I want to share is that sometimes you miss the LVOT gradient, especially in patients with LVH and after apical myocardial infarction. Often the other parts, especially the basal septum, contracts vigorously, which can be which is often hypertrophic. And often after procedure, patient lands up with hypotension and shortness of breath, and we think that whether it was a peri-procedural event. So actually, if we manage the LVOT gradient with proper fluid therapy and beta blockers, often the patient improves. So now moving on to lung ultrasound, we all know that the B lines can help us to differentiate pulmonary edema from cardiological, which is more diffuse and bilateral, to non-cardiac pulmonary edema, which can be.
Dr. Bashavendra, your time is over. Please come to conclusion, please.
Okay. So from B lines, the lung ultrasound can also help us for the diagnosis and aspiration of pleural effusion and diagnosis of pneumothorax when in doubt. T in critically ill patients is only reserved for those on mechanical ventilation in intraoperative studies, acute aortic syndromes for the confirmation of diagnosis, acute valvular regurgitation, prosthetic valve dysfunction, and these things. And before also cardioversion in symptomatic AF. Next slide. Contrast echo, I will just show the picture. It can help us to detect LV thrombus and pseudoaneurysm with more confidence. Next slide.
Please come to your conclusion slide.
Yeah. So there is some role in ECMO as well when we want to wean the patient. I will not go into the details. Next slide. Similarly, we can also use echocardiography during weaning from mechanical ventilation. We look at the right and left-sided parameters and adjust the positive pressure and the PEEP, or optimize our treatment with diuretics and inotropes and vasodilators before we can give a trial of spontaneous breathing. Next slide. So I think this was the last slide. So to conclude, we can say that it is very useful especially in patients with undifferentiated shock and acute respiratory failure, and it will help not only for the diagnosis but also assess the hemodynamic parameters and modify the management protocol. And it can be challenging with lots of gears and tubing around the patient, and formal training is very important for this before an operator starts performing individually, and we be confident to make the right diagnosis. An integrated approach involving other forms of ultrasound as well is key to the overall holistic management. Thank you.
Thank you. We come to the next speaker now, Dr. Das. Dr. Das.
Yeah, I'm sharing my screen. Can you see my slides?
Yeah, you are visible.
Yeah. Can you hear me?
You're ready.
Okay. Good evening. My talk today is on fetal echocardiography. Now, I would like to thank the organizing committee for giving me the opportunity to talk on this topic, which is very close to my heart. I understand that most of the people in the audience don't have a direct knowledge about fetal echocardiography, but being a cardiologist, it should not be difficult to interpret the images. And that's what I'm going to do in next 15 minutes. Disclosure, nothing much. All images used are from my personal collection. Now, we all know that fetal echocardiography is nothing but ultrasound of fetal heart. And it is an interdisciplinary area requiring skill of obstetric ultrasound as well as echocardiography. So I will not go into the details of acquiring images. Rather, I will focus on the images already acquired so that people in the audience who are quite acquainted with the cardiac structures and the hemodynamics abnormalities can understand the fetal heart. So I will divide my talk into 3 parts. First, I will go through some normal fetal heart. Then I will show some abnormal fetal heart. And at the last, I will discuss what everyone should know. So for the normal fetal heart, it is not different. We know about the cardiac structure, and I can be sure that everyone in the audience who does echocardiography will be able to appreciate that this heart looks normal. Why? Because in the mid trimester, this is about, I think, 23 weeks. So the fetal heart has more or less similar sized ventricles and atria. That's what we see. Determining the situs is an area which is out of the scope of discussion today, but the left atrium, as I am focusing on, is the atrium which is just in front of the aorta. You can follow my arrow here. And this is connected to the left ventricle, which is smooth. And this is the moderator band. And it is not difficult to identify the right ventricle with a moderator band and a more apical placement of the tricuspid valve. And you can appreciate that there is no ventricular septal defect. You can see on the color flow as well. And there is a PFO flap here, which is moving towards the left atrium. And you can see the right to left flow through the patent foramen oval, which is normal in the fetal circulation. Looking at the middle picture, you will appreciate that both the mitral and tricuspid inflows are normal. There is no stenosis or regurgitation. And in the most left and upper structure picture, you can see that this is the left ventricular outflow, and you can follow the right ventricular outflow with a crossover of the outflows, which is normal for a normal heart. And this is an important picture where we see both the outflow tracts, the ductal arch and the aortic arch. And in the fetal circulation, we know that the ductus is open and there are 2 arches. And this is the ductal arch here, and this is the aortic arch, which forms a V, which is called a 3VT view. I'll not go into the details again. And we can basically assess the fetal rhythm as well from the ventricular inflow and outflow Doppler, which I am showing here. Again, I will not go into the detailed assessment of the heart rhythm in this small talk. This is also a normal heart, and you can see the normal 4-chamber view. You can see the 3VT view where both the ductal and aortic arches are more or less equal in size. And this is the trachea, which is on the right of this V. So the aortic arch is on the left side. So this is the left-sided aortic arch, and you can see the pulmonary veins draining into the left atrium, including the color flow also. This is the longitudinal views of the heart, or rather the chest of the fetus. And you can see there are 2 arches. This is the ductal arch, which is arising anteriorly, and this is the hockey stick appearance of the ductal arch. And you can see the handle of umbrella or J-shaped aortic arch in the lower bottom picture. And you can see the SVC and IVC, which are draining into the right atrium here. In the movie also, you can follow the same pictures, including the aortic and ductal arch with flow. So we can see much more in detail in case of fetal heart, which we can't see in a transthoracic or transesophageal echo. Let us go to some abnormal hearts with this background of normal fetal heart. And I hope that all of you will be able to appreciate the differences with the normal. And I am sure that all in the audience who does echocardiography regularly will appreciate that there are VSDs in all these pictures. So you can see a small muscular VSD here, you can see a large perimembranous VSD here, and you can see a moderate size upper muscular VSD in the two lower panels. Now, again, if we look at this heart, the upper three pictures, if you focus on, you can see a large subaortic VSD with overriding aorta. This is similar like a parasternal long axis view, and you will appreciate the aorta is overriding the VSD. You can see the bidirectional flow across the VSDs. And if you focus on the middle picture, you can see the right ventricular outflow tract is much narrower compared to the aortic root. So there is a large VSD and the overriding aorta and the narrow RVOT. And in the lower pictures also, you see the same. If you compare with the 5-chamber or 4-chamber view of transthoracic echo, you can see that the aorta is being supplied from both the right and the left ventricles, large overriding, large VSD with overriding aorta. And this is the 3-vessel trachea view, which we just described in fetal echo, and where you can see both the ductal arch as well as the aortic arch. And ductal arch is much smaller if you compare with it with the aortic arch. And you can see that instead of V, this is forming a Y-shaped, and this is classical of a tetralogy of Fallot. So we can see all the features of tetralogy in these particular pictures. Now let us focus on this video and the still images. Now, out of the left to right shunt, only the VSD can be identified in the fetal heart because the patent foramen ovale and the ductus is present in all the fetuses. So this is, I am sure already some people have already have identified the problem. You can see the ascending aorta is dilated. This is like a 5-chamber view in transthoracic echo, and you can see that there is turbulence across the aortic valve with a dilated ascending aorta, and the aortic valve velocity is about 3 meters per second. So there is aortic stenosis. Let us go to the next one. I guess everyone will appreciate that there is significant ventricular dysfunction. So this is left ventricle, and you can see that there is some hyper-echoic endothelium as well, suggestive of endocardial fibroelastosis. In the lower picture, you can see that there is good flow through the tricuspid valve, but the mitral flow is limited. Because of the severe left ventricular dysfunction, the left ventricular end diastolic pressure is high. So most of the blood from the left atrium is bypassing the left ventricle and going to the right atrium through this patent foramen ovale. So the flow through the patent foramen ovale is left to right, which is reversed. It should be right to left in fetus. So these are indication there is severe left-sided obstructive lesion, and you can see the velocity through the aortic valve is again at about 3 meters per second with such significant ventricular dysfunction. We can use the M mode to assess the ventricular function, similar manner like we do in transthoracic echo, and you can see the fractional shortening is only 14%. This is the 3VT view, and again you can appreciate that the aortic arch is much smaller compared to the ductal arch, and there is a red flow which is suggestive of reversed flow in the aortic arch, and which suggests that there is significant coarctation with the duct-dependent systemic circulation. So this is critical aortic stenosis and evolving hypoplastic left heart syndrome. This is another picture where you can see that the left-sided chambers, left atrium and left ventricle, look smaller compared to the right heart. And in the 3VT view, you can appreciate that the aortic arch is very small compared to the large ductal arch. And you can see a narrow isthmus in both the longitudinal and 3VT view, suggestive of a coarctation of aorta. This is a picture where you will appreciate that the right-sided ventricle, the right ventricle is quite hypertrophied, and it is small, not forming the apex, almost half the size of the left ventricle. And when we put color, there is significant tricuspid regurgitation. The IVS is bulging towards the left ventricle, suggestive of severe right ventricular hypertension and suggestive of severe right ventricular outflow obstruction. In the outflow also you can see turbulent flow across the aortic pulmonary valve. and compare it with the neonatal echocardiography, transthoracic echocardiography, and you will appreciate the same pictures with a severe tricuspid regurgitation, high velocity, severe pulmonary stenosis with a velocity more than 6 meters per second. So that was a critical pulmonary stenosis. The baby was balloon dilated in the neonatal period and doing quite well. And this is a relatively multiple problems. Looking at this 4-chamber view, you can appreciate that the left-sided chambers are again a bit small, and you can appreciate that the coronary sinus is dilated as we see in transthoracic echo, and there is a VSD as well. And you can see that there is a bidirectional flow through the VSD. And this is a hypoplastic left heart with large VSD. There is interrupted aortic arch and bilateral SVC as well, suggested by the coronary sinus dilatation. And here you can see that there is a left SVC also along with the right SVC. The mitral valve and aortic valve are quite small with a Z score less than 2.7 in case of aortic and almost -5 in case of mitral valve. And you can appreciate that there is an interruption in the aortic arch. If I zoom on that area, you can appreciate that the aortic arch interrupted with the ascending aorta discontinuous with the descending part. Again, this is a parallel great arteries coming out of the left ventricle is the pulmonary artery, and the aorta is coming out of the right ventricle. I'm skipping the slides for the sake of time. Again, this one, everyone will appreciate that there is a large cardiac tumor, and you can appreciate that there is some ectopic beats as well. But look at the pictures just a few minutes later. There is severe ventricular dysfunction with tachycardia with heart rate around 250 per minute. So this is a rhabdomyoma with supraventricular tachycardia. The baby needs urgent delivery for further treatment. Now, the advantage of fetal echo is that we can look at the baby outside the heart as well. Here you can see in both the moving pictures, the right-sided chambers are dilated, but we don't find any problem in the heart. But if you look at the brain in the upper two pictures, you can appreciate that there is a large vascular structures within the brain, and this is called vein of Galen malformation causing right ventricular volume overload. And the lower one is a very rare abnormality where the right umbilical vein is persistent, and you can see draining directly into the right atrium in addition to the IVC causing right ventricular dilatation. Anyone will probably appreciate these two pictures. This is the complete avicanal defect, and this is Epstein's anomaly on the right side with abnormal tricuspid valve and a common AV valve. I'm skipping these slides with for the sake of time, and let us come to this very important topic, that when to do fetal echocardiography. So there are two parts. What are the indications and what is the time? That's when during the pregnancy we should do a fetal echocardiography. So this is the recommendation by International Society of Ultrasound in Obstetric and Gynecology. I'm not going to the details again. This is a recommendation which is a much shorter one and abbreviated one. So let us look at some of the maternal and fetal indications. So all in vitro fertilizations should have a fetal echocardiography because of increased chance of fetal abnormalities. Any mother who is diabetic should have fetal echocardiography. There are many other indications out of the fetal indications. Definitely, if there are abnormal ultrasound, one should go for fetal echocardiography. There are many other indications. This is the recommendation by American Heart Association. One can find it out in the net, and definitely one should be updated with these recommendations. About the timing, when should we do the fetal echocardiography? So now termination is possible in our country without legal help up to 24 weeks. There has been a recent change in the PNDT Act. So according to that, the ideal time should be 20 to 22 weeks of gestation when we can see the fetal heart very well. Definitely it can be done earlier also, but it may not give us a very complete and comprehensive picture, but we should avoid to do it later than 24 weeks unless it has not been done. So why it is important? Just look at this news. This is from this month only. The High Court refused to terminate a pregnancy with, I have shown the pictures of this particular patient as well in my talk, and you understand the anguish of the parents. So it is to save the family, to avoid the legal uncertainties once it is more than 24 weeks. And at the same time, it is to save yourself to avoid medical negligence. And my time is almost finished, so I'll go to end my talk here. And I would like to thank you for your patient hearing. And I hope you have some idea about the fetal echocardiography and the fetal heart. Thank you so much.
Thank you, Dr. Das. I think we don't have time for any further questions. Dr. Sinha, please.
Okay, that was a very interesting session. Next, the last session of the day deals with arrhythmia. Speaking on this topic will be Dr. Debabrata Bera, Dr. Suchit Mojumdar, Dr. Dilip Kumar, and Dr. Sumanta Chatterjee. Moderating this session will be Dr. Alok Mojumdar and Dr. Dipankar Mukherjee. Chairing this session will be Dr. Manoranjan Mondol, Dr. Amit Rai, Dr. Uttam Shaha, and Dr. Jayanta Shaha. May I please request the moderator to carry forward this session.
Good evening. After the huge talk on various subjects and a very successful CME type, we are now at the end of the session, and we have 4 speakers. Everybody will be given 15 minutes, and they are very knowledgeable and they are very eloquent in their speech. I will request Dr. Debabrata Bera, who will be talking on the frequent ICD shocks. Dr. Bera, please. Dr. Debabrata Bera.
Good evening, sir. Am I audible, sir?
Yeah, very good audible, and slides
sir,
are
sir,
also.
a very good evening, sir. A very good evening to you, all my respected moderator and chairperson, and all my dear audiences. So, first of all, it's very thankful to give me this opportunity to speak on this prestigious forum. Without wasting time, I'll directly go into my talk. So, it is about a patient who comes with recurrent or frequent ICD shocks with, and what to do with that patient. Now, I thought I'll just discuss 3 or 4 cases as per the time takes, and without talking much of the theory. But because I know many of our audience is not EP audience, majority or cardiology audience, I'll just take one theoretical slide for the rest of the discussion. So when we think about or interrogate a device or ICD, especially who comes with recurrent shocks, we need to know whether the shock is appropriate or the shock is inappropriate. And the key thing comes when you interrogate an episode which has been stored. Anytime the patient receives the therapy, the episode is stored. And what you need to see, there will be something like this electrogram. These are called intracardiac electrograms. And these are stored intracardiac electrograms or can be real time. What we see in that, we need to just see first, this is called a far field electrogram, which is about what a device or ICD sees from little away or far. It is like a bird's eye view. It is the overall cardiac activity, and it is something like a ECG which the ICD is picking up. And this electrogram, far field electrogram, comes from the can to coil. There is a vector which starts from the can and ends at the coil. So this big vector takes care or reflects into this far field electrogram. There is another EGM which is called a near field electrogram. That near field electrogram is the electrical activity picked up at the tip. That's why it is called near field. Generally, this activity is like a spike. This is not like a ECG, whereas the far field is like a ECG. Now, based on these 2 far field and near field activity recorded on this channel, it reflects into the marker channel. Now, importantly, this marker channel, what is this? On this marker channel, the sense activity will be marked, and based on that, a decision will be taken for a therapy or no therapy or whatever. Now, almost always the default setting nowadays, recent ICDs are coming from this near field sensing channels, because far field sometimes picks up external activity because the antenna is large, whereas the near field definitely almost always picks up the internal activity provided the electrode is properly inside the right ventricle. Now we'll go to one of our cases. I'll go first, the first case I'll go a little slow for the understanding of my junior colleagues, and then the next couple of cases we can go a little fast. So this is a patient who is a 63-year-old gentleman with non-ischemic cardiomyopathy, and he had a fast VT and he was implanted with an ICD. Now, after 6 months, he comes with recurrent ICD shocks when he was coming out from a bathroom. What we find that there is, this is a St. Jude pacemaker or Abbott ICD. So there is a, this upper channel is the near field, which I told is looking like a spike, whereas this is far field. This discrimination is actually the far field, that is can to coil electrogram, which looks like somewhat like a ECG. So what does it look? This far field electrogram, whenever records, it matches and try to compare with the baseline template which the ICD has taken and kept in memory when the patient was in sinus. Now, this is an episode. When there is an episode or a tachycardia, it compares each beat to beat and tells us a percentage. So if you look at it, it is like this beat is 88% matching with the sinus, this beat 88%, 82%, 88%, 90%, 85%, 88%, like this. So now we have a tachycardia. What is the feature? The QRS morphology looked by the ECG or seen by the ICD is almost similar, is almost 80 to 90% matching with the sinus QRS. What does it mean? This means this is less like to be a VT, although rarely possible. Most of the time when a patient develops a ventricular tachycardia, the QRS morphology changes drastically. So this comparison will, the scores will come like 10, 15, 20 like this. So this is one thing which tells that although this episode has been described as VT, it may be SVT. The match is so good. Second thing is, if you look at the RR interval, these intervals are so much varying. If you just look at this channel, far field channel, it itself tells you so much of irregularity, and here it is so drastic. It tells that most likely the patient has atrial fibrillation. Now the device, in fact, initially called it as SVT. Then the device gives, so here from SVT, suddenly the device called it as VT. Why? I will come later. So as it detects it as VT from SVT, it gives a therapy. It is called ATP, anti-tachycardia pacing, 2 ATP. Then there is another ATP, and obviously, as we are suspecting this was atrial fibrillation, ATP doesn't make any difference. Finally, it gives a shock. A 10 joule shock was successful enough to convert the atrial fibrillation into sinus rhythm. Now the question is, this patient indeed had recurrent paroxysmal atrial fibrillation, for which he received almost 3-4 shocks when he was doing activity. So this patient initial diagnosis was SVT. Why SVT? Because the morphology, this patient, the morphology by default was kept as 91%. That means if the majority of the QRS complex has similarity with the template more than 90%, will be called as a supraventricular tachycardia beat and not a SVT. So it was indicated SVT. It was a sudden onset because it was atrial fibrillation. It was sudden onset. But ICD, sudden onset means comparison between sinus tachycardia versus others. For ICD, sudden onset means it is any of the tachycardia. If it is gradual onset, that means it is most likely sinus tachycardia. What is the third one? So these three, although there are various companies and there are various protocols, majority of the ICD companies for SVT versus VT discrimination, they look at morphology match. They look at the sudden onset, whether it is sudden, then it is tachycardia. If it is not sudden, it is sinus tachycardia. And it is interval stability. This interval stability means if the RR is variable, that it will call it as SVT, most likely FF. If it is very stable, it will consider it as VT. Although there can be AVNRT, AVRT, which can be very stable although. Okay. Now what happened? Initially, the VT diagnostic criteria for this patient was kept as 2 out of 3. This is again a default setting. You can change it. So for this patient, initially, only sudden onset was in favor of VT. Other 2 were in favor of SVT. So it only fulfilled 1 out of 3. So it's called SVT. But after some time, there was little faster rate and there was a rate-related aberrancy. So with subtle rate-related aberrancy, the matching came below 90% in majority of the beats, and immediately it called, by morphology criteria, it called it VT. and that fulfilled 2 out of 3 VT criteria, and the patient received inappropriate therapy, initially ATP followed by shock. Now what to do? Because we know, I think this patient has, although this same setting will work for many patients, but for this patient it did not work. So what to do? What I did, I knew that his VT beats are much more difference will be there in the morphology. I made it 75%. I make it more lenient. Like even if you find a 75 to 80% match, consider it as a sinus beat and not a VT beat. So that will take care of this problem of morphology match. The sudden onset was already on, interval stability was already on. So this patient on this setting is on 1 year follow-up. Now, one of the important things, not only change the parameter setting, you have to take care of the medication and the other part. If the patient is not on a proper antiarrhythmic drug, you have to take care of the atrial fibrillation, like amiodarone, sotalol you can give, or you can have to give rate control drug. Even if the patient develops atrial fibrillation, the ventricular rate should not go into the VT zone. So that way you can avoid inappropriate therapy. So take home from this patient is atrial fibrillation diagnosed as VT and inappropriate ICD therapy was received. In fact, this is by far the most common cause of inappropriate ICD therapy. You can keep stability on, for this patient is already on. You can keep the template match little lower than 90% the default setting, or you can keep the VT criteria more stringent to avoid such therapy in this particular patient. For sinus tachycardia, if you want to avoid in some young patients, you need to switch on onset, and morphology also is generally keep it on. Now let us go to second case. It's a 55-year-old lady who had a dilated cardiomyopathy, again had a VT and underwent ICD implantation 2 months back. Now this patient, one fine day, he came with 4 ICD shocks and there was audible alarm. When you interpret the device, you find this is a stored electrogram or device lock we call. There is a ICD therapy or shock of 36 joules. And for what she received in FS means this tachycardia is in CF.
Sir, sorry, sir. Hello. Hello.
Yes, I can hear you.
Sir, but we are unable to hear you. Voice is not clear.
Is it clear now?
No, your voice not at all clear, sir. No. Can you remove your headset? If you are wearing a headset, kindly remove your earphone. Hello.
Is it audible now?
Yeah, now audible, sir. Now clear.
Oh,
Please
sorry. I don't know how much was clearly audible till now.
1 minute back, sir. Maybe approximately 1.5 minute back from there.
Shall I go back and repeat last 1 minute or so? Am I audible?
Sir. Yeah, sir. Now, yeah, please.
Okay. So shall I go back for last 1 minute was not properly audible? Last 1 minute?
Correct, sir.
Okay. So what I meant to say, if I summarize the last case was initially diagnosed as SVT because 2 of the criteria, that is morphology match and stability, they suggested that this is SVT. The morphology match suggested that most or majority of the beats were having a QRS complex match more than 90%, and it was a unstable rhythm. So that's why it called it as a SVT. Unstable rhythm means the RR interval was very much variable. So it was most likely atrial fibrillation. But after some time, the rate of the tachycardia, the ventricular rate increased slightly, and there was a little rate-related aberrancy that made majority of his tachycardia beats morphology match. Match means the matching of the present QRS with the sinus template which has been achieved during sinus rhythm. So that was less than 90%. As soon as the set was 90%, so this was the set threshold. So as it was less than 90%, it fulfilled 2 of the criteria. The atrial fibrillation was sudden onset, so it already fulfilled the criteria of sudden onset, and the morphology also suggested that the matching is less than 90%. These 2 fulfilled diagnosed as a ventricular tachycardia after some time, and he received inappropriate therapy. So the problem here was a template match. So what we did, we reduced the stringentness of the template match. Initially it was 90%, we did it 70%. That means we asked the ICD, even if some of the QRS
during a tachycardia is matching more than 75-80%, you consider them a non-VT beat. If that is the case, it will not fulfill 2 out of 3 criteria. The other ways you can do it is, you can keep the stability on, which was already on in this patient, or you can keep 3 out of 3 criteria. That means you ask the device to call it as a VT only if there is all 3 criteria. Morphology is like not matching sinus, it is a stable rhythm, and the onset is rapid, or the onset was sudden. So to avoid sinus tachycardia, there is something is called onset. So if you want to avoid sinus tachycardia in some young patients, the onset has to be switched on. Am I audible? Am I well audible?
It's audible. Proceed.
Okay, sorry. So coming to a second case, this was a 55-year-old lady who received a ICD for a ventricular tachycardia, and she already had a dilated cardiomyopathy. Now comes with 4 ICD shocks within a span of 2 days, and there was an audible alarm as well. When we detected or checked the device, interrogated the device, we found this is one of the episodes. All of them were similar. So there was a shock here. It was a 36 joule shock, and for what she received shock was, when we looked at the marker channel, we find multiple very frequent, that is FS means it is the VF zone, ventricular fibrillation zone. TS means it is in ventricular tachycardia zone. You can set the zones. So we find there is almost like a VF which has been detected here. But when you look at the far field electrogram, we find there is discrete QRS complexes which are not at all correlating with this FS or VS or TS. And also we find in the near field electrogram, which we discussed in the first slide, this near field electrogram has a lot of noise. And as I discussed again, this near field electrogram is the only thing which gets reflected in the marker channel. This noise in the near field electrogram got detected in the marker channel and detected as a VF, and she received an inappropriate therapy. So again, as I tell you that when you look at the intervals, they are not at all matching with the far field electrogram. This far field electrogram is clean and it shows almost like a regular rhythm, like a sinus. It is in 25 speed. So that means there is a over sensing going on. Now, what is this noise? It can be an internal noise from the lead. It can be an external noise like a electromagnetic interference. But generally, EMI or electromagnetic interference are reflected in both the channels, near field as well as far field. In this patient, we found only the near field has the noise, not the far field. And why is it so? When we checked the device, the impedance was normal, but the threshold was high. And if you look at the X-ray, it was found that the lead is almost outside the heart. It is reaching almost the chest wall. So this was an ICD lead perforated out of the heart, and picked up diaphragmatic myopotentials, that high frequency potentials. So this patient again received an inappropriate therapy. So we planned for ICD lead repositioning or replacement. We thought of changing the lead altogether. So when you have noise, you need to keep all these things in mind. Either there is a lead fracture or lead insulation break. There could be loose set screw in the perioperative period. There can be myopotentials or EMI. If the impedance is changing or it is showing variation, generally it is lead related issue or loose set screw. When there is no impedance change, generally they are myopotential or EMI. Coming to a third case, Mukherjee sir, please stop me when my time is over because there was some audio issue. I think I am out of my own time zone. So please stop me when I have 1 minute left.
Okay, you continue.
Sure, sir. So this is the third case. Again, this patient is a ischemic cardiomyopathy dysfunction. He received ICD monomorphic ventricular tachycardia, and now she comes with recurrent ICD shocks. Like the previous case, we interrogated the device, and what we find here, the upper channel is the atrial channel, and the second one is the ventricular channel. Now here we clearly see the number of V is more than number of A. So this tells this is a true ventricular tachycardia, like a rule of thumb. V more than A, that itself tells you, or QR more than P is itself, QR is more than P wave, itself tells you this is a ventricular tachycardia. In fact, the far field is not shown here. His morphology was also not matching the sinus template. So both these suggested it was a true ventricular tachycardia. Now how to treat it? So this patient who received multiple shocks, we started him, actually he was on oral amiodarone, we had to hike the dose. We also had to hike the dose of beta blocker. And the plan was to consider VT ablation because this is or old MI. So they are discrete channels which we can ablate by radio frequency under 3D electroanatomic mapping. And we can also consider a bilateral sympathetic denervation if radiofrequency ablation fails. Fortunately for this patient, medication itself worked, so we did not have to go for any other difficult treatment approach. Coming to my last case. So this is a 45-year-old lady who received the ICD for apical hypertrophic cardiomyopathy. Now, the front page itself tells you this was a VF episode. We'll go to that, how was it a true VF? But whenever there is a VF episode, you have to be very careful. Because VT generally you can treat with drugs, you can treat with ablation. For ventricular fibrillation, there is less or limited opportunities of drug as well as ablation. So, as you see the episode, this is the discrimination or the far field. That means it is equivalent to the ECG. And this is the atrial channel. So, when you look at it, the tachycardia starts, the QRS remains reasonably similar, and there is same amount of or same number of A as V. So there is almost like 1:1 AV ratio. So it could be a ST, it could be a ventricular tachycardia with 1:1 VA conduction. So when you see this, in fact, the device detected it as SVT because of this 1:1 VA ratio as well as the good morphology match. But as soon as the SVT, up to here it was diagnosed as SVT. As soon as the SVT terminates, or it could be a VT, the machine might have misdiagnosed as SVT. But as soon as this tachycardia terminates, there is a true ventricular tachycardia. You can see it's almost like a polymorphic VT. And later on, it is a true VF for which she received a therapy. So we thought this is definitely a SVT which has triggered a ventricular fibrillation. And what is the most common tachycardia in HC? Because of the stiff ventricle and also the enlarged atrium. So we thought it is atrial tachycardia. We started her on amiodarone. Still, within next 2 weeks, she received recurrent shocks. And coincidentally, all those shocks, another 3 shocks, all of them induced just like that. And it was a ventricular fibrillation. We cannot ablate a ventricular fibrillation generally. So we looked at the onset of the tachycardia. We knew that possibly it started PSC, and as soon as the premature atrial complex comes, there is a PR prolongation. If you look at this PR is prolonged. Every time this has happened. When during an onset of a SVT, you have a PR prolongation, you have to think that this tachycardia is AV node dependent. So we thought, are we dealing with a AVNRT or AVRT? Because if we are dealing with AVNRT or AVRT, they are easily treatable by ablation. Whereas atrial tachycardia, there could be multiple atrial tachycardia in a background of structural heart disease. So we took this patient for EP study. There was a surprisingly we found a left lateral pathway, a concealed left lateral pathway, easily inducible orthotomic AVRT. RFA was done 1 month back, and she is doing well without any further recurrence. So I'll conclude my talk with telling that when you have to discriminate between ICD recurrent shocks. You have to discriminate between artifact or noise versus a true arrhythmia. When you have a true arrhythmia, you need to discriminate between VT and SVT. And when you have a ventricular tachycardia, you actually need to differentiate between a ventricular tachycardia and ventricular fibrillation. Now, when you have to differentiate between these two, because when you have a ventricular tachycardia, you need to treat it with drug, ablation, or sympatherectomy. If it is ventricular fibrillation, generally ablation has very limited role. It is about only drugs which you can take care of. or if there is some particular PVC, say monomorphic PVC triggering a VT like a R-on-T phenomena, you can ablate those PVCs. You also have to always be vigilant as whether there is any curable SVT, like the last case, like a typical AVNRT or a pathway-related AVRT or a focal tachycardia, which can be cured by a simple ablation. If it is a paroxysmal atrial fibrillation, like the first case, you definitely need to take care it with drugs. And if fails, you can consider atrial fibrillation ablation or a AV node ablation. Thank you so much. And thanks for the opportunity. Sorry for the taking a little longer time.
Oh, absolutely nice. And with proper illustration, you have made the lecture very fruitful to all the cardiologists. I think we should go for the next speaker. I'll request Dr. Amit Rai to announce the next speaker.
Thank you, sir.
We are not audible. Our next speaker is Dr. Suchit Majumdar. He'll be speaking on 12D ECG reported it. Yeah, Dr. Amit Rai. Amit da bolo. Amit da, now you are audible.
Yes, Dr. Suchit Majumdar will take over.
Yeah.
As how the 12-bed ECG can diagnose a sudden cardiac death. Is the prognostication and its variation will be deliberated by Dr. Suchit Majumdar. Yeah, Dr. Suchit Majumdar.
Yeah. I think my slides are visible now, most likely.
Yeah.
Okay, so let us start. 1 second, make it full screen first. So at the outset, I thank the CSI West Bengal or Scientific Committee for giving me the chance to present in this August gathering. Though it is virtual, and I will always hope that in future we meet in person. But then also, I think let us deliver the talk, which is an important topic in itself. So the talk is about a 12-lead ECG, whether it can predict arrhythmia and sudden cardiac death. Now, sudden cardiac death, still after so many developments and all of these things, still it accounts for 50% of the cardiovascular death. And even there is a very low rate of survival following sudden cardiac death. If the survival is even lower if you're out of hospital sudden cardiac death, and also depends on the country. For example, here we don't have availability of AED, and also bystander CPR is also not well in vogue. So in these cases, the low rate of survival is there. Hence, the importance comes of predicting a sudden cardiac death and prevention of sudden cardiac death. Now, since long time that LVEF is a marker of sudden cardiac death, and all ICD trials and everything centers around the LVEF value and to predict the sudden cardiac death and prescribing AICD. The 12-lead ECG, on the other hand, is a widely available, inexpensive and non-invasive tool, and is familiar to all the physicians. And also is a time-tested modality reflecting the electrical activity of the heart. And it is intuitive that it may contribute significantly to identifying the risk of sudden cardiac death, which is usually the result of electrical disturbances. Now, before going to the most common cause of sudden cardiac death, that is coronary artery disease and subsequent VF, VT, let us discuss something in which ECG is more importantly shown to be valuable. That is inherited arrhythmia syndrome. It is rare, but they have a clear genetic basis, and ECG forms the mainstay of diagnosis of inherited arrhythmia syndromes. And what are the inherited arrhythmia syndrome? Long QT syndrome, Brugada, catecholaminergic polymorphic VT, short QT. Here we see hypertrophic cardiomyopathy and early repolarization syndrome. So these all have a particular genetic basis, and ECG forms very important criteria for the diagnosis. I'm not going into detail, but these are very important in these cases. So for example, we go into one or two syndromes which is important. One is a Brugada syndrome. Brugada syndrome is diagnosed in patient with an ST elevation with a type 1 morphology more than 2 millimeter in more than one lead among the right precordial lead V1 and V2, either positioned in the fourth, third, or second intercostal space, occurring either spontaneously or after a provocative sodium channel blocker testing. So this is the Brugada syndrome, and ECG is very important in the diagnosis because diagnosis depends on Brugada syndrome. Important thing here is that Brugada pattern may not be present in all the ECGs, that it can be transient and may be present only during fever. So in those patients, a febrile fever time ECG may be very important to detect Brugada syndrome, whereas other ECGs may not show it. Also, prognostication is very important because type 1 has a graver prognosis than type 2 and type 3. And if you have a fragmented QRS with Brugada syndrome, that has a bad prognosis. And even spontaneous AF in a Brugada syndrome is correlated with more chance of sudden cardiac death. Also, the type 1 versus type 2 and type 3 is important in deciding the management, that whether the patient requires an ICD and quinidine. So coming to the long QT syndrome, the long QT syndrome is diagnosed by a score more than 3.5, and if you and also or by a genetic mutation of the long QT genes in the presence of a QT interval for heart rate using Bayes formula more than 500. Long QT can be diagnosed in the presence of a QTC between 480 to 499 in a patient with an unexplained syncope in the absence of a secondary cause of QT prolongation in the absence of a pathogenic mutation. So in long QT, it is important to measure the QT and it prognosticates. Also, the type of long QT depends on the broad QRS, broad T wave, or a notch T wave, or a ST segment, and then there's a narrow base T wave. We can diagnose the different types of long QT and diagnose the treatment and also manage the treatment. For example, long QT type 2 and 3 may be less responsive to beta blocker. Long QT type 3 may be responsive to mexiletine. All these things are important if we know the type of long QT by the ECG. So it is a risk stratification for arrhythmia and sudden cardiac death. Also, QT is very important to risk stratify patients of acquired long QT, that is drug-induced long QT syndrome. Now, a long QT syndrome before a torsade often shows T-wave alternance that is also picked up by ECG and is a harbinger of torsades in long QT syndrome. So coming to the more common type of sudden cardiac death, that is the CAD-associated sudden cardiac death or other myocardial scar-associated sudden cardiac death. Here we have markers which are markers of abnormalities of depolarization or markers of abnormality of repolarization. Also, resting heart rate, which indicates an increased sympathetic tone, is an important marker. In the Paris prospective study, subjects with heart rate of more than 75 had an almost fourfold risk of sudden cardiac death compared with those with heart rate of less than 65. And higher heart rate predicts appropriate shock, VF, and sustained VT in some ICD trials. Heart rate is closely tied to autonomic tone, which influences the risk of arrhythmia. Now, one can say that heart rate is influenced by drugs. So how can it be an independent marker? Even after corrected by the confounding effects of the drugs, it has been shown that higher heart rate has a more chance of sudden cardiac death. Now, coming to the abnormalities of depolarization, I'm dealing one by one. First, coming to the Q wave. Q wave represents a loss of myocardium and possibly LV dysfunction and scar, and this has been associated with increased risk. There are even QRS scores which predict the increased risk. But Q waves is mostly seen in CAD. It can be also seen in HCM and others, say L kappa and all these things, but mostly seen in CAD, and fail to distinguish between an arrhythmic risk and heart failure risk for mortality in these patients. Now, coming to the second abnormality of depolarization, that is the longer QRS duration. The long QRS duration has been shown to be associated with increased risk of sudden cardiac death, irrespective of the presence of bundle branch block and even after controlled for the presence of CAD. Prospective population-based study in Finland showed a 27% increase in sudden cardiac death risk with each 10 millisecond increase in the QRS duration. Now, if we compare the different types of longer QRS duration, whether it's IVCD, LBBB, or RBBB, it has been shown that IVCD is most importantly associated with increased mortality. LBBB has a smaller chance of increasing mortality, while RBBB is not predictive of increasing mortality in this group. Acute prolongation of QRS in an ischemia, acute ischemia, is an important predictor of VF and sudden cardiac death. Now, coming to another important thing called as a fragmentation of QRS. There are different definitions of fragmentation of QRS. I'm not going into detail. Most are different RSR patterns, and they have recently generated considerable interest as a potential risk marker. because these are thought to result from disrupted electrical conduction in areas of decreased diseased or fibrosed myocardium or scar, and thus a pathophysiological correlation of reentrant arrhythmias in these cases. And it is better than Q waves in detecting scar, and studies have shown that fragmented QRS is related to SCD as well as ICD shocks. And fragmented QRS in different myocardial anatomic territories also predicts different risks. So important in CAD, ARVC, amyloidosis, and sarcoidosis. Also, usually these fragmentation of QRS is associated with decreased voltage. That is very important of indication of scar. Now, these are the different types of fragmented QRS noted on the left side. And also important is that whenever you are dealing with measurement of fragmented QRS, don't reduce your low pass filter. If you reduce your low pass filter, the number of spikes of QRS will be reduced in an ECG, and you may miss the fragmentation. So low pass filter should be kept around 150 to detect fragmented QRS in these patients. Now coming to the LVH on ECG. Recent analysis among SCD cases showed very low overlap between ECG and echo LVH, with more than half of those who had increased QRS voltage not manifesting echocardiographic LVH. And ECG LVH was independently associated with SCD risk even after adjustment for echo LVH. So even if echo LVH was not there, if the patient has an ECG criteria of LVH, it is independently associated with SCD risk. Increased myocardial voltage may be reflecting adverse electrical remodeling and conveying a risk that could be distinct from that conferred by anatomic LV hypertrophy. Now coming to the abnormalities of repolarization. First is the QT prolongation. Apart from risk of arrhythmia and SCD in patient with long QT syndrome, it also indicates the risk of SCD in the community at large, even if the patient has no long QT syndrome or doesn't have a acquired long QT. If a patient has an increased QRS duration, there the QT interval may be definitely increased because of the QRS duration. So how to differentiate whether the increase of QT is due to the depolarization or a repolarization abnormality? There you can deduct the QRS duration from the QT interval, which is called as a JT interval, and that may be more indicator of repolarization abnormality for risk stratification for sudden cardiac death. Evidence from the Oregon SUDS study suggested that while diabetes and QT affecting drugs contributed to SCD risk, idiopathic QT prolongation unrelated to either of these factors was the strongest predictor of SCD in CAD, conferring up to for 5-fold increased risk. QTc of more than 450 milliseconds in men and more than 470 milliseconds in women appeared to be an independent predictor of SCD in patients undergoing bypass surgery. This is from another study. Now coming to a very important thing. This is also a very important indicator of repolarization abnormality. This is called as a T peak to T end interval. I will come how to measure that. A prolonged T peak to T end interval may reflect a period where the epicardium has fully depolarized, but the endocardium is still recovering. And it is an indicator of transmural dispersion of repolarization. And this could create an electrical substrate for after depolarization driven reentrant ventricular arrhythmia. And importantly, T peak to T end interval was more strongly associated with SCD in patients with prolonged QRS duration where measurement of QTc is challenging. Also, TPE or TPE by QT ratio is a predictor of arrhythmic events in inherited conditions such as Brugada syndrome and hypertrophic cardiomyopathy. So this is how you measure the T peak to T end interval, and that is very important for detecting transmural dispersion of repolarization. And this creates a phase 2 reentry, giving rise to a arrhythmia. Now coming to early repolarization pattern, we all know this. This was reported to have a link with idiopathic VF, but its broader association with more common forms of sudden cardiac death was demonstrated even in patients with acute coronary syndrome. It has been recognized that there are benign and malignant varieties depending on the ST segment. If it is an ascending ST segment, it is less dangerous than a horizontal or a descending segment. The QRST angle, it is a difference between the depolarization and repolarization vectors. Increased QRST angle has been associated with increased sudden cardiac death risk. So this is a early repolarization pattern, just an example. Now we see all the different things. One is a loss of myocardium by Q waves, increased QRS duration, QRS fragmentation, increased QRS voltage, and on the other hand, repolarization, increased JT interval, increased TPE, ER pattern, and increased QRST angle. Now, that's why the importance of cumulative risk comes. As SCD represents the convergence of multiple risk-inducing processes, it stands to reason that using multiple risk factors reflecting different facets of the heart's electrical activity would convey more information than a single marker. And validation of this approach in large population-based studies would be needed to finally develop an electrical risk code derived from the ECG. An ECG likely represents only one arm of a multi-pronged approach to SCD risk prediction. One is ECG, another is genetics, biomarkers, and imaging. And apart from this, there are dynamic ECG changes which can be picked up by telemetry, Holter, or ILR, or ICU. And most important to predict arrhythmia in ACS, and you can have a T-wave alternates like of thing, dynamic STT changes. All these things predict SCD in CAD. There are ECG predictors needing special software and analysis. I am not going into detail because these are not available everywhere. So these are called as, they may need a spectral analysis and all these things. So this is called as a microwave T-wave alternates. This is a predictor of torch sets and also sudden cardiac death in low EF, heart rate variability, signal average ECG. This usually detect the late potentials and also very important in diagnosing of ARVC and also in CAD. But these are not accessible to many and require special analysis. So I am not going into detail. So in conclusion, the utility of this modality is undisputed for making a diagnosis and assessing the risk in patients with primary and inherited arrhythmia. So these are already established. But several ECG markers have also been associated with increased risk of more common forms of SCD like those associated with CAD and ACS. And it is likely that these will not be used as a standalone predictor, but used as a score to predict risk in a cumulative manner, even in combination with other risk stratification tools like genetics imaging. Thank you.
Thank you, Suchit. It's a very good deliberation and very useful to everybody, every cardiologist and physician, I think. I think you will be here. Will let us finish the session and then the question answer will be unlimited time. Now, Dr. Dilip Kumar, he will be speaking on a patient with 50 years old with torsades. How to approach? Dr. Kumar, please.
Thank you so much, and thanks for having me here. And I am asked to discuss a case which is a 50 years male presented with torsades. Let me say it in the beginning that not all polymorphic VTs, which looks like this, are torsades. So torsades will mean that a polymorphic VT with a of axis with a long QT in the baseline. Then only we call it torsades, and similar kind of polymorphic VT we can have in ischemic etiology, CPVT, which Suchit has a little bit touched upon. And they are basically paroxysmal. They can degenerate into VF. Which patient is going to degenerate? So our 50-year-old male, and we have to kind of consider that he is having a torsade. So what could be the possibility, and what is the possibility of him going, down and have an outcome? So basically, torsades is of very low amplitude. He has a very bad family years. Chances are less that he had a very bad family history, and a T-wave alternance, which has been assessed, impressed upon earlier also. So T-wave alternance, low amplitude torsades, these are, a marker of bad prognosis. So this gentleman looks like having acquired kind of a long QT, but definitely we can't say that this is it's not a congenital, because usually these are mixed, and many times the long QT, they persist 40 years, 50 years, less malignant form of congenital long QT. So a good history will clinch the diagnosis here, a good family history, a precipitating factor, recent illness, what drugs he has been taking off late. After that, we can a good examination and a general ECG, a good ECG, quality ECG, and general tests can give us an indication and diagnosis in this patient. So coming, to torsades. So basically congenital is most common, and acquired, these are mixed variety. There are some underlying factors, and then added on with hypokalemia, hypomagnesemia, other factors, they generally precipitate. And congenital are adrenergic dependent. Acquired are basically most likely bradycardia, pulse dependent, short long sequence happens there. So this is how a ventricular action potential develops. And to be precise, the in long QT and torsades, the problem lies in the phase 3 depolarization most of the times, where delayed rectifier currents, potassium channels, they are having some problem, and they are abnormal function. So when there is a kind of a delayed repolarization, it is basically early after depolarization, and this doesn't happen in all the cells in the myocardium. It happens basically in the deep endocardial and the mid myocardial layer, where there are M cells, and there the kind of concentration of potassium current, delayed rectifier current, is less. So that's why they are more prone to have after depolarizations. And then added on with a short long sequence, there is a transmural reentry. So basically early depolarization precipitates, and a transmural reentry establishes the torsades. So these are M cells and endocardial cells, and how they can lead to early after depolarization, and then finally reentry, and finally torsades happens. So let's look at the history. Quinidine associated syncope is known to us since 1920s, 1950s, and 1960s. We had an idea about congenital syndromes. But in 1966, Francois Dessertin described a specific EKG form of polymorphic VT, which is termed torsades de pointes, and this is a French term which means twisting and turning of the axis from from the baseline. And this is, over the past decades, single most common cause of drug withdrawal, restriction from market. So we all have encountered some kind of torsades, and we have seen drugs causing havocs. And if we don't be vigilant on the ECG and the QT, keep on giving drugs, and 1 or 2 paroxysm patient can be saved, but later on patient succumbs. So this gentleman, 50 years, needs a very precise ECG observation and the drug history. So 9 structurally unrelated non-cardiac drugs have been withdrawn. These are terfenadine, nastimidol, and then additionally non-cardiac like crepafloxacin, cisapride. So there are long list, and there are also list of recent FDA warnings on very common drugs, which we all know, and like azithromycin in 2013, non-nesatran, domperidone, citalopram, one of the most widely prescribed drug, haloperidol. So these all drugs have potentials to cause long QT, and we have to be vigilant. When it comes to prevalence, it was basically assumed without any supporting data that it hovers around 1 is to 5,000 to 1 is to 20,000. But Italian registry, 18 Italian maternity hospitals in 2009, they reviewed the ECG, the history, and the detailed examination and observation. They came to a conclusion that something like 1 is to 2,000 roughly is the prevalence of long QT. So diagnosis depends on the history, long QT associated syncope, provocation like accident, drownings, emotional, and QT C of more than 450 millisecond in male and 460 millisecond females. How to calculate a corrected QT is very important. We all know about Baggett's formula, but this is very important to highlight and affirm that this is RR in seconds, it's not RR in milliseconds. And this is a quick method. So every 10 bits increase in rate will reduce QT by 20 milliseconds. So someone has a QT of 400 milliseconds at rate of 100. So QT-C tells us that what is the exact QT at 60 heart rate. So this patient has a 40 beats higher than 60 in a minute, then 4 into 20, 480 milliseconds is the QTC interval. So this is an easy idea, easy way to calculate. And these 2 methods may yield slightly different results, but Baggett's is definitely more accurate. This is an easy way to calculate. And every 10 millisecond increase in QTC increases 5 to 7% exponential increase in risk of torsades. These are the major long QT syndromes, and LQT1, 2, 3, and these are the channels which are involved. Coming to inheritance prototypes, the dominants are Romanin-Ward, which is commoner, and autosomal recessive is JLN, which is rare but very, very fatal. And these are the channels whose loss of function or gain of function are responsible for long QT. And besides these three major categories, long QT 1, 2, and 3, which are responsible for 70% of long QT syndromes, the major ones also are quite prevalent, and they have basically, once they are combined with some phenotype, there's some precipitating factors they manifest. And these are the T-wave morphology which we can assess and we can come to know. So like LQT1, which has a broad-based T, and LQT2 has a notch T, LQT3 has a long isoelectric ST with a normal looking T. And these are basically the precipitating factors. So LQT1, we all know, is basically adrenergically driven, torsades. So exercise, emotional stress are precipitating factors. LQT2 is mostly emotional stress, and that is important. These patients generally die once they are, arose from the sleep. So early morning, chance of mortality is very high, and LQT3, the patients die in sleep or rest or bradycardia. So these are short, plays here, and bradycardia is the precipitating factor for LQT3. There are many, concealed long QT syndrome where ECG doesn't show changes, but there are genetic abnormalities present, and these are 10 to 40%. And this is the criteria which Suchit also mentions, the Schwartz criteria, where 3.5 score of 3.5 tells us or gives us a diagnosis of long QT syndrome. So these are the points which I'm not going in detail, but how to risk stratify this 50-year gentleman, how to risk stratify how bad is his outcome. So if we go with the genotype, if we diagnose these patients, patient with a TS, Timothy syndrome, JLN, and autosomal recessive LQT1, they are extremely high risk patients. Their prognosis is very bad. Male patients with LQT3, very bad prognosis. And then QT, if it is more than QTC, more than 500, the more is the QTC, chances of having a sudden death is higher. And the patients early onset, like the patient is adolescent, young patient is getting it, their chances of mortality is very high. So just a brief emphasis on JLN and Timothy syndrome. They are the worst kind of long QT syndrome, with a Timothy syndrome presenting as long QT, syndactyly, and 2:1 AV blocks. And you can appreciate this survival curve, sudden dip in the survival in patients with JLN as compared to LQT1, 2, and 3. Now coming to management, once we diagnose these patients, acute management, DC shock should be used as last resort, because these comes in paroxysms. You can witness the patient has a polymorphic VT torsades and suddenly it has gone self-terminated. It can happen many times, you can witness it. So DC shock has to be given what is prolonged, and patient is getting hemodynamically unstable for maybe 30 seconds, 1 minute time. And the same time, if you're avoiding DC shocks for 5-10 seconds, witnessed episode, start IV magnesium. Mexiletine is especially important in LQT3. If it is brady dependent, you can start isoprenaline, or you can put a TPI in these patients. And then we look at the long-term treatment of these patients. So a beta blocker is the cornerstone of therapy, cornerstone of treating these patients, and they work wonderfully in long QT1 as well as LQT2. LQT3 has got suspicious and not a very clear evidence that beta blocker works there. Mexiletine has been used in LQT3 syndrome, but there are some reports where if the LQT3 syndrome patients have a good heart rate and genetically LQT3 beta blocker may give us result, but there are 10 to 15% sudden death even on beta blockers. Cardiac sympathetic denervation is performed in all those patients where the patient is on ICD getting shocks or on beta blockers having recurrent polymorphic torsades. Implantable cardiac defibrillator, this is an overall consensus in guidelines. It has to be immediately implanted. All patients documented with documented cardiac arrest, either on or off therapy. And we have to assess the risk. If the patient falls in high risk category, we have to go it beforehand in primary prevention. And the very important is to choosing which kind of how to program your ICDs. You have to have a fast VT and VF zone. There should not be a VT zone when we are going for a long QT syndrome AICD implantation. And this is how we can make out the prognosis. Even on AICD, this M fact will give us how the patient is going to perform, how the chances of mortality is there. So M fact is M for -1 point for being free of cardiac arrest while on therapy, and then points for 500, more than 500 QTC, age less than 20 years of implant, and then cardiac arrest. So if someone has a higher point, then chances of death is higher. And you can appreciate 4 to 6 points, the cumulative event-free survival is less, but someone has a 0 point or 1 point on AICD in TORSATs, the mortality is not that bad. This is a brief emphasis on some of the advices which we give. LQT1, patients should not participate in competitive sports. Swimming is particularly dangerous. Majority of the mortality happens during swimming. LQT2 syndrome are exquisitely sensitive to serum potassium levels, and we should not be allowed to fall. And again, in LQ2 patients are at higher risk, especially when aroused from sleep, which I mentioned earlier. So there should be advised to have no telephones, no alarm clocks in their bedrooms. This is very important for LQ2 patients. And LQT3, since the prognosis is not good and the beta blockers role is doubtful, we can give Mexaltine, we can put AICD, but the genetic therapy is what we all are awaiting. And finally, antiarrhythmic drugs, the antifungals, the antibiotics, the antidepressants, the antiemetics, we should be having an idea very clear that these patients can be leading to a further worsening of long QT, or someone can have a acquired kind of TORSATs with these drugs. And finally, the precipitating factors, hypokalemia, hypomagnesemia, which you all know, so I'm not going into, I'm not discussing it. Finally, this last slide, this index patient with witnessed TORSATs requires IV magnesium, correction of electrolytes, or removal of offending factors, offending agents. Even though it is 50 years old patient, but a long QT at baseline can give us, should tell us that a genetic study should be performed, and genetic study is available everywhere. In Calcutta, there are multiple centers. I have sent patients for genetic study, and long-term beta blockers and AICD, if there is no reversing factors were there, reversible factors were there, he is going to have an AICD. Thank you so much for the patient hearing.
Thank you very much, Dr. Dilip, for your overview, fantastic overview and the management. Now, Dr. Amit Rai. Dr. Amit Rai, is he not here? Now, the next speaker is Dr. Sumanta Chatterjee. I will be speaking on bundle branch block, how to assess its probability of progression. Dr. Chatterjee, please.
Yeah, thank you, sir. My slides are visible?
Yeah, well visible, okay. Well audible.
Okay, thank you, sir. So today's topic is bundle branch blocks, how to assess its probability of progression. So we know this is a normal anatomy of cardiac conduction system, that fibers of left bundle branch begins the conduction, impulse travels across the interventricular septum from left to right, and then travels across the ventricle, causing depolarization of the both ventricles simultaneously and giving rise to the peaks and troughs in ECG. So these are the phase 1, 2, 3 of depolarization, septal depolarization from left to right, first and alone, and then 2 and 3, depolarization of free wall left and right ventricle occurring simultaneously. These are left bundle branch producing left anterior fascicle, left posterior fascicle. This is septal fascicle, and this is right bundle branch. So bundle branch blocks are the intrinsic impairment of conduction system in the left or right bundle branch, can be chronic or paroxysmal, rate dependent, without cardiac disease or with cardiac disease, mostly due to CAD, hypertension causing ischemic and or degenerative disease. The usual format is QRS duration gets prolonged more than 120 milliseconds, results from slow myocyte to myocyte conduction causing prolonged ventricular depolarization, and terminal QRS is sluggish, reflects the electrical forces in the affected ventricle. And T-wave abnormality or T-wave patterns oriented opposite to the terminal QRS. This is the usual 3 formats of bundle branch, every bundle branch block. This is the RBVB. We know that this is R-dash patterns and secondary T-wave abnormalities. These are various schemes of RBVB. It increases with age can occur as a normal variant in 10% of the population. Most common cause is CAD and hereditary involvement. Other causes include both the structural and functional involvement of the RV, that is RV dilatation and hypertrophy, maybe from corporomonal COPD, dilated cardiomyopathy, CABG ablations. These are the things. Differential diagnosis, that means diseases where RVB can be seen, maybe causative or incidental, myocardial infarction, embolism, COPDs, and pulmonary hypertension, hypertensive heart disease, degenerative disease of the conduction system, Brugada, cardiomyopathy, Chagas, congenital heart disease, specifically Epstein, where we can see the RVB is there. Prognosis depends on the underlying etiology. Worse prognosis for patients with type 2 second-degree AV blocks or multifascicular block. Good prognosis in patients without any underlying heart disease. If there is, asymptomatic patients, isolated RVB, no treatment is at all necessary. If the patient is having symptoms and patient is having RVB, then we have to look for multifascicular block or other higher degrees of AV block, if we are at all thinking of in the line of pacemaker. If the patient is having heart failure, reduced LV function, RVB, and QRS duration is more than 150 milliseconds, then there is a chance that patient may need CRT or will be a CRT responder. RVB and MI, this is a specific chapter. T-wave inversion may be seen in lead V1, V2, and V3 and inferior lead secondary to the additional RSR dust complex type. But STT abnormalities in the same direction as the QRS could be considered as primary abnormality. And since it doesn't alter the initial phase of ventricular depolarization, it doesn't mask abnormal Q waves seen in AMI, unlike that LVVB. So it is easier to pick up AMI in a background of RVVB. RVVB in heart failure, 10% of the population is having this combination. They have worse prognosis than LVVB. They have significant delay in RV conduction system. They have significant LV conduction system delay as well, maybe that is masked LVVB or left axis deviation. And this is LVVB. We know that this is the usual pattern of LVVB. This is T waves inversion in the right precordial leads cannot be explained by LVVB. MI can be difficult to diagnose on ECG in presence of background LVVB. That's why some criteria are there to pick up MI in presence of LVVB. Exercise testing is of limited value in diagnosing CAD in presence of LVVB. There we should use MPI to detect CAD in presence of LVVB. Incidence increases with age, almost always associated with underlying heart disease. Most common cause CAD, hypertension, DCM, aortic stenosis. Rarely results from primary degeneration of the conduction system, unlike that is of RVVB. Depends a worse prognosis in patients having multifascicular block or higher degrees of AV block. More the age, prognosis is worse. Isolated LVVB is more likely than RVVB to progress to higher degrees of AV block and worse mortality. No treatment for asymptomatic isolated LVB is necessary. If the patient is having recurrent syncope, especially associated with prolonged period, their permanent pacemaker we can think of, and if associated with heart failure and some other criteria are met, then CRT is in line. Individuals with type 2 diabetes mellitus and LVV have more severe and extensive CAD and advanced heart failure as compared to isolated diabetes or isolated LVV. LVV following AMI is associated with higher long-term and short-term mortality. Even in absence of associated structural heart disease, LVV is associated with the synchronous left ventricular activation, which reduces the efficiency of LV contraction. It is an independent risk factor for mortality in patients with heart failure and is associated with increased all-cause mortality and sudden death at 1 year if someone is having complete LVV. Exercise-induced LVV is a predictor of higher rate of mortality and cardiac events in 1 year. We know that in presence of LVVB or bundle branch block, there's some criteria by which we can pick up. These are the patients which will respond to CRT. What are those? QRS duration and width. More the QRS duration, more will be a responder. QRS morphology, LVV with notching, some criteria are there. fragmented QRS, RS in V1, delayed intrinsic deflection in lateral leads, PR interval. These are the features. These are the stamps which we should look for in ECG, and serially look for whether these patients will be responders to device. These are the fascicular blocks. We know this anterior fascicular block and some are posterior fascicular block. Usually this posterior fascicular block doesn't arise from ischemia because they have a dual supply from LAD and RCA, unless someone is having triple vessel disease. Bifascicular block, that is combination of RVVB and either LAFB or LPVB. The most commonly we get RVVB plus left anterior fascicular block is the most common of the two patterns. It's a sign of extensive conduction system disease. Bifascicular block is an extensive conduction system disease. The risk of progressing to complete heart block is thought to be relatively low, that is 1% per year. This is a bifascicular block. We know the causes of bifascicular block, usually more than 50% cases, ischemic heart disease, then hypertension, aortic stenosis, anterior AMI, primary degenerative disease of the conduction system, congenital heart disease, and reversible causes like hyperkalemia, which can be reversed whenever your potassium gets corrected. Trifascicular block refers to the presence of conduction system abnormality, all the three fascicles, right bundle branch, left anterior fascicle, and left posterior fascicle. This is an extensive conduction system damage. It is of two types: incomplete, that we usually see in OPDs, and complete trifascicular block produces complete heart block that comes in emergency. So this is incomplete trifascicular block, that is RVVB, one fascicular block, and prolonged PR. We generally know if this thing is asymptomatic, then definitely no indication for doing a permanent pacemaker. But if the patient is producing syncope and have ECG showing incomplete trifascicular block, usually they need to be admitted for a cardiologic workup, as it is possible they are having episodes of complete heart block meanwhile. So Holter monitoring and ELR, these continuous monitoring systems are needed to pick up the patients, which will be requiring permanent pacemaker for this baseline trifascicular block. This is a complete trifascicular block. We know that this is already a complete heart block. So to sum up the thing, if somebody is having bundle branch block, they can be categorized into spectrum. One is having heart failure, one is not having heart failure. If we are dealing with bundle branch block and heart failure, then we have to pick up some stamps or some signatures in ECG, LVV, prolonged PR, and some criteria there where we can pick up these are the patients which will be needing CRT, which will be those will be responders to CRT. And if the patient is not having heart failure, then we have to pick up the ECG abnormalities or the ECG abnormality which will tell that these patients may progress to a more complete AV blocks, will be needing permanent pacemaker right now or in future, like prolonged PR or QRS durations and morphology. Some features are there which will indicate that these patients will be needing device therapy right now or in future. Thank you.
আমি আর কিছু খাবো টাবো না, মুখ হাত দিয়ে শুয়ে পড়বো। আমার এত মাথাটা সারা দুপুরটা রোদে রোদে ঘুরেছি, শোয়া নেই বসা নেই কিছু না। এই রাস্তা আবার উঁচু করে। তুমি যা খাবে।
Dr. Mukherjee, please unmute, sir.
Dr. Rai, Dr. Amit
Mukherjee
Rai.
sir, you have to unmute yourself. Mukherjee sir, you have to unmute yourself, sir.
আইবের মধ্যে সাইকেল চালাচ্ছে।
Dr. Amit Rai, please mute your mobile.
Yes. Actually, the four topics are very well illustrated, right from the Debobodo Bera, who has explained the digital, most inappropriate ICT shocks and his calculations of the SVT and VT, and elucidating of the beta blockers and amiodarone in the drug therapy. Next is Dr. Sukit Majumdar, who has told about the fractured QRS and the RDRF syndrome, RD repulsion syndrome, and also all the vignettes of the 12-bit ECG in quite the possible terms how to start here with sudden cardiac death. And there's so many possible ways in 12-bit ECG only, and also signal the average ECG. Third is Dilip Kumar, who had explained the torsions in the white form in the LQT1, Q2, and LQT3. In the case of LQT2, particularly the sound and sleep arising techniques may provoke the sudden cardiac death. And the QT3 is particularly SCS and a gene is very much prolonged. And that mutation is just taken about. And the fourth is Sumanto, the Dr. Sumanto Chatterjee, about the bundle black life history and well explained right from the RBB and LPAP and LAFP in quite a possible terms. So I think all the delegates cardiologists are very much enriched on the four topics of electrophysiology and just very much just congenial to all these three things. Only one question to say forth about the Shrutis, the telling about the sudden cardiac death history. In this case, Sujit has explained the fractured QRS. In the fractured QRS, only one question is there: whether the RSR does pattern, which we have found in the incomplete RBAP, whether this is the prognostic in case of the STD or not.
So basically, you are telling complete RBB. Yeah, I'm there. I think. Okay. So that's a pertinent question. So these all fragmented QRS, all definitions are in with narrow QRS. There has been some studies where fragmented QRS has been associated with a LBBB or RBBB. There also it has been shown as important indicators of scar. Now the issue is that incomplete RBBB is a pattern actually. Often if you have a fragmented QRS with a low voltage, this can be an indication of early sarcoidosis also. So all these things are important based on the clinical setup where we are looking at maybe echo and maybe cardiac MR, and all these things will correlate that whether that is important. I think so.
Dr. Sujit, before reporting as a case within normal limits, what is your tips to see which lead with some careful, much careful attention?
Yeah, because the ECG reporting at least this concept I don't like at all, because you don't know the patient, you suddenly report a ECG, that is not possible in fact. So I think if you are knowing the history of the patient and maybe you are knowing the context in which you are reporting, then only you should report. That is very important. Reporting cannot be a blind thing. Second point is that you are telling that what things we should look at. Number one is that QT. Often we miss a longer QT interval. And this ECGs also sometimes say it is a long QT. Now, I think you should measure the QT yourself, take some time, and maybe there or maybe put a tangent on the T wave and measure the QT with the longest QT in all the leads. So that is important. Second point is that often we miss ARVC because there is a T inversion in V1, V2, V3. Now the issue that can be present in other persons also, normal person. So how to differentiate? Differentiation can only be done by the history and also by the pretest probability. I think so.
Yeah, so histories must be there before reporting. Okay, thank you. Dr. Bera, are you there?
Sir, I'm there, sir.
Yeah. To characterize the atrial rhythm, as in your case that atrial fibrillation was missed, do you think that dual chamber ICD have got any advantage over single chamber ICD?
So very pertinent question, sir. This is always intuitively we think that dual chamber ICDs are more intelligent and accurate to diagnose a SVT versus VT discrimination, because that's immediately tells you whether A is more or V is more, and you know the diagnosis. But there are many literature and large papers which has looked into this, and almost all of them found that there is not no significant difference between discrimination of dual and single chamber between SVT and VT. So yes, when you are a clinician and you are looking into the electrogram, for us to analyze, it becomes easier to discriminate SVT versus VT when you are actually looking into an episode of whether whatever it has been diagnosed with. But from the ICD perspective, just for this, that dual chamber pacemaker will detect more accurately is a wrong concept. There are many mechanisms behind this. I think that will be a little difficult to discuss in this short period. One of them is because sometimes this A on V tachycardia, even if there is a A on V tachycardia, because of the time intervals, ventricular blanking period, atrial blanking period, even a VT with V more than A will be misclassified as SVT. Those atrial or the ventricular rhythm sometimes get, even the dual chamber ICD will be fooled with. So my take home should be, it should be the clinical background whether you should advise a single or dual chamber. A patient who needs atrial pacing or a patient who needs a sinus bradycardia, you give dual chamber, not for SVT discrimination. They are not good in terms of dual versus single.
Yeah. Large scale study does not support, but only in case of pacing need, you have to give it. Okay, thank you so much. Very nicely elaborated. Shumanta, Dr. Shumanta Chatterjee is there?
Yes, sir.
Yeah. Do you think that LBB with right bundle branch block is more ominous than LBB with left bundle left axis deviation? LBB with right axis deviation versus LBB with left axis deviation?
Yeah, so it is a difficult one, but I think LBV with right axis deviation is more harmful than the
because of more extensive fibrotic changes.
Yeah, more extensive,
more area, yeah,
more area. And if it is at all due to CAD, so it's a more triple vessel disease or severe triple vessel disease kind of thing. If it is due to CAD, or if it is due to degeneration, more degenerative process is ongoing in that case.
Dr. Kumar, may I ask you a question? That's a very simple question, but we are not aware, many of us, that how much of magnesium sulfate should be infused while you are treating a TDP case.
Correct, sir. I think this is a very, very practical, pertinent question. Once there is an acute episode of torsades you are witnessing and you are going for magnesium, you can give the patient 1 to 2 grams of magnesium over 30 seconds to 1 minute. And then you can repeat it and you can see the magnesium level of the patient. Try to keep it more than 2.5. At the same time, we have to be a little careful about the patient's kidney function. So if the patient's GFR is less, we have to be more vigilant and giving all out 2 grams. Sometimes we give BD for 1 or 2 days. So we have to be careful about these doses once the GFR is less.
Okay, thank you so much. Okay, now Miyala, we can conclude it with permission from Dr. Amit Rai.
One simple question, just one last question from to Dr. Dilip Kumar.
Yes,
sir. About that about LQT3, long QT3 syndrome and SCNA gene mutation. Whether he will prefer the beta blocker or some other drugs in the LQT3.
LQT3, the precipitating factor is sleep and rest. So bradycardia is the lethal factor there. So and the mexiletine is the preferred drug there. And beta blockers. So the studies show initially that it can increase the chance of mortality. Later on, some studies show that still can be beneficial if the heart rate is maintained in these patients. So mexiletine is the drug of choice, generally preferred in
maximum. Right. Thank you very much.
We are very astonished. We were very astonished that within such a small span of time, our organizing secretary, scientific chairman, Dr. Lipika, could arrange it with the help of the state committee. So very, very, very rapid and well organized within a very short time.
Fantastic update.
I reciprocate with Dr. Dipankar Mukherjee. Really, we are very grateful that we had such a very, very good quality meeting. And that has been arranged in very, very short time. Really speaking, Dr. Lipika Chaudhary got hardly 1.5 months or 1 month, and Dr. Dipishina got hardly 15 days, and still they managed to have a very good quality meeting. Not only that, they could manage money also, which is a very, very important thing for all the conferences to be had in our by our society. For societal running, you need money also, so they could manage that. And apart from that, the high quality, the quality topics and speakers thing, everything went really very nice, except 1 or 2 or maximum 3 speakers. They could not upload the slides in time. But apart from those hiccups, which are very common with the digital technology and with the internet facility, definitely they are sometime encountered, and we cannot help that. And we had to be tough as the part of the organizing as well as the scientific committees, that to minimize the loss of time, we had to be harsh enough to the chairpersons and moderators to hasten the process. So they should not take it very seriously. These are part and parcel of the conferencing. So that's why we should be pardoned for that. But hats off to Dr. Lipika Odhikari and also Dr. Dipishina and all other team members, especially the West Bengal CSI members like Chandan, then Siddhartha, Sudeep, and everyone did excellent job in this thing. And of course, I also pay my regards to the chairpersons, moderators who spent their time in this meeting. Yes, before Deepida finishes, or any other comment from any other person, Lipika, you just share your experience.
Well, I'd like to thank all the wonderful people who spoke and performed in last 2 days program. All of you taking time out of your busy personal and professional schedules means a world to me. A special thanks goes to our support staffs of the office, audiovisual personnel, and the sponsors. Without their assistance, this conference would not have been possible to arrange. I wish a good luck and goodwill to the organizing committee of the next year, Update Cardiology, for their grand success. Thank you all and good night.
Any other comment from anybody? How can we improve the virtual meeting? I don't think the next meeting will be virtual, because the annual conference of CSI this year is almost expecting 1,000 to 1,000 plus delegates. And I invite all of the faculty members, at least the faculty members, to be present there physically from Bengal. Deepida,
Okay,
your
sir.
comments.
Okay, sir, we can conclude the session. Very exhaustive full-day program. So we can write.
Deepida is not there. Dr. Dipishina is not there. Okay. Then last comment by Lipika again. Conclusion.
Finally, we are at the end of this 2-day long, excellent, thought-provoking and scientific program, Update in Cardiology 2021. I would like to thank all the speakers, moderators, and chairpersons for their excellent job in different sessions, and of course all the support staffs who helped us a lot for this audiovisual conference. Thank you all and good night.
Thank you. Good night to everyone.
Thank you. Good night.
Recording stopped.